Okay, stop. 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 Okay. Okay. Okay.
Hope you all had your lunch. And so today we'll move on to the clinical case discussions. The first is a presentation on a case of osteomalacia. I invite Dr. Krishna from SRNC to come on stage. The faculty for this case discussion would be Dr. Sriram Mahadevan and Dr. Vagesh Iyer. Sir, if you would move on to the stage. I also asked the other students who are participating in this case discussion to occupy your seats. Dr. Niragi Mehta, are you here? Dr. Siddhant? Dr. Amulya? Dr. Anu Wilson? Dr. Roshan? Dr. Komal Sanjay? Dr. Debaditya? And Dr. Pyas Gargari. So I invite Dr. Krishna to come to the stage.
Good afternoon. I would like to present a case. My patient is a 40-year-old female, Mrs. A, who studied till class 6, residing in Karur, who is a homemaker, presented with chief complaints of bony deformities noticed at the age of 4 years, generalized body pains for the last 10 to 12 years, and difficulty in walking for the last 10 to 12 years. She was born out of a she is a second born child out of a second degree consanguineous marriage with a normal antenatal course, normal vaginal delivery. Birth weight is not known to her, with no neonatal hypoglycemia, seizures, or jaundice, with normal milestones until the age of 4 years. Her parents noticed at the age of 4 years that there was inward bending of her left knee. Because of these bend, she could not play with other kids, and there were recurrent falls noticed in that age. However, she never sustained she never sustained a fracture at that point in time. At the age of around 6 to 7 years, the patient also noted that there was an outward bowing of the right lower leg, which further hindered her daily routine activities. On inquiring about the dentition in the childhood, she doesn't remember the exact chronology of appearance and falling of the teeth, but she does report that there were multiple dental infections in the decidual teeth as well. From the age of 8 years till the age of 28 years, there has been a gradually progressive inward bowing of the left leg and the inward bending of the left leg and outward bowing of the right leg, which has been progressively worsening. To such an extent that by the age of around 27 to 28 years, she is requiring the help of a stick or a bystander to walk and do her daily routine activities. She never sought medical help till the age of 28 years, as she was told that she has poliomyelitis, which is an irreversible condition. At 28 years of age, she sustained a low trauma fracture while she slipped and fell in her house, for which a surgery was required, which according to her was a nail was inserted into the right femur. For 1 to 1.5 years, this fracture did not heal, even on giving calcium and vitamin D supplementation as told by the patient. It was the second surgery which was required around 1.5 years, after 1.5 years of the first surgery, at around 29 to 30 years of age, during which she consulted an endocrinologist for the first time. And after the treatment started by an endocrinologist, the fracture healed after the second surgery. At 30, she also named the doctor, sir.
I am surprised a patient the word endocrinology. Okay,
at 30 years of age, she also noticed the swelling of the left lower jaw, which was told to be a tooth infection, which required extraction of the left third molar. A similar swelling was also noticed in the right upper jaw, which again required an extraction of the tooth of the second upper molar of the right upper jaw. Since the 32 years of age, she has been in follow-up with CMC and is doing fairly well. Bony pain she described was also insidious in onset, gradually progressing over the last 10 to 12 years, predominantly involving the bilateral lower back, hip joint, and bilateral lower legs, which are also present at rest, which aggravates on movement, with significant improvement in the treatment which has been prescribed by our doctors. Difficulty in walking, which was also insidious in onset, gradually progressing, initially noticed as difficulty in getting up from the squatting position, followed by climbing the stairs, followed by difficulty in walking without support. She attributes this difficulty in walking to her bilateral lower limb deformities, but she also agrees to the fact that when she is compliant with the therapy, these pains and difficulty in walking is less as compared to when she is not on regular treatment. On further inquiry, she also agrees to have noticed the stiffness of her neck as well as the back, and she is not able to flex her head and bend down and take up and bend down. Yeah. So shall I continue? So she is a female who has developed bilateral lower limb deformity since the age of 4 years, initially untreated till around 28 to 30 years of age. And most probably, I haven't examined the patient yet, but has developed a windswept bilateral lower limb deformities. And her treatment was started at around 28 to 30 years of age. She also had a low trauma fracture, along with infections of the teeth in the decidual teeth, as well as in the permanent teeth at around 34 to 35 years of age. And over the last 4 to 5 years, she has also noticed to have.
No, these are all you have already described.
Yes, sir.
What Sarah is asking is what is your
Opinion based at 4 years or now also?
So my clinical impression would be the first differential that I would like to keep would be a rickets osteomalacia, rickets and osteomalacia. When I go through the history, and she never had seizures, she never had tetany, her bone pains and everything has been recent in onset. So these factors point towards more of phosphopenic rickets rather than calcipenic rickets. And as we'll see in the case, there is some family.
In which other part of the ricketic features will get a seizures? One is calcipenic is fine. Others, where else you get seizures?
When
It looks like a rickets only, but
yes,
not rickets.
When there is
Even others get. Yes, gargari. It's like you're anything much more specific. Presentation itself is one of the history is seizures, mental retardation, and ricketic. your differential diagnosis is for rickets, especially in childhood. Hmm? No. Others? Yeah. Hypophosphatasia. Even a hypophosphatasia, one of the presentation is seizures.
Shall I go?
Yeah.
There was no history of renal stone disease, recurrent abdominal pain, irritable mood, or dyspepsia. There is no history of recurrent small joint pains, dryness of eyes or mouth, rash, polyuria, or native medication intake. No history of jaundice, oliguria, pedal edema or facial puffiness, steatorrhea or chronic diarrhea. No history of steroid abuse or long-term intake of any antiviral or anti-epileptic drugs. No history of seizures, tetany, or alopecia noted up till now, and no history of any recurrent respiratory tract infections, recurrent headache, visual abnormalities, and hearing abnormalities.
What about the history of alopecia? Why?
Sir, alopecia, it's in calcipenic rickets, specifically the autosomal, it's important, sir. 1-alpha hydroxylase.
Yes. Yes.
Usually VDDR type 2 may have the alopecia along with it.
What is the other clinical significance of alopecia if the VDDR2 is there?
Usually it is more treatment resistant.
Yeah, it's very difficult to treat among them.
There was no, she is not a known case of hypertension, diabetes, chronic liver disease, or chronic kidney disease. Personal history, she was born out of second degree consanguineous marriage. She attained menarche at the age of 12 years. She has been having regular cycles of 28 days up till now. She has got one child who is a male progeny, currently 17 years of age. He was born out of, he required an LSCS because of non-progression of labor, though there was no antenatal or postnatal complications. It was at 4 years of age when the parents noticed outward bowing of bilateral lower limbs in his child. Along with that, there was delayed dentition as reported by them, and there were recurrent dental infections which required extraction of 7 teeth at the age of 6 years. He has also been on treatment, same treatment which the mother is taking since the age of 4 years. However, she still feels that he is the shortest in the family and is not at par with other boys in the family. No other family man.
What's the specialty of abscess formation? You told no swelling and abscess formation. Mother had it 32 years. Compared to many people do have a abscess.
Yes, sir.
How it is different from your whatever you're suggesting phosphopenic rickets compared to the common garden?
Sir, in phosphopenic rickets, in X-linked hypophosphatemic rickets, there is involvement of the dentin layer of the teeth.
No, but pulp, everywhere abscess only they come. Then we make out the other things. But what is the specificity of how specifically they come? What is the characteristic history of a pulp abscess in this hypophosphopenic compared to common garden? So many people you see abscess, all of them won't turn out to be phosphopenic. Anyone? It is a pulp abscess without dental caries. That's a characteristic feature. Most of the time, people have a dental caries, then they develop pulp abscess. Here it comes without dental caries.
No other family member is affected with the same problem. She takes mixed diet. Her calcium intake per day is around 500 to 600 milligram per day. There is inadequate sun exposure because she is predominantly confined to her house because of her deformities. She has been taking treatment from the hospital. She has been prescribed a sachet, which she has been told to dilute in 100 ml of water to be divided and to be taken twice a day. Along with that, she has been taking a small capsule as well as a white tablet, which she has been told to take once daily. However, she is not very compliant with the therapy. Though she is not compliant with the therapy. However, she has not noticed any side effects with this treatment.
Is there anybody else can answer? Is there anything odd in this history of both the patients presenting only at 4 years? What other history should have been probed, or how is it that till 4 years nothing is happening? First year, do you expect something? Or is the history superficial, some more history should have been taken. Now that mother is affected from a very young age, mother is giving the history of the son. So son is till 4, the mother knows everything about her problem. I'm sure she would have noticed the son having some problem earlier. Did you ask any questions in the first couple of years? What should you have asked? Maybe that was overlooked in this case, probably. Because what history will you ask? Wrist pain, okay, maybe. While crawling, how will a crawling child complain of pain? Most of us are not pediatricians. That's why we are
Swelling.
There might be delayed developmental milestones like motor milestones.
This history should have been specifically mentioned, and most likely this patient will have. It's not that they identify with the deformity. Very likely that sitting up, crawling, standing, everything would have got delayed, specifically motor. And there also you can, if you are a good pediatric oriented history, easily can differentiate gross motor from fine motor. All fine motor thing would have been normal in this child because upper limb is not involved against walking, whatever, which actually the mother gave this history. That's why I'm asking. She clearly told this. She herself told that I'm taking in Tamil. She told everything clearly, this history. That will tell you that things are from, maybe her parents missed out on the first few years, but this son wouldn't have been missed. Anyway, this guy was born after her diagnosis, or?
Yes, sir.
All the more then she will know, no? Okay. Carry on.
I'll summarize it.
Oh, history over. Anybody else wants anything in the history?
Any clarification?
Anything you want more? Things looks reasonably clear, but for completion, what other differentials, certain rarer things? I am saying that they both are having a problem due to the environment. They are from the same place. So, which diagnosis will you consider?
Fluorosis.
Fluorosis with a deformity in the leg at the age of 4. Fluorosis, can you describe how it will present?
Fluorosis is a known ricket mimicker. It can present with the different bony deformities. So there can be osteosclerosis also. Then interosseous membrane calcification can also be seen.
Patients won't come with these things. Fluorosis classically
Dental
will it present at
problems.
4 years of age? If it presents, then how will it present?
Will present with yellowing of teeth, dental problem, dental caries.
Oh, Colgate advertises that you give fluoride for dental preventing caries. You are saying it will cause caries. What is this, man? I am confused now. Fluoride will protect caries or will cause caries?
Excess fluoride will cause problem.
I don't think it will cause caries or pulp abscess. What is classic of fluorosis of dental fluorosis? What age fluorosis will present? I'm sure you would have seen fluorosis case in your ward. At least in the differential, you would have considered in a given patient. Will they come at 4 years? That's what I'm asking. How many pediatricians will vouch for seeing a fluorosis patient? Very rare. Even pediatric orthopedics, they won't see. Dentist, yes. You can pick up from the, incidentally, Vellore and the adjacent Tirupattur, this area is supposed to be a fluorotic belt. Anyway, I'm just for completion or academic sake, we are discussing. Any other DD? If suppose many people in her village or any other differential can
Renal
be kept.
tubular acidosis.
Age, you are happy with the presentation? Anything else should have occurred by now?
The other systemic manifestations would have occurred, like eye or ear manifestations would have occurred.
24, almost 28 years of no treatment, no, for her. That's what is odd there. So that if you bring into the picture, then some of these diagnoses will be less tenable, no? RTA going on. What is the underlying cause of that RTA, which is 28 years untreated? What else would have happened by then?
Nephrocalcinosis. nephrocalcinosis would have occurred, but then nephrolithiasis, etc. problems will have occurred.
Anything else which can occur in families in a given place? Common environmental, anything you can think of, especially bony disease. Leave pediatrics, suppose any other diagnosis. Fluorosis is very important in India, I fully agree. You should consider that. More than one family member always does not mean it's genetic. That's the idea of discussing.
Juvenile Paget disease.
Oh. Wonderful. Okay, can you tell a few lines on that? I'm sure
that is also one of the ricket
more common,
mimickers and
more than juvenile Pagets, which is more common in the adolescent age. Bony deformity in both the mother and father.
FOP, fibrosis ossificans progressiva.
Ayyo. This is only
Fibrous dysplasia.
no. I see. As endocrine people sitting in this room, many of us will be aware of many rare diagnoses. I know, but as clinicians, you should give us some order. Which is more common. Like fluorosis, if you say, I cannot disagree. You have to, but justify in this patient is different. But I am talking now academically. One more diagnosis in the same family, more than one person affected. Both can happen at pediatric age. May present late.
Metaphyseal dysphagia.
That's more common, much more common than that. Metaphyseal, something starting with F, fibrous dysplasia.
McCune-Albright syndrome.
Not as a McCune-Albright syndrome, but fibrous dysplasia affecting the bone is much more common than juvenile Paget's disease. I remember one senior bone expert, either in CMC or in other lecture, we had diagnosed this juvenile Paget's like overzealous. Then he said, extremely uncommon. How many reports you would have? You would have read case report somewhere. Maybe somebody in big institutes would have published one or two. Where is the problem in juvenile Paget's? Who mentioned that? This is leg pulling now. Sorry. Okay. Anyway, if you know that, you should know about osteoprotogerin and its effect. They have given even osteoprotogerin as treatment for juvenile Paget's. Anyway, juvenile Paget's, please remember, if you see any young patient with a bony deformity, rickets, this hypophosphatemia, calcipening, all those things are more common. RTA, very, very important. Then fluorosis, then FD is much more common than the other few things which you will mention. Anything else? Why did they diagnose polio? How can it be considered? I don't know. Polio. They didn't meet orthopedicians.
No, sir. 28 years
But they
was
met
the first
endocrinologists.
contact with
That's Okay, so in summary,
a 40-year-old female.
any other history, anything else he should have asked? Everything is clear. Only one diagnosis possible. Our idea as clinicians is to broaden the scope of considerations. I agree. You all know by now what is the diagnosis. Can the third or fourth person tell what is the diagnosis? Tell the diagnosis now, most likely diagnosis, clinical diagnosis with the history.
Rickets or osteomalacia.
That is even general pediatricians will tell me.
Hypophosphatemic.
Okay, much more.
X-linked.
Son is affected, mother is affected.
X-linked.
Next word, X-linked.
Autosomal dominant.
अरे राम X-linked.
No.
अरे क्या बोल रहे?
Dominant.
X-linked dominant, hypophosphatemic, rickets or osteomalacia?
Rickets.
What is the difference between rickets and osteomalacia?
Sir,
You take the mic for the benefit of. Sorry. So what does this mother have? He started with rickets and proceeded to osteomalacia. Right? What will be her bone age? Just for she has had, according to the history and presentation, hypophosphatemia for so long. Her bones would have got fused.
sir, this is rickets because the rickets is a disorder of the growth plate. and which incorporates the bone mineralization as well. And osteomalacia is the disorder in bone mineralization. But as the history suggests, the mother had deformity started since the age of 4 years. And also that there is deformity that indicate that growth plate was involved. So that's why it is a diagnosis of rickets.
Semantically, you are right. I agree. But what I'm asking is a theoretical possibility as to will her bones would have fused by now or not?
I think so, sir. Yes.
Why should the lower limb get affected? How does the phosphorus know that I should affect the lower limb? Why the upper limb there is no problem? Anybody in the
Actually,
hey, others can add on, especially students.
problems
DM
are there in
candidates.
both the limbs. The thing is that it presents a bit late. By that time, the child starts walking on two legs rather than crawling and all.
Why it presents late?
Which is more common in presentation, bowing or wrist deformity. But at least when the child comes with bowing or any lower limb deformity, by the time when you examine, you will have rickets features in the upper limb also. No? In this patient, there was no such history or no examination finding like this.
Why it's only lower limb? Why can't we upper limb?
Both
Usually it depends on the time of presentation, when the disease is presenting and
Why
how
it
the
presents
child
late?
is.
Why this phosphopenic presents late?
That is also included in the
Ah.
first question. Why? What is the history in the first 2 years, 3 years?
What
Exactly
happens
sure,
to
but
renal phosphorus handling in the first year? Initially, what happens?
Usually the phosphate levels in infancy are high, and usually phosphaturic effect is low
Why?
of the kidneys. I think due to some PTH resistance, I mean, not PTH not fully acting on the receptors in the infancy.
So renal phosphate handling is not fully developed till the age of 1 year. So only when child starts walking, so that after that phosphorus levels in the children is high, and as they grow, it falls down. Then the manifestation starts. And why she has not seek the medical help for such a long time? Among the two rickets, which rickets will seek the medical help early?
Calcipenic rickets.
Hmm?
Calcipenic rickets
Yeah.
will be
Why?
more painful.
Second person.
Body pains will be more.
Yeah, they are more symptomatic. This is of a less
Pediatric
symptom.
age bony pain. Bony pain in pediatrics, how will you diagnose?
The parent lifts the child.
Ah. Yeah, okay, then anything else? Yeah, much more severe calcium deficiency symptoms will happen. Even seizures will happen.
Right? They have a more of a motor symptoms. Why? See, in both cases, phosphorus is low. Even in calcipenic, phosphorus is low. Even in phosphopenic, phosphorus is low. But there they have more of a muscle weakness. They become more symptomatic. Here they become less, not much compared to that. They seek medical help earlier.
Because of the effect of the increased parathyroid level in the former. That lead to bone resorption and that will lead to bone
Yeah,
pain.
it's a bony deformity, but I'm telling of a muscle. You develop a muscle weakness in a calcipenic compared to a phosphopenic. Why? Huh? Okay, what is that to do with? So even a
So
muscle has got a
muscle
vitamin
atrophy
D
will-
receptors.
Yes.
So that's the reason they
Vitamin D
become more of a.
deficiency.
Was the pregnancy uneventful?
She delivered at 9 months, but she required a lower LSCS, sir.
If you had known the diagnosis, how will you manage pregnancy in this case? In that lady, what will you be your concerns, extra concerns? You know the diagnosis. He's saying that he's already on that supplements. The third person from here. Oh, number Komal. Okay. I know her. Fourth person. I'm sorry, your name. I'm sorry that I don't. I should ideally call by name. Yeah. Unga pair, your name? Ma?
Niragi.
Huh?
Niragi.
Nirag. Please. Nirali. Yeah. Anybody? Either of these 6 people, phosphorus and pregnancy. Hey, Bellu.
Half an hour over. Start. Yeah. Can you just one of you?
Hey, that's very vital, no, in this case. Luckily, she didn't have her second pregnancy.
Let's cut down the second phase of labor.
Usually, when pregnancy-related questions are asked in metabolic field, how will you approach the question? First trimester, second trimester, kidney, dilution, fetal, demand, labor, drugs used. Like that, you tell something, no? You try to approach after. There is nothing. See, even I am thinking along with you. Luckily, myself and Vagish, we have managed. Remember when hypophosphatemia in pregnancy?
Sir,
Supplements will increase, decrease, something like that. You
phosphate
discuss.
supplements will need to be increased because there will be increased requirement in the mother. We need to increase.
Okay. What about vitamin D? What vitamin D will you give in this case?
Calcitriol.
Hey, but always he's holding the mic. I want others to speak. Yes, no?
Calcitriol.
Okay. So in pregnancy, what will happen? Any physiological adaptation will happen?
There will be
Maybe anybody? What happens to 1-alpha activity from placenta? From breast? 1-alpha activity is highest placenta. So your requirements of active vitamin D will come down during pregnancy. And due to that, good generation of 1-alpha will happen from whatever vitamin D she is eating otherwise. So her requirements for phosphorus will relatively come down because she will absorb well. Osteoporosis in pregnancy or something somebody discussed? Was there any discussion on that? You all know that a lady will develop, the maximum stress for calcium and phosphorus during pregnancy and postpartum, no, breastfeeding, etc. A lot of calcium demand. All this you would have read. You tell me how many. Maybe you are aware of it, but I am stressing that point. A lady, otherwise healthy lady, conceiving, postpartum breastfeeding. What will happen to her bone density? Pre-pregnancy to 1.5 years later.
decrease.
It will never happen. A lady's bone density, in fact, will be constant. How many of us have? My grandparents had 8 children, 9 children. But so what I'm saying is osteoporosis is so much of protective adaptive mechanisms happen during pregnancy. And one of the main mechanisms is this, the placental 1-alpha generation. So whatever normal vitamin D and sun exposure and whatever little you get in diet, etc., will be very robustly converted to 125. So your absorption will be so good. This you can see even in your hypopara patients where you are replacing, and if they conceive, the same thing will happen. So theoretically, so the actually nature will help you in this pain. That's why, in spite of not getting diagnosed properly, pregnancy, I'm sure she would have got delivered in not a tertiary care hospital, definitely with the diagnosis.
LSCS and
LSCS. What will happen, ma? Labor? Do you expect anything with phosphorus? It's well known that calcipenia, vitamin D deficiency, phosphopenia and all will, after all muscle contraction you require, so they will get delayed. So that's why labor wouldn't have started. In fact, he presented that. That's why they undergo cesarean. These are all to be expected.
Only the point to add is lactation is more deterrent to bone than the pregnancy.
You all know, quote unquote, father of metabolic bone disease in India? Quote unquote. It's unofficial, but just use. SPS Teotia. You all know Boyd's famous pathology statement for rheumatic heart disease, no? It licks the joint and bites the heart. You have heard of this, no? Similarly, Dr. Teotia mentioned a very nice thing. He has done the maximum work on fluorosis and vitamin D survey, ICMR survey all over India. Osteomalacia is a big expert. You should know his name. In India, in an Indian forum, I have great pride in mentioning his name again and again. He mentioned to us when we were like you sitting there that pregnancy licks the bones and lactation kicks the bones. This is what he is mentioned. That is because this is in contrast to what I mentioned 2 minutes back. I said that nothing will happen to the bone, and now I'm saying it licks the bone, kicks the bone. That's because of the vitamin D deficiency is very rampant. If you are adequately supplemented, these things don't happen. A pregnant lady will compensate fully for this. So I think that fits into your thing. Examination.
When she was brought to the examination room, she required the support of the attender and she came with a stick. Temperature was 37.5 degrees centigrade in the right axilla. Pulse was 88 per minute in the right radial artery with normal pulse volume and character. Respiratory rate was 20.
Volume and other things. Fine, it's right.
You should not.
Respiratory rate was 18 per minute, thoracoabdominal. Blood pressure in the right upper limb was 124 by 80 millimeter of mercury in the right brachial artery in the sitting position. Anthropometric examination.
What's the specialty of hypocalcemic hypotension? You're mentioning blood pressure, no? That's right. Even hypocalcemia can produce a hypertension, no?
Hypocalcemia can produce hypotension is what Sir is asking.
What's the specialty about that? Hypocalcemic cardiomyopathy you have heard, hypocalcemic hypertension is there. What is the specialty of that? Unless you give calcium, it doesn't pick up, like your cortisol. Like Addison's hypertension, unless you give a steroids, it won't pick up. In hypocalcemic hypertension, unless you give a calcium, whatever inotropes you push, it doesn't pick up. Same thing, calcium you give, then it picks up.
Her height, because of the bowing deformity, I had to measure the segmental height. Her sitting height was 74 centimeter. Distance from the anterior superior iliac spine to the medial malleolus, medial condyle was 38 centimeter, and from medial condyle to the medial malleolus was 34 centimeter, which turned out to be 162 centimeters.
Means her lower is shorter.
Yes.
Trunk is normal.
Yes. Her weight was 48.
What does this suggest? Asymmetric.
Disproportionate.
Disproportionate or asymmetric short stature is suggestive of?
Again, it favors.
Yes, anybody, just it's like no lower segment shortness in the short stature when you see in the adults. This is one of the sign of a rickets, childhood, especially hypophosphatemic rickets. Which are the other signs? They would have treated during a childhood. You may see perfectly normal when they come to you. What are the other signs of a childhood rickets? What you see?
In infancy, sir, craniotabs.
No, that won't be there. When you see the adult, they have come to adults, they have not been treated, diagnosed, treated during the thing. You are seeing them in adult. What are the signs you will see? Which will tell that, okay, they had a rickets during the childhood.
Broadened wrist.
Those are all treated.
They're treated, no?
Okay.
Which will remain?
The lower limb deformities.
Okay.
Only
bony deformities.
Bony deformities.
Like?
Genu varum.
Okay, that's fine. If there other things. Your rickety rosary, Harrison sulcus, all those things, bony deformities will persist.
On general examination, there was no signs of pallor, icterus, clubbing, lymphadenopathy, or edema. There was no hemangiomas, neurofibromas, nevi, cafeolus spots, or any soft tissue swelling appreciated throughout the body. From head to toe examination, there was frontal bossing. However, there was no dysmorphic faces, no cataract on visual examination. Oral cavity examination, the left third molar and the right upper second molar were absent, consistent with the history of extraction. She also had a right lateral incisor implant in the right upper jaw. However, there was no active infection or discharge from these cavities. There was no goiter, acanthosis, or any other neck swelling. A surgical scar was appreciated on the right lateral aspect of the thigh. There was a right genu varum and the left genu valgum deformity, suggestive of windswept deformity. She though never complained, but on examination, there was a left foot talipus deformity, which was also appreciated. A generalized bony tenderness, especially in the lower limbs, was appreciated while examination. No kyphoscoliosis, no Trozius signs, and Schwarz's signs were negative.
Your diagnosis. Anything anybody wants to add? You have seen? Anybody has seen along with him?
Neurological?
Systemic is pending. This was just head to toe.
Only general physical exam.
Oh, I think Mudichal.
Okay.
Any findings?
No, sir.
You want to mention anything?
Anything specific you want to look?
Sir, there was a left lower foot
Talipus, you said. then.
Talipus deformity. Power was 4/5 in all the muscles, the flexor, as
Upper
well,
limb also.
upper limb as well as lower limb, both.
Then.
Reflexes were normal, and the gait. That's it.
Gait though she requires support. There
Yes,
is
sir.
no question of gait here. For the reflexes.
2+, sir. I checked normals.
Anything else you want to see in CNS?
Yes, sir.
Especially this long-standing.
Yes, sir. I would like to examine the second cranial now to look for the visual field as well as the papilloedema. I would also like to check the 8th cranial now to look for the Rennie's and Weber's test was also done, which was non-remarkable as well. These were the positive.
I didn't hear what.
No, you did a second nerve for a papilloedema, raised ICT features, and the auditory nerve. 8th nerve. That's it.
Anything else? Anybody who can add to or correct what you said?
Anything specific neurological? Still more.
Open up.
Still more.
Be free. This silence.
Anything typical of a sensory distribution, things you read can happen in similar cases. Goes by very famous names. They can have a picture like Arnold cherry malformation because of the foramina magnum stenosis. This is the one which causes even raised ICT, all the other things. Long-standing hypophosphatemic rickets.
I go to the final diagnosis. Final diagnosis is rickets osteomalacia. Most probably, I would like to still hypophosphatemic rickets most likely X-linked dominant variety, but others I would also like to consider with my biochemical evaluations.
What you would like to consider?
What other things? See, mother is there, son is there.
Both are having almost same problem, same
yes.
treatment.
Same age.
Sir, there was a 3-generation history of consanguinity, sir. Even her, the mother married to her mama, her grandmother also married to her mama. So though X-linked dominant is the most common cause of hypophosphatemic, I would also like to consider autosomal dominant and autosomal recessive as well because of the consanguinity history.
Is right. So how will you differentiate clinically between these three?
Autosomal recessive is more severe and present in the childhood mostly.
Okay. So she going till second decade without missed problems.
Yes.
Slightly against that. Okay, then tell theoretically the differences between the three. Clinically, any other differences? If you know, others know, please add. Otherwise, time, it's not like exam for only one. Yes.
Presence of enthesopathy. He has mentioned presence of enthesopathy. He has told that the patient had back pain, flexion deformity. He has mentioned that. So that more indicates towards X-linked dominant rickets.
Okay. Only by genetic thing we have to prove this, or any other clinical subtle thing? Only one. More severe autosomal recessive, I agree. What is the mechanism difference between the three? X-linked and autosomal. What is the cause of hypophosphatemia in this?
X-linked is due to FEX gene.
Mike near.
FEX gene mutations. FEX gene mutation.
So what happens?
The FGF20 metabolism.
बाकी लोगों को भी chance.
Metabolism will be decreased, sir.
Metabolism of
FGF20.
okay. Komal, you want to say?
Endopeptide. It is an endopeptidase. So the life of FGF23 will be prolonged, because of which the action.
That is FEX gene. Which one? The other one? Autosomal dominant?
Autosomal dominant FGF23 gene itself will be and recessive DMP1 ENPP.
So Mechanism of phosphatemia.
Renal loss.
Ultimately, everything is intertwined towards
The
FGF23.
channelopathy, sir, it will be lost through this thing because of inadequate reabsorption through the kidneys.
Fairly correct. Already on treatment. So how will you monitor? Let us discuss that first.
She is on conventional therapy, that is most likely from the history oral phosphorus with calcitriol and calcium tablets. So I would like to monitor her with alkaline phosphatase, urinary calcium creatinine ratio, and serum PTH.
All three important. What is the importance of all these three?
Sir, alkaline phosphatase will give us an idea of the adequacy of the treatment. If alkaline phosphatase is high, I would like to increase, up titrate the dose of phosphorus. If it, for urinary calcium creatinine ratio, if it is high, I would like to decrease the dose of calcitriol. And if PTH is high, again, I would like to increase the dose of calcitriol.
If PTH is low.
PTH is low and calcium creatinine ratio.
No, I'm just telling you're encountering PTH is low. What will you do? You told high it is there, it's fine. If it is low, what will you do?
I would like to see the calcium creatinine ratio also, sir.
No, only PTH is low is there. What is your conclusions out of it? See, patient is coming. You ask for all the parameters. Other two parameters are fine. Anyway, you will never aim at normalizing phosphorus. So PTH is suppressed. So what is your actions on that patient?
I would like to decrease the dose of calcitriol.
Okay, what it suggests is correct. What
Over treatment with
the patient is receiving more of a vitamin D compared to the phosphorus. So that's suggested by the PTH, which is suppressed. Why don't you normalize the phosphorus?
Sir, in case of trying to normalize the phosphorus, there is a chances of secondary hyperparathyroidism.
No. Yes, others.
There will be deposition of calcium because of
Nephrocalcinosis.
nephrocalcinosis.
No. Why you want to normalize? What is the action of how long it acts phosphorus? How many times you give?
3 times divided doses.
Initially, you give more times. Subsequently, stabilization is 3 times. So fasting to become normal, you'll be over treating. So always when you aim at a normalizing phosphorus, you'll end up over treating the phosphorus, which is deleterious. Fine. But tell me a clinical situation where you'll aim at normalizing the phosphorus in a phosphopenic rickets. Everything you get in clinical medicine or spectrum you get. Imagine you'll get it. Anyone? This is the one treatment where you'll aim at normalizing phosphorus, not at just giving a benefit.
When borozumab is given.
This one. Borozumab treatment is where you will aim at normalizing the phosphorus. All other treatment you don't aim at normalizing the phosphorus. How do you assess the over treatment of a phosphorus when you are giving patient? What complaints they'll have?
Sir, it will cause dyspepsia, GI complaints.
Okay. More than that? Wire ennaaradu? Tamil, no, your SRMC.
Yes.
Yes, others? More phosphorus you take, what happens? That's the first complaint they tell, then your lab values comes.
Diarrhea.
Yeah, cramping, diarrhea. That is one of the indicators of we are over treating the patient. So you told patient is taking solution and also some white tablet. So what white tablet patient is taking? You don't know, no, you don't ask for it. Yeah. Be as practical as possible. You need not be like you are doing some discovery channel, something you are finding out which is hidden.
She would be most probably on calcium carbonate, sir.
Okay. What is the disadvantage of giving a calcium carbonate along with your phosphorus supplement togetherness? Yeah. Most of the time your phosphate absorption comes down, it gets deposited. Sometimes if it is possible, try to time it. Fine.
Why do you want to give both? You know it is hypophosphatemic rickets. Why give calcium?
Yes. Unless
my question is correct.
Correct. Why this is the one rickets which doesn't require a calcium.
Technically, I don't think you require calcium in this case. And anyway, you want to give. Please give.
Yeah.
Initially you give, later you need not give. Maybe that is
In a stabilization phase,
Yeah, at least in the beginning
initial,
phase.
yeah,
Ah.
I can. Fine.
what Vijay Sarthi sir saying is absolutely agreed, because even in vitamin D deficiency rickets also you need to give calcium initially, especially in rickets.
So this
One
is-
can argue that I am taking from diet, but it will not be enough because it will be like hungry bone.
So this is the one situation where you need not give a calcium if their diet is adequate, which is a situation where you don't give active vitamin D.
Hypophosphatemic rickets with hypercalciuria.
HHRH, you need not give a active vitamin D. Only this phosphorus solution is good enough.
What will be the normal? I mean, no, I'm not asking normal. What is the PTH level usually in these kind of rickets? Normal.
Usually on the high normal side.
What is a better endocrine way of saying it? Normally, when the phosphorus is low, what happens to PTH? I mean, my phosphorus suppose goes very low. It will come down.
So inappropriately high.
It is inappropriately high or inappropriately low. It's not, you expect it to be high or low when the phosphorus is low. Phosphorus is high, PTH will go high. What happens in CKD? Phosphorus is low, PTH is normally also low only. Low means low normal. Then why are you discussing that it is low and further low? That's because of calcitriol suppression.
Well, monitoring.
Practically, do we do that? PTH assay repeatedly in a hypophosphatic patient?
Annually, at least you should do it.
What else will you do annually? What else will you monitor?
I would like to also monitor for nephrocalcinosis, renal ultrasound once a year. And based on the symptomatology, I would like to look for any other complications of X-linked hypophosphatemic
If there
rickets.
is an hypercalciuria, what will you do? You are looking nephrocalcinosis, only thing, without your knowledge, patient must be losing more calcium.
Urinary.
So what will you do?
First, I would like to optimize the dose of calcitriol phosphorus. But even after doing that, there are
That calcium is not, okay, it's normal only, but more of a calciuria is there. What will you do?
Cinacalcet can be added to.
Why suddenly want to do?
Thiazide diet.
So in which situation you get a hypercalciuria? Which are the clinical situation where you get more of a calcium excretion in the urine? Tell no, all rickets patient you give this advice.
In patients who are on
Yeah, calcitriol you stop, done, that's accepted.
also
Then,
RTA type.
no, this is the thing. It's typically we are treating proven by Dr. Thomas Paul. It's an hypophosphatic. Nobody will question it. Fine. Yeah. What will happen if excess sodium is taken in the diet? It will produce a thing. Which are the other things, dietary factor, which will add to the hypercalciuria? High protein, high sodium, and one more, complete.
Auxiliary.
Increased acid load, not this one. Diet contains more of an acidic food, there is a hypercalciuria comes. Fine. So that, for example, everything is optimized, still patient is requiring lot of your phosphate solution to be given. Hypercalciuria is there. What is the other mechanisms we'll do? What changes you'll do in the solution? What's the content in the phosphate mixture you get?
Sodium acid.
Yeah, so you'll shift to, from sodium, you shift to the potassium based phosphorus solution. How much do you want to start?
30 to 60 milli
Yes.
phosphorus.
10 minutes. Yeah. Yeah.
For conventional therapy, 30 to 60 milligram per kg per day of phosphorus I would like to start, along with calcitriol of 30 to 60 nanogram per kg per day.
How your initial therapy changes from the maintenance therapy?
Initially, it would be on the higher. I would like to start on the higher doses, around 60 milligram per kg per day and 60 nanogram per.
No, more divided doses you give rather
Yes.
than more giving.
5 to
because
6
it's a very short acting.
Yes.
Fine, you to give 5 to 6 times rather than subsequently you can reduce it to frequency
times.
2 to 3 times. Fine.
Basically, how much they can tolerate rather than you give higher doses, definitely GA problem will come.
That's why small and more frequent doses you need to give. How much of active vitamin D you want to give?
Again, 30 to 60 nanogram per kg per day.
I think it's more. 30 to 60 is more. It's still less. 20 to 40 nanogram per kg body weight. The one which is preferred. What is the role of active this one regular vitamin D?
Regular vitamin D, if deficiency is there, I would like to supplement it,
You
keep it in the
optimize.
sufficient state, but not for the therapy.
What about the bony deformities? Would you like to do something?
Metabolic derangement has to be corrected first, and with that, maybe the bony deformities will get cleared automatically. After the bone growth is
28 years, pa?
after
I don't think it
I'm
will.
treating from before puberty. For that case, I'm saying.
Yeah,
And
yeah.
I'll wait till the bone stops growing, and if there is any residual deformity, I'll go for orthopedic correction.
So in this case, in this mother now, she is not able to walk. She has a windswept deformity.
Corrective osteo.
I think she should be advised. Definitely orthopedic opinion will slightly vary. In principle, what you said is correct. Optimize the medical treatment well and make sure that mineralization is happening well. And then, like you said rightly, alkaline phosphatase and other things will help them.
So when you child you see, no, you take oxology. Which are the parameters you monitor in these children, especially phosphopenic kids?
USLS ratio might be
Okay,
of
height,
importance.
weight, upper segment, lower segment, then
Intercondyle and intermalleolar distance.
then anyone? Actually, that son has got that picture. What is that?
He has
Head circumference. Head circumference needs to be monitored in these kids. They can have a dolichocephaly. Yes, just in tell a case of a, if you are seen at 4 years of age, how you would have approached this child. See, it's a late by default. Seen at the age of 4 years, how you would have approached. What is the first investigation? How would have proceeded by that? 1 minute, fast.
I would like to start with a PTH value for evaluation. If
PTH is not available. In fact, left and right, none of us can ask PTH, which is takes time. Which is initial first thing you'll have.
for evaluation, first routine CBC, RFT, LFT, I would like to rule out the nutritional.
Okay, done. Now specific to this one, bone only.
Bone only. The first line of would be calcium, alkaline phosphatase, phosphorus, urinary calcium creatinine ratio, urine routine to look for RTS, and then ABG to look for an acidosis as well.
Vitamin D, you didn't tell.
Yeah,
Vitamin D,
vitamin
and
D,
PTH comes the
yes.
thing. Fine, because still commonest is
Vitamin D deficiency.
nutritional rickets is still more commonest. This is still a rare. Only when you treat that, if it doesn't respond, then you
Then
think
we have
of
to look for
these
other
things. Still, your approach has to be toward, because which is a consistent feature of rickets? Rickets across all spectrum of rickets, which is a consistent feature?
Biochemical.
Yeah, biochemical. Yeah.
Increased alkaline phosphatase.
Low phosphorus. Low phosphorus is the consistent feature across the thing. So that's why every rickets will come as low phosphorus. You can't just jump and start the treatment on this. Alkaline phosphatase is more reliable in childhood or an adult?
In adults.
Okay, no need to. Another is left is yours. Adult or a childhood? Alkaline phosphatase is more reliable in childhood or in the adults?
Sir, adulthood, sir.
Childhood. Adult only 50% comes from the liver. Childhood is the one which is more specific. So still with general your alkaline phosphatase is fine. Adults sometimes you may have to ask for a bone specific. Done. Yes.
Thank you. Thank you, everybody.
Thank you, Dr. Krishna, for your thorough workup. And thank you, Dr. Sriram sir and Dr. Vagesh sir, for the excellent case discussion. We'll move on. In the next 1 hour, we'll be discussing 2 cases. For the first case discussion on PCOS, I invite Dr. Aditya from Amrita to come on stage. Dr. Aditya. And the faculty for this session would be Dr. Nisha ma'am and Dr. Vijay Sarthi sir. I also invite the other students, Dr. Subhashish, Dr. Mokshit, Dr. Arjit Singha, Dr. Yash Chauhan, Dr. Mahesh, Dr. Lavanya, Dr. Vishwanath, Dr. Gopinath, and Dr. Raghuraman. Over to Dr. Aditya.
Good afternoon, everyone. I'd like to start off the case. Our first case is a 14-year-old 8-month girl studying in 9th standard who presented to us in early 2021 with the chief complaints of menstrual irregularities for 2 years, unwanted excess hair for 7 months, and hoarseness of voice for the last 4 months. Coming to elaboration of presenting complaints, we'll start with menstrual irregularities.
Aditya, go slow.
She had thelarche at 12 years of age, pubarch a few months after that. She had menarche at 13 years of age, which was manifested by spotting in early 2019, after which she did not have any cycles for 1 year. When she presented to us in January 2021, she had had 2 episodes of spotting in the previous few months.
You said pubarche was few months prior to thelarche or after thelarche?
After thelarche.
Okay, so what are the conditions where if pubarche precedes thelarche, you will suspect any particular condition? Will it be of any use in your differential diagnosis?
So in non-classical CAH, they have a propensity to present a few years before thelarche.
Other than non-classical CAH, any other condition which can present with earlier pubarche? I think that's not a DD here. Any other condition which can present with unwanted hair and irregular cycles at 14 years can have premature adrenarche? Other than CH? Cushing's disease, okay. Can it be glucocorticoid resistance syndrome, though rare? What about an SGA girl who is later progressing to PCOS? Can she have a premature adrenarche? Right? Okay.
How do you define menstrual abnormality? What do you think about? What is abnormal menstrual cycles? Definition?
It's divided according to the age after menarche. In the first 2 years, any cycle length which is greater than 90 days is abnormal, or the average cycle length is greater than 45 days. And after 2 years, if the average cycle length is greater than 30 days, or at any time if the cycle length is greater than 90 days.
All of you agree with the first year definition? When you say irregular menstrual cycles or normal menstrual cycles in the first year?
First year, if greater than 90 days is there, then it is abnormal. Apart from that, everything is.
For the first year, nothing is abnormal. You did not have to consider anything to be abnormal. Earlier definitions used to say even 2 cycles per year is okay for the first year, whereas now they just consider it as a normal menstrual transition. Even not having a next cycle in the first year is also not considered abnormal. Whatever you told 90-day cycle is beyond 1 year of menarche.
That is 1 to 3 years. That is the definition. Aditya, you can just show the slide.
This is the proper definition. Normal during the first year post-menarche. From 1 to 3 years, less than 21 days or more than 45 days. From 3 years post-menarche to perimenopause, 21 to 35 days, or less than 8 cycles per year is abnormal. Or from 1 year post-menarche, more than 90 days for any one cycle. And primary amenorrhea is defined as by absence of onset by age 15 or more than 3 years after thelarche.
Okay. Okay.
So which ones? Coming back to history, hirsutism, she noticed hair growth over her face, which was increasing over the last 7 months. Initially, it was over the upper lip and lower jaw. Initially, it was slow in progression, which had intensified over the last 2 months prior to presentation. She had not attempted to remove it, and she had also reported increasing hair over torso and abdomen.
So, Dr. Mohit Shah, what is hirsutism? Define hirsutism. No, that is the how we quantify. What
Definition.
is hirsutism definition? What is the other? What is the other type of hair which you get? How do you differentiate between the two?
Keep your mic close, please.
Thin hair, ma'am, non-pigmented, while in hirsutism, hair is thick and pigmented.
Any growth rate mentioned?
Growth rate is low in villus hair, while
No,
high.
any quantification mentioned? Any reference?
For villus hair, it is 0.03 millimeter, and for another is 0.06 millimeter, I think.
So,
what are the other features of hyperandrogenism which you look for other than hirsutism? Dr. Singha.
Ma'am, we also look for any features of any virilizations, particularly if there is any history of the breast atrophy, if there is any history of any clitoromegaly,
No,
also in the
that is
voice change.
Oh, that is virilization. Yeah, extreme hyperandrogenism. Other than that, common things.
After hirsutism, next important thing is what?
In skin, we also find the presence of acne and also the oily skin is there.
Do you suspect hyperandrogenism in all patients with acne or in a subset of patients with acne? When do you suspect hyperandrogenism? Cystic?
Cystic.
Or pustular, nodular? Anything? Sorry? I don't think it's a
That is
particular
normal.
thing, but something that does not respond to topical therapy. Also, you should suspect the possible hyperandrogenism there.
So this is defined as moderate to severe comedonal acne or moderate inflammatory acne. Both these are manifestations of hirsutism. Less severe varieties are common in adolescents. It is not pathogenic for hyperandrogenism. What is the cutoff for Ferriman-Galway score which you use, Dr. Chauhan?
More than 6 to 8 is suggestive of significant. More than 8 is suggestive of hirsutism.
We have got different cutoffs. Where do you get the 6 and 8 and all from?
More than 8 is abnormal, 8 to 15 is severe, and more than 15 is moderate to severe.
What does the latest international guidelines say?
So according to the latest international guidelines, they have essentially recommended a cutoff of more than 4 to 6, but it varies according to ethnicity. This is from 2018 guidelines. And they have said that the simplistic cutoff of 95 percentile is not appropriate. So if it is more than 4 to 6, we can suspect hirsutism. Next is
that is the modification. Previously, you used to take 8 and all. Then now it is 4 to 6 because to define what is significant, you need a different methods. Like some take 85th to 90th percentile, some take 95th percentile, some take features in association with PCOS. So overall, the conclusion is more than 4 to 6. That is in general. Do you know of any Indian studies which have given Indian cutoffs? Anyone from Kashmir? Okay. So Dr. Kashmir has a study of hirsutism where they have taken more than 8 and define the prevalence as 10%. Yes, Aditya, you can go. So what is the other manifestation of hirsutism? Alopecia. So alopecia, acne, and hirsutism. Sorry, hyperandrogenism, alopecia, acne, and hirsutism. So what is the action of androgen on the hair? Dr. Lavanya. Why does androgens produce hirsutism? What is the source of androgen in females?
50% from the ovary and 50% from the adrenal.
Remaining, not that. It's ovary and adrenals contribute equally. What is the other major source? Peripheral conversion. So, which are the androgens which are important in hair cycle, and where does it act? On the pilosebaceous unit. What are the cycles of hair? What are the phases of hair cycle?
Anagen, telogen, and catagen.
So, what is the action of androgen on the hair cycle? Why does it produce hirsutism? Aditya?
So androgen induces the expression of a keratin-specific protein, which is HHA7, which is specifically expressed in the medulla of sex hairs. The promoter contains an androgen response element, and which is activated by androgen. And there are multiple other hormones which also act on the hair cycle, including glucocorticoids, estrogen, peptide hormones like parathyroid, prolactin, thyroid, growth hormone, IGF-1, as well as vitamin D.
So this is the how you quantify hair loss Ludwig scale, and how you quantify acne. So more than 10 comedonal acne or inflammatory acne is defined as suggestive of hyperandrogenism.
So non-inflammatory acne forms are usually whitehead or blackhead comedones, while inflammatory ones are nodular, cystic, papillary, or pustular forms. So coming back to our history, other changes which we noted, there was no acne, no androgenic pattern of hair loss, but mother had noticed a change in appearance of external genitalia, which had increased in size. So 6 months back when she had a genital examination for UTI, it was apparently normal. So hoarseness of voice was also reported around 4 months back. Laryngoscopy was done by an ENT doctor, and it was found to be normal. She also reported change in body contour, more muscular appearance, along with weight gain and height spurt over 1 year. The weight gain and height spurt could not be quantified. She was above average in height compared to her peers.
Aditya, just hold on. Go back to the last slide. So what are you trying to point out with the word hoarseness of voice?
So essentially, sir, I'm trying to look for features suggestive of virilization.
Do you think the voice gets hoarse in virilization?
Deeper and
is it the right term to use? Okay. Breaking of voice was there? Or it's not strong enough to say breaking of voice?
That specific history I cannot tell, sir.
Okay. Maybe just the change in voice is a better term if you're not very sure about what you're dealing with, rather than committing it as a hoarseness.
Yes, a change in voice we can.
Right. And second point is that, are you going hand in hand when you say muscular appearance and weight gain?
No, sir. So in this, sir, muscular appearance will probably more in favor of defeminization along with virilization rather than anything else.
And this muscular appearance is also compounded with loss of fat typically, right?
Yes.
But here you are giving a muscular appearance with weight gain. So where the weight gain is coming from?
Sir,
is it just the muscle bulk, or?
So probably fat deposition along with.
Do you have photographs of the patient? Can we
No,
have a look
sir,
at it?
we don't have the photographs.
No? Okay, please go ahead.
Other relevant negative history, there was no loss of scalp hair, no abdominal pain, no intake of any exogenous drugs, alternative or otherwise, nor she did not have any history suggestive of Cushing syndrome, like difficulty in getting up from squatting position, striae over abdomen, easy bruisability, no history of cold intolerance, constipation, dry skin, headache with galactorrhea, visual disturbances, increase in shoe size or ring size, no history of no snoring, a daytime somnolence or interrupted sleep. Perinatal history. She was the second child of a non-consanguineous marriage. The antenatal course was uneventful. No history of any maternal virilization or any use of any hormonal agents at this time. She was born at term through normal vaginal delivery, weighing 2.9 kgs at birth. She cried at birth. There was no ICU stay. Parents did not note any genital ambiguity. There was no failure to thrive in the immediate neonatal period. Postnatally, she was immunized for age and milestones were normal. Coming to family history, a mother was hypothyroid on treatment and she has been on LT4 for last 3 years. Father was diagnosed with diabetes at 30 years of age and on oral antidiabetics. There's a strong family history of young onset diabetes during the father's side, all less than 40 years of age, multiple siblings and cousins. Elder sister was diagnosed with PCOD. But in her, hirsutism was less severe and cycles occurred roughly around every 2 months. In the family, there was no other history of.
Can we have more details of her? Is she obese? Elder sister, is she obese?
So overweight, so not obese.
Overweight. And like, when did she had this irregularity of cycle? What age? How old is she at the present time?
She is 16. Elder sister would be early 20s, sir. So she had around 16, 17 years of age, roughly.
She manifested irregularity of cycles.
So initially, mostly irregularity of cycle, for which she had gone to an OG-shin. Ultrasound-wise, it was proven. And after that, she has hirsutism, but much less severe than her sisters. So primary will be oligoanovulatory pattern was the primary complete, right? So in the family, there were no other history of infertility, gynecomastia, unexplained childhood deaths, failure to thrive, abnormalities of stature, or any surgeries. So coming to importance of family history.
So anybody would like to take? So what are the importance of family history in a patient who is presenting with hyperandrogenism of adolescent onset? Anybody? Lavanya, want to take?
Consanguinity can be there if it's a non-classical CH. So it's very important to assess it.
How strong the family history of simple PCOS?
It's also significant. If mothers with PCOS are more prone to have daughters who will also develop PCOS in adolescents.
Right. You want to take up the next slide?
Regarding concordance studies, twin concordance show there's a concordance of about 70% in twins. In around 50, in mothers with PCOS 50%, and in siblings 50% concordance with hyperandrogenism and 25% when it comes to anovulation. So the multiple genes, genetic loci have been determined in genome association studies, but they only contribute to a modest proportion of heritability. This includes the more famous version would probably be overexpression of DEN-Day1.V2.
Go to next slide.
Coming to adolescent hyperandrogenism.
What are DDs you would like to entertain here in this particular patient?
Sir, as there is a history suggestive of virilization is there, and which is rapid in onset. So along with the severe PCOS, we will also look for any androgen producing tumor, particularly the adrenal and the ovarian origin also.
Right.
Exactly.
But would you like that as a first DD for someone who is presenting for the first time during adolescence with hyperandrogenism? I won't say it's not adrenal or ovarian androgen secreting tumor, but I would say it's not my first DD there.
Yeah, yes, sir. Well, possibly we will first keep the PCO and the first DD and the only PCOS, sir.
PCO is the first DD, right?
Yeah.
Right? Is
non-class. Sir, severe PCO may present like this.
So what do you mean by severe PCO? Which variant will present with severe
If there is any ovarian hypertrichosis, if there, then it may present like
so
this.
one thing could be hypertrichotic PCOS. Any other possibility?
NCCH may present like this.
Non-classical CH. What type of non-classical CH can present like this? Which enzyme deficiencies?
We don't know the history of hypertension is present or not, but
right.
21 alpha hydroxylase deficiency,
21 alpha hydroxylase,
11 beta hydroxylase deficiency,
11 beta can present like this.
3 beta HSD2.
3 beta can also present like this, right? Anything else? Aromatase is a possibility. It has not gone into the examination. But how aromatase would differ from these conditions? Typically, the breast development won't be too good, unlike other conditions where breast development is relatively good, right? Any other condition? Again, GRS. Okay, and of course, your androgen secreting tumors.
Pore also. In the CH pore also you should consider.
How many of you would agree with man? Got the answer right? How many of you would agree with man? No answer. Right. So typically the pore deficiency, right? They do present with cystic ovaries, in fact, multicystic rather, may sometimes get confused to polycystic morphology. And also they get menstrual irregularities, which often gets confused for PCOS. But in someone who is presenting with such a severe hyperandrogenism, pore deficiency is one of the least likely causes because there is also impaired production of androgens. They may have excess production of androgens in the prenatal period. But in the postnatal period, even around puberty, it's very, very unlikely that they will come with an elevated testosterone. So that's, of course, you can include in as a last cause, but one of the least likely causes in this particular patient.
And what are the drugs implicated? He's told there is no intake of drugs. So drugs which can cause PCOS like picture, commonest. Pardon? Phenytoin is no, other than more than phenytoin, some other anti-epileptic? Valproate. So a common thing is valproate and sometimes phenytoin. And there are a lot of other drugs which are described which are not commonly used. You can go on.
To summarize the history, this is a young teenager with a menarchal onset of anovulation with hyperandrogenism with a relatively rapid progression. So we have to look for secondary causes of PCOS also. Apart from that, based on history, the other differentials would be androgen secreting tumors, and lower down aromatase deficiency, glucocorticoid resistance, Cushing's, over-testicular DSD, or also mixed gonadal dysgenesis with a Y chromosomal involvement. So coming to exam,
Aditya has not mentioned hypertrichotic variant of PCOS there.
So in the secondary causes of PCOS,
secondary cause of PCOS does not include hypertrichotic variant.
Atypical PCOS with insulin resistance and hypertrichosis. Right. So on examination, I'll just speed through because of time. Patient was oriented, comfortable in rest. Vitals were stable. She was obese. BMI on IAP was 27.23, which corresponds to adult onset of obesity. Waist circumference was 91 centimeters. Head-to-toe examination.
Hold on, Aditya, go back. Though it's not very relevant for this case. Upper segment, lower segment ratio of 0.85. How do you interpret this? One could have been aromatase deficiency. But any of you are aware of the recent data from Khadilkar and group on the upper segment, lower segment ratio in children? In fact, in the adolescent age group, the median was 0.9. That means nearly around 50% of the children had a USLS ratio which is less than 0.9. So if you go by then, even 0.85 may not be abnormal for Indian children. So we need to interpret the USLS ratios with the reference data. Okay.
So examination wise, significant findings. She had so fleshy nose and thick lips. Acanthosis was grade 2 over axilla and neck. The modified Feynman-Galvez score was 20. On examination of genitalia, Tanner stage pubic hair 5, 3 centimeter, and the size of clitoris was 3 centimeter. The breast appeared to be atrophied, but the nipples were well developed.
Hold on. First, try to say it's a female external genitalia. If you're really, especially when talking about clitoromegaly, okay, or at least apparent female external genitalia. Another point is you have not mentioned about the breast staging. You said breast atrophy. Are you not able to stage it?
Sir,
is it B4, B5?
B5 only, sir. Actually.
Okay, B5 with a smaller glandular component. How did you say it's atrophy?
So the nipples are the nipple alveolar complex is preserved, while the breast size per se is on the lower side.
Okay.
So then we took the help of pediatric surgeons, and two openings were well delineated. Vaginal discharge was present. There was no posterior labial fusion. The labia minora appeared to be poorly developed, and there were no palpable gonads. The systemic examination was largely normal.
What do you mean by vaginal discharge present? Why was it present? What type of vaginal discharge?
So, mostly non-infective, nothing to suggest infection.
Is it just a simple mucoid discharge?
Simple mucoid discharge. Extra point in examination in this case would probably be presence. We should look for macroglossia, lipodystrophy, abnormal fat depositions, hyperpigmentation, or any hepatosplenomegaly, all of which are relevant for differential diagnosis as far as history is concerned. So we know that portosystemic shunting can also manifest as hepatomegaly or splenomegaly.
No, that's just because one rare cause of hyperandrogenism in adolescents and or even in children with premature puberty, you have to always consider systemic causes, photosystemic shunting, because of the increased insulin and the decreased catabolism of the androgens and the sex hormones, you can get hyperandrogenism. We have had cases who were misdiagnosed as PCOS and later turned out to be photosystemic shunting, basically because extra hepatic portal obstruction, portal vein obstruction can all present with hyperandrogenism. So just to make you aware, and go ahead, Aditya.
Coming to differential final impression. So 14-year-old female who had onset of menarche, who had two openings were present. There was peripubertal virilization and ovulation with significant clitoromegaly. So differentials.
We have the same differentials out there.
So in this case, it could be adrenal and ovarian tumor because of the rapidity of progression, atypical, more aggressive forms of PCOS. Later down, there could be NCCH or POR mutations, mixed gonadal dysgenesis variant with Y chromosome, or aromatase deficiency at the very last.
Fine, just hold on. So, yeah, please.
We have seen, especially in South India, many girls coming with the history that they had on spotting. Other declare, it's a custom, social custom that they declare the concept of menarche. So, but many times they turn out that they have additions. So, socially, so why not it came in?
That's what. So that's the point I wanted to highlight in the second slide. The two things I wanted to highlight. So, yes, yeah. In fact, he brought it partially by saying mixed gonadal dysgenesis, right? But it could also be any kind of a partial gonadal dysgenesis or variants of O-testicular DST, even some variant, other variants of 46XY testicular DST with some virilization at puberty. So very well possible, right?
So, sir, in OTDSD, possibly there will be asymmetrical genitalia will be there.
Yeah. Not necessarily. Asymmetrical genitalia, if it presents, it suggests O-testicular DST. But not necessarily that all O-testicular DSD should have an asymmetrical genetic. It also depends on, for example, you have one side ovary, one side O-testis. That's also O-testicular DSD, though a rarer form. They typically present almost like a girl, right? So it's not necessary that they should have an asymmetrical genetic.
If you believe Dr. Sriram, what Dr. Sriram has told is absolutely right. This history of spotting is this way, that way. We can't take it. We have to always take it with a pinch of salt. But this girl described 3 episodes of spotting. So that means there should be something is what we assume. So that means the Mullerian structure and the outflow tract is intact. And then something happened which developed. And then the physical examination also shows only isolated clitoromegaly with no posterior labial fusion. And nothing else to suggest a prenatal androgenization. Yeah, and the nipples were also well developed. So that is breast 5, but the size is less. So probably it is most likely, initially we had a doubt whether it was 2 openings or single openings, but pediatric surgeons told for sure that there are 2 openings.
So in view of B5, we can discard the XY as a D. Right.
Then laboratory investigations can be divided into first line and second line ones. These are the first and second line which we pursued in this case, which ideally should be pursued. So if investigations, investigation wise, in the first line of investigations, testosterone levels were elevated. It was 5.5 nanomole per liter with LH more than FSH. estradiol, norm, and prolactin, thyroid function test, DHEAs were all normal. The routine examination, there was no dyselectrolyte electrolyte abnormalities were not there. HbA1c was 5.4, fasting blood sugars level 94.7. LFT was AST was slightly elevated, and total cholesterol and triglyceride levels were also borderline elevated. So we did it on the baseline, so we did not recheck it.
If it's a primary hypertrichotic variant, sir, then the LH suppression doesn't come. If it's usually typically androgen secreting tumors, they're also like it will still be remaining in 5 and 10. Probably this is more of it favors more of a hypertrichotic variant of PCOS.
The androgen level is only 1.44 nanogram per ml, 5.5 nanomoles it is. Testosterone, not very high.
In fact, like we always thought that it may suppress LH in androgen secreting tumors. When we wrote that paper of virilizing ovarian tumors, majority of them had normal LH only, so none of them had a suppressed LH.
So then the second line test, free testosterone was also elevated, 7 picogram per ml. SHBG was reduced. Androstenedione was also slightly elevated. Free androgen index is definitely elevated, around 4 times of what is ideal. ONDS, we did stim cortisol and stimulated 17 OHP to rule out very unlikely form of NCCH. ONDST was suppressed and AMH levels were normal.
You're done?
No, sir.
No, I think we'll stop here because you already exceeded the timing.
So finally, since there was a menarche which we believed the patient, and then there was an androgenization feature which lead to virilization. Even though the testosterone levels didn't reach the tumoral range, we always had to rule out a tumor, which is a sinister thing. So we did an MRI, which turned out to be simple PCOS, no tumors in the ovary or the adrenals. And finally, so the final diagnosis we thought was still could be hyperpicosis, a typical variant of PCOS. And she didn't respond to progesterone. She did respond to estrogen progesterone combination. She was very irregular in treatment, and she she was lost to follow up. And when we called her again, she has not taken the tablets, and she again had a baseline testosterone of 5 nanomoles per liter. Just show the PCOS. That's it. So this was the typical PCOS appearance in the MRI. Ultrasound also.
Right side, left side.
With an increased trauma and a peripheral arrangement. Right. And we started on metformin also because Hyperandrogenism syndrome was because of the insulin resistance and the high insulin levels. We started on metformin also. We did clinical exome. Sorry about that. Dr. Nihal would not agree to that, but our place we do because this is so atypical. We did a clinical exome also to rule out any insulin resistant syndromes. It turned out to be negative. At the type B, acquired you are telling? Type B. Okay.
Typical insulin PCOS of that insulin resistance, that will be a dyslipidemia, somewhere. Here, if it's HDL 55 triglyceride, just the period we considered for.
Yeah, subtle findings. Thank you.
Okay, so we'll go on to the TAO because of want of time.
For the discussion on TAO, I invite Dr. Afsar from Nellore. The students and the faculty will remain the same. I think we should try and finish by 3:30. So that will be about 20 minutes.
Good afternoon, professors and my colleagues. The case I'm going to present today is a 27-year-old male hailing from Nellore, Andhra Pradesh. He's a daily vision by occupation and he belongs to lower socioeconomic strata. He's a diagnosed case of hyperthyroidism from the past 5 years. He has presented to us in November 2021 with a complaint of prominence of both the eyes from the past 4 years. There is a history of weight loss from the past 1 year. He has also complaints of pain and redness of eyes from the past 4 months. Presenting illness. He's a known hyperthyroid from the past 5 years. He was initially started outside on medication neomercazole 10 milligrams TID. However, due to poor compliance and intermittent medication, it was increased to 20 milligrams thrice a day. Later, which he has developed hypothyroidism. The TSH report was not available, and he was shifted to levothyroxine 50 micrograms once a day, which he happens to use for a period of 6 months. And currently, he was reverted back to anti-thyroid drugs from the past 1 year, and he's on methimazole 10 milligram once a day. So he had a brief episode of hypothyroidism during his course. So from the past 4 years, his main complaint was mild prominence of eyes, which for the initial 3 years, there was no further progression, no associated complaints. But from the past 1 year, the prominence has increased to more bilateral eyes, more in the right side. There was associated grittiness, foreign body sensation, which was initially occasional, but from the past 1 year, it was excessive and associated with tearing from the both eyes. There was no purulent discharge, fever, or headache.
Right. Subhashish. Right. So I would like to ask 2 questions from this slide. So like this patient required treatment with levothyroxine. So do you think was that necessary in this particular patient who is only on ATD? How we would have managed this patient if he goes into hypothyroidism?
Sir, we can decrease the dose of neomercazole and that will be, but however, he has a history of thyroid associated ophthalmopathy and hypothyroidism or increased TSH at the time, but there is nothing to about the TSH.
Let's just take a word from Fatima. Fatima, is this hypothyroidism episode preceded this prominence of eyes or it's a later incident?
Sir, initially he had prominence of eyes, sir, but it was very mild.
But when this hypothyroidism
this
episode
from the past,
occurred?
yes, sir, it preceded this 1 year episode, sir.
Okay,
This
so
hypothyroid.
I mean, after hypothyroidism phase,
It
ophthalmopathy
has
appeared?
worsened, sir.
Oh.
Yes.
Maybe the TSH has increased, yet iatrogenic hypothyroidism is a cause of more precipitation of tau. So this may have led to the increase in the proptosis and thyroid associated.
So what do you do in that case? So you want to give only thyroxine or you want to give thyroxine with continued carbimazole? What do you want to do?
Sir, I think.
Are you not going to over-treat if you do with thyroxine?
Sir, I think if you decrease the dose, if you halve the dose, then it will be enough.
Yeah, maybe you can consider a larger reduction in the dose in that case rather than adding thyroxine. Or you want to temporarily consider completely stopping and looking for the, kind of, right.
What do you think has happened? First year, then some prominence, then no progression, and now there is progression. Is it all graves of thermopathy? Do you think it's all graves of thermopathy? What is the natural history? How long it will progress? How long it will remain status quo? And then how long will it take to remit?
Usually, a Graves' orbitopathy is a 2 phase: the active phase, initial active phase, and then the static phase, and then the remission phase. The initially active phase usually around 1.5 years and 18 months. And after that, the phase usually gets static and the patient may become.
So why is it like this in this case?
I don't know whether the prominence of the eye, the patient is.
That is what you want to. So initially it may not be a Graves, it may be just a stare of the hyperthyroidism, which the patient has
possibly
noticed.
Prominence or may not be the thyroid acid already. Possibly it may be the lead retraction was there. So
what is that curve typically called as? The course of ophthalmopathy?
Randall, sir.
Only 2 patients. Nobody validated it later? Good.
To continue, he had pain during extremities of gaze from the past 1 year.
No, that's RUNDLE, RANDLE, they're different. So, yes. Please go ahead.
Pain during extremities of gaze from the past 1 year, which has progressed to spontaneous pain at rest and discomfort behind the eyes from the past 4 months. It was associated with redness of eyes, blurring of vision, photophobia occasionally from the past 4 months. There was no history of double vision or difficulty in color vision. There was also unintentional weight loss over the past 5 years of about 14 kgs with a normal appetite. It was not associated with polyuria or any other symptoms.
One thing I would like to point out, Fatima, is that like how often your patient will come with difficulty in color vision, even if they have color vision. Is it a history worth taking even?
No, sir. Difficulty in color vision mainly points out towards optic nerve involvement or
But will they come out with that? The patient will ever come
sir.
to you and tell you that they
Usually-
have color vision defect?
No, sir.
Right? It's
Usually,
only pure examination finding. So no need to include that in the history at all. Right? Okay. Good.
There was history of decreased sleep with anxiety episodes, and his routine activities were affected due to his occasional blurring of vision, excessive tearing, and his behavioral symptoms.
What was the cause of blurred vision in this patient? Okay.
It can be due to this thyroid optic neuropathy. It can be due to glaucoma.
But what is the most common cause?
Lacrimation.
Increase? Yes, it could be because of lacrimation. On the other hand, it could also be because of the exposure, right? Where there's a dryness. Many times may not even be, there may not be any keratitis changes, but just a corneal dryness can also lead to blurring of vision, right? That's the most common cause. Because when it comes to loss of visual acuity, of course, that several features in picture, including thyroid optic neuropathy.
He has palpitations on and off, which are insidious in onset. They are mostly exertional and relieved spontaneously without any intervention. He had tremors of hands, both at rest and during activity. There was no history of heat intolerance, excessive sweating, any skin or nail changes, no history of dyspnea, dysphagia, or change in voice, no history of muscle weakness or arthralgias, no history of chest pain, swelling of feet, or jaundice. His past history was unremarkable. There was no history of any other medication intake or radioiodine therapy or orbital procedures. There were no history of comorbidities or any major illnesses. Family history was unremarkable for any thyroidal illness. Personal history, he's a chronic smoker from the past 12 years and he continues to smoke cigarettes 8 to 10 per day. He's a non-alcoholic. Diet is mixed. He takes iodized salt in meal and consumes seafood.
Yeah, 1 second, Fatima. I think we'll take up this question. Arjit, so what are the mechanisms? Why is the smoking history is important in this particular patient?
Smoking is particularly aggravate the pathogenesis of thyroid-associated orbitopathy, and there are several mechanisms of that. Number one is the smoking contains mainly nicotines, and it has been shown that smoking is associated to increased oxidative stress. And also there is an increase in the inflammatory markers. There is also some proposition that smoking causes the polymorphism of the TSH receptor and it becomes more antigenic. And there is also production of increased anti-TPO antibody.
Right. I'm not sure about that, but the most important thing probably could be hypoxia.
Yeah, hypoxia.
Right, rather than the oxidative stress. And obviously there's worsening of inflammation because of several mechanisms which are there.
And smoking is also associated with decreased remission and also resistance to treatment, to anti-thyroid drugs.
So it has all the aspects, I mean, it affects in all the aspects on ophthalmopathy, right? Okay. Next slide.
To summarize, this is a case of 27-year-old male who is a chronic smoker, known hyperthyroid from the past 5 years, and is currently on methimazole 10 milligrams once a day. He has a history of intermittent treatment and poor drug compliance and history of hypothyroid episode. He presented with prominence of eyes, redness and pain, difficulty in vision, with a worsening of all these symptoms over the past 1 year. He has associated palpitations, tremors, and weight loss suggestive of active clinical thyrotoxicosis. With this, the provisional diagnosis could be Graves' disease with thyroid-associated orbitopathy.
Right, go to next slide.
General physical examination, conscious, coherent, and well-oriented. He was normally built. Height, BMI was 25 kg per meter square. His pulse rate was increased, 114 beats per minute. It was regular rhythm and high volume. Blood pressure is 146 by 70 millimeters of mercury in right brachium in supine posture. Temperature and respiration were normal. He had fine tremors of hands and tongue. Palms were warm, moist. Skin and nails were normal. No vitiligo, acanthosis, skin tags, skin hyperpigmentation, no skin plaques, or any evidence of dermopathy.
So, Dr. Yesh, can you please tell what are the nail changes in patients with Graves? What are the prevalence of thyroid acropathy in Graves? Okay. What is the prevalence in a Graves patient who does not have ophthalmopathy? Yes. Usually it's very, very unusual to have dermopathy or acropathy without having ophthalmopathy. Right. Any other nail changes you know? Anybody else in the group? Very good. Onycholysis. What is it called as?
Plumber's nails.
Plumber's nails. Right. Good.
Examination of thyroid. On inspection, there is a grade 2 diffuse goiter noted at the anterior aspect of neck, moving with deglutition with visible lateral extension and lower border. Overlying skin is normal with no distended veins or sinuses. On palpation, a diffusely enlarged goiter which was soft in consistency with a smooth surface and palpable lower margin is noted. There is no fixity of goiter to underlying subcutaneous tissues, no tenderness, nodules, or any palpable thrill. There is no cervical lymphadenopathy. Percussion of sternum was normal, no dullness. There is a bruit auscultated over the thyroid.
Right. So anything in addition to this you observe in the patient, which is purposefully skipped to mention? You're going to tell it in eye examination.
Yes, sir. Next eye exam.
Okay, fine. So then like the bruit, what kind of a bruit it is? Like how do you describe this thyroid bruit? Mahesh? Is it, how are you going to examine it? It's with a bell or a diaphragm?
The bell, sir.
Okay, what kind of a sound it is? It's like a systolic, diastolic, or a continuous?
It's a systolic, sir.
Sure? Huh? Anybody have a different opinion? Right. Bruit is supposed to be continuous. Right? Systolic, if it's in fact, you should think of a radiating murmur, okay, or a transmitted pulsation from the carotid artery. If it is purely systolic, you should attribute to that. Whereas thyroid bruit is typically continuous one. Where else you can see bruit in a thyrotoxic patient?
Eyelids.
Eyelids, very good. You can also see a bruit in thyroid in orbit, but that's not a sign of ophthalmopathy. That's just a sign of thyrotoxicosis per se, right?
Examination of orbit, staring look is present. Von Graef sign, Geoffroy sign, Mobius sign, Stelvag signs were noted. There is axial proptosis with Hertel's exophthalmometer. Right eye had 30 millimeters, left eye had 28 millimeters of proptosis. Lag of thalamus was noted in both the eyes, more on the right side than the left side. There was bilateral lid lag, but no globe lag. Bilaterally proptosis.
Which lid lag, Fatima?
Upper eyelid lag.
Upper lid lag.
Upper.
Is there anything called as a lower lid lag?
No, sir.
Anybody? Both are described. Both upper lid lag and lower lid lag, both could be seen in patients with Graves' ophthalmopathy. That's why you should very specify what lid lag you're talking about.
Okay.
Right? Good.
There's bilateral eyelid ptosis noted more in the right eye than the left eye. Extraocular muscles, there is restriction of abduction movement in both the eyes, more on the right than the left. There is restriction of elevation in the right eye. Pain on lateral gaze is noted in both the eyes, more on the right side. Congestion of bilateral bulbar and palpebral conjunctiva is noted. Edema of right eyelid and both the lower eyelids is noted. Active lacrimation is noted. There is no diplopia. Yugogo no spec score shows the presence of symptoms and signs, proptosis and extraocular muscle involvement.
What is the normal X of the means proptosis?
In Asian people, normally proptosis should be within the cutoff of 17 for males and 16 for females. But if it is more than 20 and 19, it is suggestive of proptosis.
It depends on the race, basically.
Based on race.
Asians have the lowest or the highest?
Lowest. Sir. Clinical activity score in the right eye was 6/7, left eye was 5/7, with pain at rest and pain with movement in both the eyes, swelling of caruncle, redness of eyelids and conjunctival injection in both the eyes, swelling of eyelid noted in the right eye. Yugogo severity score was suggestive of moderate to severe ophthalmopathy. Systemic examination, cardiac examination, apex were hyperdynamic.
You can skip it. You can skip it.
To summarize, this is a 27-year-old
Just
male.
hold on before we move on to the summary. So we looked at the CAS, right? So what are the limitations of CAS? What is the major limitation of CAS?
First is the components are subjective. The second, the score is binary, 0 or 1. When treating, after treating, we are not able to evaluate if an equal weightage is given to all the components. These are the
Basically, we're not able to use to assess the progression or betterment in a more objective way. So what is the better one to use, if at all, if you're monitoring to, no?
composite outcome score we can use.
Okay. Or any modification of CAS? In fact, do you know this is a modification?
Extended CS.
Yes. In fact, this is a modification. So the earlier CAS had all the 10 points, including 3 points for monitoring progression. So what are the points we'll monitor for progression or improvement? When do you say it's progressing? Any one of you?
If the visual acuity decreased by one Snellen chart, one line in Snellen chart, or diplopia increased by 8 degrees in any direction, or there is increase in proptosis by 2 millimeter.
Right.
These 3 points are included in the extended CS.
Good.
Any other scoring system you know?
There are other visa scoring system is also there.
Any other?
Any other? No specs. And one is that Vancouver, that is.
What does visa stand for?
V for vision, I for inflammation, S for sight, and A.
Strabismus. S for strabismus. A for appearance or exposure. Right? Total eye score. There are many, right? Summarize.
This is a case of 27-year-old male, known hyperthyroid from the past 5 years, currently on methimazole 10 milligram once a day. He's a chronic smoker and presented to us with proptosis, redness, worsening of symptoms over past 1 year. He has diffuse grade 2 goiter with clinically active orbitopathy with the clinical activity score of 6/7. Severity was moderate to severe with no dermopathy or associated manifestations or complications. So clinical diagnosis would be Graves' disease with grade 2 goiter, clinically thyrotoxic, moderate to severe with clinically active orbitopathy with risk factors of active smoking, poor drug compliance, hypothyroidism, no associated dermopathy or cardiac failure.
How do you manage this patient? Vishwanath? It's not in the team. Gopinath?
So first we'll make the patient euthyroid with medical management. Then we can plan for sperm.
So you want to make him euthyroid first before starting any treatment for his eye?
Eye, so there is.
What was his clinical activity score?
6/7.
Focus on it and then answer.
You can start pulse steroids. Sir.
How do
Pulse
you
steroids
start?
Plus,
What are the regimen you are using?
latest guidelines, we can start methylprednisolone, 500 milligram weekly for first 6 weeks. Then we can give 250 for next 6 weeks. Along with that, we can start mycophenolate mofetil also, 720 milligram. That is for 24 weeks.
720 milligram.
720 milligram.
What is this?
Mycophenolate.
Sodium.
Sorry, mycophenolate sodium.
Why you should know it's a sodium or other component?
Dosage differs.
Dosage. What is the equivalent dosage of the other molecule?
1 gram.
Right? Okay. How do you administer mycophenolate?
Oral. Sir.
Oral, but like what instructions you will give? Morning, evening, before food, after food?
1 hour after food, 1 to 2 hours after food.
Typically, it's given in empty stomach or 2 hours after. Maybe only in those patients who have a GI intolerance, you can consider giving with the food. More important is to give it consistently in relation to the food, but preferably given in the empty stomach, right? Okay.
Anyone giving mycophenolate as first line for Graves orbitopathy? Which institute?
In the interest of time, we would like to wind up, though discussion is not complete. So can I? Kripa?
Thank you, sir and ma'am, for that excellent discussion on PCO and thyroid-associated orbitopathy. We'll move on to the next session, which will be an exciting debate. For this, I invite Dr. Lavanya from St. John's and Dr. Avivor from Calcutta. The topic for the debate is the administration of octreotide before surgery for acromegaly, for or against. So each presenter will have 7 minutes each for for, 7 minutes for against. You will have 4 minutes to defend and rebut, and the remaining 12 minutes will be a discussion by the faculty. The faculty for this session would be Dr. Sridhar sir, who is here with us, and Dr. Madhukar Mittal sir, who will be joining us online. Over to the presenter and the faculty.
Good afternoon, Randall. So by the two post-lunch case presentations, the third one is a debate. And I think everyone understand the title. So octreotide before acromegaly surgery. So octreotide definitely plays an important role in management of acromegaly. So this debate is regarding the before acromegaly surgery, whether to all. So for the motions, I would like to invite the Dr. Lavanya from St. John's for the motions. Dr. Madhukar sir, you want to tell?
No, sir. Good afternoon, Dr. Sridhar, and I think we can go ahead with the debate. Just want to thank the organizers, Dr. Thomas Paul sir and Dr. Nitin Kapoor, for having me and the entire department. We can go ahead with the debate, sir.
7 minutes you time.
Good afternoon, everyone. I'm Dr. Lavanya from St. John's, and I'm here to speak for the motion, use of octreotide preoperatively in patients with acromegaly. It's not moving. Before starting, I'd like to bring your attention to a few facts. 80% of somatotroph adenomas are macroadenomas. Only 10 to 20% of macroadenomas more than 20 mm achieve remission with surgery alone. And uncontrolled acromegaly, as we know, leads to very high morbidity. Since I'm talking first, I'd like to introduce the topic. Somatostatin is a hypothalamic factor responsible for inhibition of GH secretion. Synthetic somatostim receptor ligands are used in acromegaly because of their high potency. For example, octreotide has a 19-fold potency than the native somatostatin. So somatostatin receptor ligands have an anti-proliferative effect, reducing the tumor size, and also reduce the GH and IGF-1 levels, leading to therapeutic effect in acromegaly. The various formulations used include the first generation SRLs like octreotide and lanreotide, of which I'll be talking only about octreotide today, and newer SRLs like pasiotide, somatoprim, oral octreotide, and paltusotine. So octreotide was the first SRL introduced more than 30 years back, with a high affinity binding to SSTR2 and type 5 receptor, with a pharmacological action primarily via type 2. It was earlier given as subcutaneous preparation in the past, and now it's given as an IM depot preparation using microsteers. And the doses are around 20 to 60 mg every month. So moving on to the treatment of acromegaly. What is the role of surgery in acromegaly? Yes, it is the first treatment option in a large proportion of patients with acromegaly. However, in reference centers, persistent disease is seen in up to 50% of patients harboring macroadenomas. And coming to Indian data from prestige centers like Vellore and PGI, there is a cure rate of only 23 to 31%. And surgery is largely operator dependent, and at least 50 pituitary surgeries per year has been given by Pituitary Society as a criterion for the operator's proficiency. So what could be the reason for such a dismal surgical success rate? They are usually macroadenomas, like I mentioned. They have a long latent period for diagnosis, and most are invasive by then. And when invading into the cavernous sinus, which is not easily accessible through TSS, there is again a high surgical risk, which is why it may fail. So we can agree that probably surgery alone is not the perfect solution. Which brings me to the preoperative use of octreotide. It was first put forward more than 30 years back that if one could by some means shrink the tumor, bring them into an easily accessible field, and thereby improve the success rate. So there is no doubt about efficacy of SRLs as somatotropinoma shrinking agents. As seen in this large meta-analysis of 41 studies, some post-op patients, 41 studies including more than 700 patients showed that a tumor shrinkage was seen 66% of patients, with a mean percent reduction of tumor size of 50% with a very narrow confidence interval and a high precision. The first study was on pre-op octreotide use was done in 1988 by Barkan et al., which showed that 80% of pre-treated patients achieved mean 24-hour GH less than 4.6 and normal IGF-1 post-op, compared to only 31% of untreated patients with tumors of the same size operated by the same surgeon during the last 5 years. So how does preoperative treatment help exactly? It induces tumor shrinkage by causing perivascular and interstitial fibrosis. It brings the tumor into the accessible field. So even a less experienced neurosurgeon may be capable of successfully removing a tumor that has pre-shrunk, which may even obviate the need for referring the patient to a faraway specialized center relevant in a large country like ours. It may also convert the tumor from sparsely to densely granulated and thereby improve the outcome. These are the first few studies done on preoperative management. We can see that only 2 studies by Barkan and Kalo et al. Showed a significant difference between the pre-treated and the untreated controls. Quite disappointing incident, I think not, because these were retrospective and non-randomized studies. So after overcoming all the epidemiological flaws in design, a few prospective randomized clinical trials were designed. And it showed that in all the cases, except one, there was a dramatic improvement in the biochemical control rate that was seen in the short term, 3 to 4 months after surgery. So naturally the question comes, does the benefit extend to long term? Yes, it does. This meta-analysis by Fooner et al. Shows that for macroadenomas, twice as many patients were cured without additional treatment 6 to 12 months after the initial surgery in the pre-treatment group versus the direct surgery group. Another study done in invasive adenomas shows a 40% remission with the 2-step approach, that is using pre-op therapy compared to the direct surgery group. So, and even refining the patient selection further by choosing patients who can optimally respond may even improve the outcome. So what are the preoperative predictors of SRL response? Including a female gender, an older age, macroadenoma, densely granulated, and a T2 hypointense. All can further improve the SRL response. For example, this study by Heck et al. Shows that choosing patients who had a hypointense tumor on T2 weighted MRI, they had a better reduction in IGF-1 and GH levels compared to the other group. So T2 signal intensity can predict the biochemical outcome. Also, this another study even found a cutoff of relative signal intensity below which we can actually predict better biochemical outcome. This meta-analysis shows that another point, that there is a highly significant relationship between untreated surgical outcome and the SSA pre-treatment results, which basically means that they have suggested that in centers without optimal results, all patients with GH secreting pituitary adenoma should be treated with a long-acting SSA prior to surgical treatment. What are the other benefits of pre-op therapy? It can reduce the arterial stiffness, improve the endothelial function, reduce the soft tissue swelling, especially in the upper airways, induce better blood pressure control, all translating to decreased anesthesia complication rates and lower surgical risk, especially in patients who have severe cardiac and respiratory complications. This study by Herman et al. Shows that pre-op octreotide significantly reduce the tongue volume, reduce the respiratory disturbance index, and which can help in pre-op therapy, which can help as part of anesthesia. This another study shows that the aortic pulse wave velocity and the flow-mediated vasodilatation all improve with pre-op therapy, thereby reversing or decreasing the cardiac, vascular, and sleep complications in many patients with acromegaly. And this does not correlate with the change in GH and IGF-1 levels, which basically means that they have independent beneficial effects in the vasculature because these receptors are expressed on other areas too, including smooth muscle cells and as well as cardiac cells.
1 more minute is there.
Which led to the ASCE recommending that patients with severe cardiac and respiratory complications due to acromegaly could benefit from pre-op SRLs to reduce perioperative morbidity. And does pre-op therapy reduce resurgery? Yes, it does. The study shows that the patients who use pre-op therapy had a 1/4 requirement for reoperation or RT need compared to the untreated group. So, and I'll conclude by saying, consider pre-op therapy in macroadenomas with a high likelihood of SRL response, especially in centers with less than optimal surgical outcome, with severe cardiac or respiratory complications, and with no pressing need for urgent surgery like a mass effect. So I'll end by saying an ounce of prevention is worth a pound of cure. Prevent surgical failure, prevent persistent disease. Thank you.
So I would like to invite the opponent, that is Dr. Aviva from Calcutta, regarding the octreotide therapy before surgery, against the octreotide therapy before surgery. And subsequently, we will have a rebuttal from the previous presenter. Close that previous presentation.
The timer is
Good afternoon, respected teachers, my colleagues, and my worthy opponent. I am Dr. Aviva Awasthi, a third-year postdoctoral trainee in the Department of Endocrinology and Metabolism, Medical College, Calcutta. The topic which was given to us was use of octreotide preoperatively in patients with acromegaly. My worthy opponent did a really good job explaining how octreotide works in acromegaly. However, she did not state one important fact, which was the cost of therapy. Furthermore, the slides which she presented, she showed a very dismal rate of surgical cure, that which she pointed out was, I think, 20%, which I think is not true. And the third point was most of the studies which she quoted, I think none of them were after 2016. So coming to acromegaly, as you can see, this was the archetypal description in history of acromegalic patients. The annual incidence is around 0.2 to 1.9 per 100,000 patients, the prevalence being slightly higher. This is a rare disease. However, the cost of therapy in this disease is very, very high. So I would like to frame my argument into the following headings. So coming to the elephant in the room, what does the evidence say regarding preoperative octreotide therapy? And what does the cost-effective analysis show regarding the use of octreotide preoperatively in these patients? So as she already said, that surgery has likely a dismal outcome. However, I would like to say that is the standard of care. It offers a potential cure. It is a one-time cost if it is successful, and we know the disadvantages if present. Surgery for acromegaly, as we can see, from a paper from Vellore itself. Here we can see there is a wide variety ranging remission rates starting from around 30% going up to 80%. So yeah, that I think is not very true what she had quoted earlier. Now, coming to the post-operative outcomes, one might say that yes, we should give octreotide to those patients with a pituitary tumor to reduce the post-op complications. So coming to the Western data, here we can see the percentages of post-operative complications. And this is a paper from Vellore where we can see the post-operative complications. However, now I would like to point out one thing. For example, resection of a non-functioning pituitary adenoma, the side effects are higher post-operatively. Furthermore, a very common surgical procedure done by the neurosurgical departments, the burr-hole craniostomy, there you can see that the rate of meningitis was 0.5%. And here you can see that the rate of meningitis in the Vellore paper was also 0.5%. So I just wanted to point out that the post-surgical complications are very low as compared to the other pituitary tumors. Octreotide therapy prior to surgery has certain advantages, I do agree. That is, there is rapid disease control. There might be a tumor mass control. They have a higher short-term remission rates. However, it has been seen that the long-term remission rates, there was no benefit, and the cost involved, which was not discussed at all. A single dose of octreotide LAR 20 mg or 30 mg starts from around 18 to 35,000. You have to give it for at least 3 to 6 months pre-surgery. You can do the math there. So looking at the preoperative use of octreotide, what are the intraoperative complications? Yeah, it is said that if there is severe pharyngeal enlargement, or if there is a macroglossia present, there might be difficulty in intubation. However, it has also been seen that if you use a fiber optic flexible bronchoscopic intubation, the success rates are similar, if not better. Post-op complications, I have shown there is no difference between the two. Hospitals say it was seen there was no difference between the two groups. Short-term remission, yes, I do agree that the first study, that is the POTA study, that is the preoperative treatment with preoperative octreotide treatment or acromegaly, in the short term, they showed benefit. However, in the long-term remission, when they did the long-term trial, which was published in 2014, which she rightly pointed out, they showed no benefit. However, when they did meta-analysis, they said it showed a tendency towards benefit with SRL. However, there were further meta-analyses which showed there was no benefit. So why is there a short-term benefit, one might ask? So it has been seen that a hangover effect is seen with the SSA, even a single dose, 3 to 4 months after the surgery, which might persist. So that is why we have short-term remission rates, which are more significantly improved in preoperative cases as compared to surgery alone. Now, what does the evidence say? So when we look at the Endocrine Society guidelines from 2014, they suggest against the routine use of preoperative medical therapy, and they have given two very important indications for the same. The one would be severe pharyngeal thickness and severe OSA or high output cardiac failure. Now, I have already explained about severe pharyngeal thickness. However, if you look at the high output cardiac failure, the incidence of that in published series is less than 3%. So we aren't dealing with many patients there. We still have to look at the cost-effective analysis there as well. What does the AACE state? The AACE states that the positive effects of preoperative octreotide do not persist in the long term. Then we look at the consensus statement published in 2018. They have said that use medical therapy only in patients who have persistent disease despite surgery and those in whom surgery is not appropriate. Again, the Pituitary Society in 2020 came up with the update for acromegaly, and the status quo regarding preoperative use of octreotide was maintained. Again, there was a consensus guideline which was published in 2020. There they have said that they do not support a recommendation of preoperative SRL treatment, and there were no sustained outcomes in the long term which were seen. So coming to the meta-analysis, again, if we see here, as she had mentioned, the POTA long-term study, which I have marked in green, here we can see it is crossing unity. Therefore, there is no added benefit here. Overall, also, there is no added benefit. If you look at the post-operative complications, again, we can see there is no any benefit here. So coming to the health economics, as stated by the Johns Hopkins University, they apply economic theories of consumer, producer, and social choice in health economics and help promoting health for all. So when we look at the World Bank data for India, we have seen that because of the pandemic, our economy has suffered a lot, as we can see by these indices, which I have put on the screen. And sadly, even though we are making great advances in all fields in the country, the World Bank still categorizes us into a low and middle income country. Coming to the 2011 rural census guidelines, here I have put 3 states because 3 of the states I've lived in and 1 for obvious reasons.
1 more minute is done.
Yeah, thank you. Here we can see that the main member of the family earning less than 10,000 is around 85 to 95% in these states. Coming to the cost-effective analysis, which was done, it has been seen that 3 studies have favored surgery alone, whereas only 2 have favored preoperative octreotide prior to surgery. Now, if you look at where these studies were done, except for China, the other 4 were done in a high-income country. So coming back to the question where the room has also changed and the elephant has also changed, would you give it to a patient who can afford it? So what does the evidence show? And what does the cost-effective analysis show? I hope I have made my point really clear, and thank you very much.
So rebuttal, following that we'll have discussions.
Thank you, Avivar, for your very energetic and enthusiastic presentation. I would like to, since it's my job to prove you wrong, I'd like to dissect your statement slightly more. So one point you said was the cost. Yes, it may be difficult in my settings from St. John's, but I believe in Kolkata, it is available free for patients. So maybe you can take back your words. Second thing is that considering the cost-effective analysis, which you mentioned about, I agree there are no cost-effective analysis studies from India on pre-op therapy, but there are certainly 2 studies at least from the West, published recently, which have shown that pre-op SRL therapy definitely does not have a financial, does not affect the financial status of the patient and does not have a worse, does not, what do you say? Yeah, there was no monitored disadvantage to the patient even after pre-op therapy in both the cost-effective analysis done from the West. And third thing is that even when you consider post-op therapy, say post-op, the first line of management in a patient who has not improved after surgery is still SRLs. So whether you give it pre-op or post-op, the cost remains the same. And if you give it pre-op, probably you can prevent the person's disease and avoid the post-op therapy. So again, the cost, you can still consider it. And fourthly, about the cost is that when you consider the cost of a surgery, then a resurgery, then a morbidity, probably you can, that will outweigh the benefits of the, that will outweigh the problem of the cost. So second thing is that you mentioned about the long-term, whether the long-term remission does not improve. So this also I'd like to disagree, saying that 3 studies showed that long-term remission improved, does not improve, and 2 studies showed that long-term remission improves. So that's almost 50-50. So you can take the glass as being half empty or half full and give the patient the benefit of the doubt. And third thing is that about long-term remission, we can see that people who have done analysis on this have shown that in the studies that there is not many patients who have undergone, who have been, there are not many studies which have studied the long-term remission. So there are hardly less than 100 patients who have been followed up to long-term. So if we can definitely call for larger RCTs, which have included a lot more patients, maybe we can we can get the long-term remission outcomes also. Third thing is the study from Pune et al. That you mentioned, in which the p-value was only 0.08. I agree so, but then the p-value of 0.04 or 0.08 does not matter to individual patient, and better give the patient a fair chance and give the patient benefit of the doubt and give the patient a fair chance at surgical cure. Then third thing, another thing you mentioned was about the ESI guidelines. Yes, the ESI guidelines 2014 said that pre-op therapy should not be given regularly. But in the 2021, the latest one published, they have also mentioned the primary study on lanreotide. And since lanreotide and octreotide are almost comparable, so we can again say that there is still a gray area, which is exactly why we're debating on it. So we can either go this way or that way. So
okay, Doctor, time is up.
Yes.
Doctor, I would like to comment from Dr. Madhukar sir. Then after that, I will answer.
Congratulations to both the speakers. They have actually debated very nicely, and the topics for debates are always gray areas. So that's where the debate actually happens. And obviously, with regards to the area which we are discussing about the preoperative use, so definitely there is a case for use in certain aspects as presented by the first speaker. And there is also an area where it cannot be, there can be a, cannot be a blanket generalization. So there are only a couple of prospective studies, agreed, and there are some retrospective studies. In the prospective studies, a section of the patients, especially those tumors with regards to cavernous sinus invasion, they have shown significantly higher remission rates. So that point is very well taken. And yes, the other aspect with regards to long-term remission, the data for the jury is still out with no clear-cut answers as to, as of now, the evidence does not show clear-cut long-term remission rates. So these are some of the points, Dr. Sridhar. So you'd like to take this forward.
So again, similar to diabetes, it is a personalized approach, acromegaly. We cannot pinpoint a rule for all acromegaly. So we have to choose a patients, right patients for right therapy. Obviously, preoperative octreotide definitely is having a role, but in selected subgroup of people, like people with severe cardiomyopathy, or maybe obstructive sleep apnea, or some patients, they may refuse time, or they may want some time period to undergo surgery or mentally fit. So in such patients, we can give, and maybe the paracavernous extensions, NASP grading 2 or more. So the severe extensions, so complete removal if not possible in such cases. So in selected subgroup of acromegaly, and particularly in macroadenoma, we may opt for this octreotide therapy. As already discussed by the opponent, that there is no long-term remissions data. So whatever data is there up to 5 years, and the long-term studies are not there. So we may not be able to recommend in all patients the preoperative this octreotide therapy for all patients. So in selected subgroup patients, again, definitely it is more having a role. And as far as 2018 and 2020, the recent updates are consensus statements. It is not for all patients for preoperative octreotide therapy. That is the recent thing, and we may have more consensus or more guidelines in futures. So with that, I want to have the opinions, questions, or any comments or discussions. Sriram sir, Vijay sir, anything you want to?
Yeah, let me first congratulate both the debaters, right? They did a really good job. But the thing here is probably I would like to know, I don't want to debate that, but like what are the definitive indications for initiating somatostatin analogs preoperative? So like someone who has pharyngeal wall thickening, okay, though fiber optic intubation is there, even then they will have postoperative complications, maintaining the tongue falling back and obstructing the airways a challenge even once we take out the tube. So they could be one of the group where we can definitely consider. In fact, like we had a patient who came with acromegaly and actually cervical cord compression because of the soft tissue thickening, not because of the bony thickening. So that was the one patient who definitely benefited with short-acting octreotide preoperatively. And of course, we could not continue again for a long term because of the financial issues. So maybe any other definitive indications, Lavanya, I would like to give?
I think that MRI findings, some predictors, T2 hypointense, densely granulated,
yeah,
and so maybe at the paracellular extension or arrhythmias or any cardiomyopathy in preoperative. Maybe 6 month period, it's I think good enough for to stabilize the patients. Maybe
yeah, but T2 signal intensity, that advantage is that may just tell you about the response rate. But definitely, when you look at the numbers, what we encountered in the initial studies, it was pretty higher. The long-term response to somatostatin analogs were quoted as like almost 70%. But as the more and more data came, finally the long-term remission rates are only around 30%. So definitely they will require surgery. So maybe just only for response-based, we should not consider. Where definitely there is a medical benefit, where we can improve the perioperative outcome, those should be the patient where definitely we should consider the medical therapy preoperatively is what I would believe.
Can we have a show of hands? How many say 4 acromegaly preoperatively? Very few. Against? More. So selective use is the message.
Yeah. So both speakers, they have done the well. Hope the concept of the debate is to understand our personalized approach, not for we cannot pinpoint it all the treatment for all the people. So with that, I am concluding this debate. Thank you for the opportunity. Thank you once again.
Thank you. Thank you.
Once again, thank you, Dr. Lavanya and Dr. Avivor, and moderators for that session, Dr. Sridhar sir and Dr. Madhukar Mithil sir. We have 2 eminent endocrinologists, one from the far north in Punjab and the other from the southern state of Kerala, joining us for this masterclass program. As trainees, some of us would have wondered, at least at some point in life, what do I do and where do I go after my training? It is my pleasure to invite to the next session Dr. Philip Finney sir from Believers Medical College, Tiruvalla, and Dr. Jubin Jagan Jacob from CMC, Ludhiana. Both completed their training in endocrinology from Vellore around the same time, and they have moved on. They will engage us in an exciting duologue on how to pursue academics anywhere. Over to Dr. Philip Finney and Dr. Jubin.
Yeah, so I think Dr. Philip will take us through the slides that we had planned to show. But I think it is just talk about how to pursue academics wherever you are. Most of you may not go to I didn't go to an endocrine center when after I passed, I was asked to be a professor of medicine for all but there is still a lot of things that you can do. Many of you go to private practice. Let's hear from Finney.
Good evening to all of you. It's my pleasure to be with you all this evening. I know it's a topic we've been doing hardcore endocrine discussions, right? So I want you to just sit back, relax, listen to something more on perspectives, philosophies, and probably a little bit, we're going to share a little bit of our life journey with you. It's about 15 years since both of us passed out, finished our endocrine training, and thereafter we have had some similarities, at the same time, quite a bit of differences in the way our careers went. I want to share a little bit of that. So we have called this Pursuing Academics Following Our Training Period. Next. Are you moving the slides there? Or? So the first quiz, who is this gentleman? Anybody? You're all experts in quizzes and MCQs, I'm sure, right? Is it visible at the back? Yes? Anybody, any guess quickly? Clue is non-endocrine person, nothing to do with endocrinology, okay? But a world famous person, Edward Jenner, right? He's a person who founded cowpox vaccination, right? And he made his astounding research from observations about how things were happening, and he had a keen sense of observation, all right? And this is his original paper written by Edward Jenner about the cowpox and how he had the eureka moment. So my academic journey, I did all my training at Vellore, and in between my MBBS and MD, I worked for 2 years in Jharkhand and Assam, among some tribal and rural hospitals. Finished my MD, I had a period to think through what I want to do with specialization. I had freedom to decide. I was invited to stay on here in Vellore, but I thought I must just get out, think clearly what I want to do, and in fact, with specialty. So I worked for 2 years in Dindigul, near district, in a place called Christian Fellowship Hospital, Odanjitram, one of the largest mission hospitals in Tamil Nadu, about 1,500 bed, 1,500 OP, very busy hospital. And thereafter, after I finished my endocrine training, I was clear I wanted to work in the northern part of India and in a remote area. And so I worked for 1 year in the border of Assam and Tripura in a place called Makunda Leprosy Hospital and General Hospital in Assam, southern Assam. Learned a lot of Bengali there, which was very helpful later on when I came back to Vellore. And also, I also worked in Bihar on the Indo-Nepal border in a town called Raxaul, which is right on the border. And thereafter, while I was finishing my stint in Bihar, we had a chance to go to the UK and worked in an NHS hospital in Essex called the Basildon NHS Trust Hospital. And after that, we came back to Kerala due to children's educational needs and stuff like that. And for the last 5 years, I'm in Kerala. So I want to just ask, Jubin, you want to share your journey a little bit?
Exactly, very similar. Only thing that between my MBBS and MD, I worked in Eastern Uttar Pradesh, again, a small mission hospital. After MD, I worked in the same place where Philip worked as post endocrinology as an MD doctor. Following my MD for 3 years, I worked in the same hospital in North Bihar. After that, I went to Ludhiana and CMC Ludhiana. There I wanted to do endocrinology, but they said, we don't have faculty in the Department of Medicine. You have to, fortunately, they didn't force me to see medical patients, though I continued as a faculty in the Department of Medicine. I did focus my work on endocrinology. I didn't have to do medical work. I did a few years in UK, very similar to what Philip did. And now, after so many years, I have a Department of Endocrinology only for the last couple of years. So very, very similar to what Philip has been doing.
So when I was an endocrine trainee here, there was a lot of busy work in CMC. If you walk through the OPs here, you would have seen how patients, we were just overwhelmed with the clinical work. Research was not something at the top of our agenda. And so the first original article which I wrote was published in the Australian New Zealand Journal of Surgery. It was on the medullary carcinoma series from CMC, over 20-year experience. But myself and Jim Phillip, one of my friends, we both wrote this paper, but it sat in cold storage for nearly a year. We needed the help of Jubin to help me get it published, basically because the effort involved to write up a paper and the struggles. But I think this is one thing which really set the ball rolling when we got our first paper published. And the next one, with Jubin and me, we published nearly 3 or 4 papers during our training period. The next one. This is our first paper of oncogenic osteomelia, one of my first case reports from CMC in the 2004, 2005, published again, both of us together. But that's when we realized this thing, that teamwork is the key to success in good research output. And I think that's what I learned, that when we collaborate, not all of us are probably excellent researchers. Not all of us are good in statistics. Some of us are excellent clinicians, perhaps, no? But if we team up, I think we can get good research output. And that's what I've been learning in the last 10, 15 years. We must hold hands together, and if you want to get good output. So
I think all of you should get together. That's the only way you are going to get. Some people are good at writing. Some people are good at planning. Some people are good at getting the money for the research. Some people are good at statistics. But there are very few people who are good at all these things. And if you're going to plan to do something all on your own, it's not going to work. So I think that is the most important message that we got after I came here and I worked here for 3 years, that without all of these people together, you will not get good. First of all, you'll not do good research. If you do, I mean, I've seen good research getting published in bad journals because they've written up so poorly. And then very average research getting published in good journals because it is written up well. So writing is also a skill, but this is a skill that all of you may not have. So if you collaborate with people, if you work with other people, you might find the right person to write for you. You might find someone who's very good at statistics. I think that is the take-home message, that it has to be as part of a team. You will not be good at all the things that you require for getting a good paper across, especially good research across.
So this is the place we both have worked in. It's a place called Roxol. Do you know which English word this comes from? If you ask a person, Yasin Bhatkal, the chief of the Indian Mujahideen, was caught in our town when I was working there. So it's not a notorious place on the border, a lot of smuggling. And you know what this place Roxol comes from? Which word in English? Rascal, the land of the rascals. Okay, that's how it comes from. So, okay, so not a very good thing. That's a place where everything not so good happens in that particular town. But that's where many years ago, some Scottish missionaries started this mission hospital, which is a very thriving and probably the only good quality healthcare facility for nearly for 5 million people in that region. So this is the Duncan Hospital, named after the doctor who started this hospital. And this is the hospital new building, which was built about 10 years ago, where we worked. We had an excellent ICU, good secondary level care with all the basic specialties, but I was the only physician as well. So I had to work as a physician and as an endocrinology. Endocrinology only 20% work. 80% of my work was general medicine when I was working there. But we had excellent work, and 8 years my role was as a dual role, and routine OP plus the ward work every second day on call. If I was on call as a physician with my family physician and me taking calls. So you can understand how overwhelming a clinical work can be. Research definitely nowhere in my mind. And I was not particularly good with numbers. I thought this may not be what is good for me.
I think this is a situation many of us may have to face. Currently, most of us endocrinologists are practicing purely as endocrinologists. But if you go to countries like Australia and UK, you cannot be just an endocrinologist. You have to do some amount of general medicines, because we'll find slowly, you will find that hospitals cannot afford just an endocrinologist. A smaller hospital may not be able to make income from just an endocrinologist. So this is, I think, a thought process which will have to come into trainees, whether you completely give up on your general medicine, because endocrinology is a purely, most of it is outpatient. So you can continue doing your outpatient, but do some general medicine, which will get you income. So this is, I think, a thought that when lot of endocrinologists start passing out, it may become more and more difficult for us to practice pure endocrinology. So if you want to have a much steadier income, you want to work in a hospital and you want to create income for that hospital, you might have to do general medicine, especially inpatient general medicine. And that's how it is in most hospitals in the UK. You cannot be a pure endocrinologist. You have to do out of hours general medicine work to make up your salary. So I think this is again some thought process we've been getting, where in bigger towns now we find that there are so many endocrinologists that newer endocrinologists are getting paid less than a physician. Why should it be? We are all qualified as a physician. So I think we should start thinking of ourselves as dually qualified. We have done general medicine. We should be able to handle emergencies. We should be able to handle that part as well.
Each of our institutions has got heritage. We had a gentleman called Dr. Sanders from Bristol in UK who worked here in the 70s. He is the first person to do the randomized trial of anti-tetanus serum versus the standard treatment for tetanus in the 70s. And he published his paper in the Lancet, sitting in the same hospital where I worked in the 1970s. Can you imagine? Due to meticulous documentation and publication of an RCT way back. So it doesn't matter fully on your circumstances whether you want to do research. I think it depends on that questioning mind. The passion to find answers to questions is what will drive you to produce research. To produce an Lancet paper in the 70s and published in 77 was no mean task. And this is again a collaborative work of him and his team who worked in the same hospital where we worked. The first thing which I want to share with you 4 experiences over the next 5 to 10 minutes. And in that, I want to say my first 2 experiences have nothing to do with endocrinology. I finished endocrine from Velo, got back. I thought I will see a lot of acromegalies, primary hyperpara, PCOS. Sorry, nothing, none of that sort. I was seeing I saw 1 acro per year. Probably that too, I was not even able to confirm the test immediately. They took a long time. But the problems there were very different. And that's what I want to sort of say. The first thing which struck me is most of my time was in the ICU managing organophosphorus poisonings, organochloride, aluminum phosphide, and these were the things which occupied. But then I noticed that these numbers only seem to be, wherever you provide good service, I think more patients will come. So we became to be known as the poison hospital. Poison ho jayega, idhar le jaiye, Duncan. That's the sort of the standard word in the community. And so we started looking at our numbers. I fortunately had an Australian lady who's a nurse practitioner who came and worked with me. She said, let's just look at what are the numbers. And she started documenting. 2007, we finished our DNB and joined. See how the numbers of admissions shot up. The number of organophosphorus poisonings and organochloride and the likes. We saw a steep rise over the 5 years we were there. And then with this data, we said there's no psychiatrist in our whole district for handling all these problems. And we said, okay, OP poisoning, you manage it, you feel good, but the next patient comes immediately. So, what are you doing to change the scenario? Only keep on treating more and more OP, putting them on ventilator, treating the intermediate syndrome. Is that all? Or something more? So that's when this thought came, maybe we should investigate why are these people attempting suicide? Is it all farmer suicide due to money problems? Actually, in our study, we found not one of them actually attempted suicide due to monetary reasons. Most of them were conflicts, various reasons, young girls getting married at 15 years, the interpersonal issues and conflicts. And this is a paper which we published in one of the open access journals about family conflict being the major influence in suicide in northern Bihar. This is known, but nobody was doing anything about it. And soon we formed a team for suicide prevention problems and identifying how high the rates of depression are. And we formed a team called Roshni is Light, right? We wanted to provide light to the community. And so this work slowly started becoming more public health oriented. And we formed a team who will go and identify the alcoholic, the families who are wives getting beaten up and things like that, and try to counsel them before they attempt suicide, which was very, very common. And slowly we had community outreach work with our PSM department. And that is Dr. Ravi from Andhra, who's our first psychiatrist in that district. After many years, and now for 3 districts, he's probably the only psychiatrist there, but he's doing human service. And so through this, it doesn't matter if I'm not able to practice endocrine work, but we were able to make a small dent in the community mental health issues.
So I think, again, the take-home message here is you may not find all these things that you discussed today. You may not find acromegalics, you may not find Cushing's disease in the places you're working, but you will find more than enough patients to see. Dr. Philip saw suicides, he saw other things that he was interested in, but in Ludhiana, there was, I didn't have to worry about suicides, I didn't have to worry about ICU care, but then I started seeing patients which nobody else wanted to see. One electrolyte imbalance that nobody else in the hospital wanted to deal with was hyponatremia. So I spent a lot of time looking at hyponatremia and looking at better ways in managing hyponatremia, though I have not made any presentations. But I think there are areas where because our training is such, we can do much better than what previously people used to provide. So I'm sure there'll be many other areas where this endocrine training that you have will help you bring solutions to other problems, may not be pure endocrine, but other medical problems.
I think for Dr. Seshadri, who was my teacher, used to tell me, first you be a good physician, then only I will even think about training you in endocrinology. That's what his emphasis was. So I think if you're good physicians, we will do well in whichever place you are. So the next thing which I never wanted to get involved in was snake bites. And I'm not very particularly bold when I see snakes. But in Northern India, we have, in my hospital alone, we had more than 500 admissions for snake bite. And all of them were either cobras or krates. That is the feeling we had. But then when we had these patients, actually that patient brought us a live cobra, by the way. He brought it in a sack, and then we had to handle how to handle the cobra. That is a challenge we had. And most people told krates, krate. They thought it was a crate, but it was all evening bites. And when we actually collected the specimens and we got the inputs from some of our herpetology friends in Hooghly in West Bengal and Vishal and others, they told us actually we found very low mortality from crate bite. And we were wondering why. Actually, when we collected specimens of snakes, we found out that they were not krates. They were actually the wolf snakes, which is a non-poisonous snake. And people were mistaking the identity. And this particular information culminated in a paper which we published called Human Snake and Environmental Factors in Human Snake Conflict in North Bihar. I had a Nagaland junior doctor, Vishal Santra from the Foundation for Wildlife Conservationists, and we published a paper. So it's things which I've never got involved in. And my Australian colleague, Lois, who was working with me, was petrified of snakes, but soon her room became a museum of snakes. And whenever students used to come, we used to show them all the types. We became experts on snakes in that area. Never I imagined that when I finished endocrine, I'm going to be a snake doctor. Many people used to call us snake doctors. Anyway, that's a different matter. But finally, the best part is this work which we did and published was noted by the Oxford University, and we were invited to the UK, and we presented our work at Oxford University about how we can prevent snake bites. Ultimately, many people came late. They died before they even reached the hospital. We were able to present it at Oxford, and the WHO included our work. And now on page 10 and 11 of the Southeast Asian guidelines, you will find the work from Duncan Hospital, which is being spread across Southeast Asia to reduce snake bites. Simple things like carrying a flashlight, carrying a stick with you to prevent snake bite among the farmers community. These things really, I think, are going to make a difference in reducing the morbidity and mortality of snake bites. When it is nice to treat, but if you can prevent, even better. So this is something which was very gratifying, which happened in the non-endocrine side. So this actually took a lot of my energy and time, but it was not alone. It was a team which helped us. That's so the need-based research can produce big impact and transformation in changing lives of people. Wherever you are, ultimately, our research sometimes can be driven by other factors. It may be driven by needs to improve my CV. It may be, I thought I must produce when I was in CMC. I used to go to this conference in Chennai. I had a Belgian ICU doctor who presented work. I said, okay, Esteban, that is his name. I don't remember, I can never forget. He has only 2,500 publications. Oh my goodness. I just shot, so I'm never going to compete, but whatever little research I do should make a difference in the lives of people. And that is something I think which all of us should aspire. Some of you are going to be busy practitioners, but can you do 1 or 2 projects which will make a difference and change lives of people. I think that should be the focus of research, and there should be some purpose behind research. I think that will be lovely that were to happen. So you want to say something, or shall I just go on? So endocrinology research. While I was training here, one of the problems we faced in CMC was a lot of admissions from hypokalemic periodic paralysis. Patients used to be referred from various departments, neurology, medicine, to us, and we used to work up these patients. And when I reached Roxol in 2008, I found that I was treating nearly 20 to 25 patients per year, and many of them were repeat admissions. Within 2 months, they'll come back again and again. So they were just given IV potassium, sent home. Again, they get back. So nobody was being worked up in detail for why they're getting hypokalemic paralysis. And so a workup was not being done. And fortunately, when I went through it, one of my predecessors in the Bihar, Dr. Thomas from Ludhiana, had already published a paper saying that among acute areflexic quadriparesis in this region of South Nepal and North Bihar, hypokalemic periodic paralysis is the commonest cause. And he said it's something like 40% of them. So this is a paper again published in a low resource setting. That's what I want to say. It doesn't matter. Your resource setting doesn't matter if you have a questioning mind.
So I worked in this hospital before Philip, and probably after this paper was published. Every year we used to get, I don't know, 20, 25 seems to be an undercount. I used to think it was more like 70, 80, 90. Almost every OPD day in the summers, we used to have 2 or 3 patients. And I mean, the treatment was give them potassium, send them home. I never thought of that they could have an endocrine etiology. I should work them up. My only thing was potassium was low, give potassium, send them home, give them some oral potassium solutions. They'll take it for a few months and they'll again come back. They'll stay in the hospital for 2 days. So I had no idea how to work up this patient, but Philip had gone after his endocrine training. So he was a little more better prepared for this.
And when I was training here, Dr. Narsingh Rao, who was our first DNB trainee from CMC Vellore, he had done his thesis on hypokalemic paralysis. And this is published in the National Medical Journal of India in 2006. And we were witness to the study, what was happening here. And Dr. Nihal and Dr. Seshadri published this paper, and they found that nearly majority of them had secondary causes for a hypokalemic periodic paralysis, of which 50% were due to renal tubular dysfunction, 50% were due to Corns, and a small amount of Gitelman and Bartter syndrome. But that was a breakup. So with this knowledge, when I landed up in Roxol, you sometimes, the universe will conspire again. You train in this thing and you go there and you see the same problem. I never anticipated it, but I was like perfectly equipped to study this, and the lab had improved significantly from the time Jubin had already been working as a physician when I went there. So we were able to design a study there. So we formed a small study. We said, let us find the underlying causes for hypokalemic paralysis in a patient presenting to a secondary care center in rural North India. And can we work up a simple algorithm? And I used to get phone calls from my sister hospitals in Orissa and other places saying, how do you manage this? Give potassium, then they're coming back again after some time. So we said, let's develop a simpler algorithm for a secondary and primary care hospital. So we analyzed data. We collected it prospectively over 84 patients over a 3-year period from Feb 2009 to Jan 2012. And we had a very clear questionnaire incorporating all that we had learned as trainees in endocrinology. And the interesting thing is, compared to the data from SGPGI Lucknow and from CMC Vellore, we had a huge male predominance. And that effectively shows that more men seek health-seeking behavior is better. In our study, which is probably patients coming more first presentation, not a referred cases, we found that the male gender divide is very little. And our mean age was much lesser than the studies published from secondary care, tertiary care centers in India. We also demonstrated first time in literature that actually all our cases were all occurring in the summer months, when probably people are probably drinking a lot of sugary drinks and sharbat, as we call it. And that probably is only the trigger. Maybe their potassiums are already on the brink. On top of it, you drink a heavy load of glucose, as we know, will be leading only trigger the problem. Seasonal variation, we found, just put in a different pie chart. We found 87% of them came in the hot season and very few came in the cold season. And this was not demonstrated in the tertiary care studies, obviously, because these are all referred patients coming. And the key findings, and our study, when it was published, was the largest series in the world to the best of our knowledge. And of course, the largest series in India, and where they showed that 80% of our patients had a definitive underlying secondary cause. Majority of them came with us a potassium less than 2, and we had 2-3 patients who went into ventricular arrhythmias, and we could revert them, cardiovert them. And majority were young, all of them present in summer months. And Dr. Seshadri collaborated with us, sitting here in Vellore, and our work there. We wrote the paper, published it together, and it was such a joy to see the paper come up. And it's only in 2020, 19 and 20 from Madras Medical College. Now we have a larger case series. We had 84 patients here from MMC. We have now a paper of 230 patients with HPP. They've got a bigger series, but it's a slightly different way the study is done. So this is a joy to see this study published in the Royal Society of Journals in the Tropical Doctor. And then we developed a simple algorithm how we can approach a patient with hypokalemic paralysis in a smallest hospital. Not all big medical college hospitals patients come to, but in a small hospital using an ABG, what will be a simple way to classify it, how to come to a diagnosis and treat them effectively to prevent recurrent. In fact, once we put them on long-term pot chlor and soda bicarb, many of our RTA patients didn't have recurrent episodes. Some of our cons patients couldn't afford surgery. We put them on spironolactone. They were doing very well, never came back for a repeat visit. So finally, I want to close with the next thing, which is well known among us. We say that 90% of Cushing's is due to iatrogenic causes. We know it, right? It's well known. But when I search my Google Scholar and Google literature, there is no series on this. We only have multiple case reports and simple clinical knowledge that steroids are abused. And we know it all in our heads, but there's no documentation. So I found a lot of people in a 6-month period. One of my family medicine doctors wanted to study how common is glucocorticoid misuse in Bihar, in a rural and semi-urban community. And we found 22 patients, of which 68% came with iatrogenic syndrome, but many were coming to the casualty with hypoadrenal crisis. When we measured the cortisols before giving them hydrocort, we found hypoadrenal crisis was very, very common. And we found a lot of them having all the ravages of steroid misuse. So this was published again in the British Royal Society Medicine Journal about misuse. And we asked Dr. Nihal to oversee the write-up just to help us, because when we were writing up to iron out all the flaws in the study, and this was published again in 2012. This led us to say, okay, this is only a hospital study. It may be incomplete. Shall we look at the study from a community base? And we went to the communities and we did a cluster sampling method. Every third household, we did a survey of what all medications they use for various illnesses. And to our surprise, this is also published in the Tropical Doctor from one of our community physicians. And this study showed that very scary thing. It showed that nearly 70 to 80% of people are misusing glucocorticoids for some febrile illness or rheumatological problem. And this study has thereafter been cited many times. And then we said it's not enough to publish these journals and put it into our medical libraries. We must write in the lay press. So the Telegraph paper from West Bengal picked up this article when we started writing about it. And this is saying doc glare on unregulated steroid use. It's well known, but I think all of us here as endocrinologists can be do advocacy. Talk about these ills. If we don't talk about it, the regulators are never going to do anything. It may be a drop in the ocean, but every drop matters. I think this is what we felt really will make an impact. Otherwise, as endocrinologists, we are being pressed on every front, right, in various ways. But can we be people who speak up and write in lay press? Dr. Jabbar recently wrote in the Vanita magazine I was reading, these are ways by which we disseminate our available knowledge. I think that's very important, for that we should find every forum to write. The knowledge which we have must be disseminated. And this is in the electron. Nowadays, this generation of students and doctors, I don't think read the newspapers. They only read social media. So we must also get an electronic platform. So this is a steroid overuse behind chronic disease in Bihar town from the electronic media. And then I said, when I got back to Kerala, I said, is this a problem in Kerala? I seem to be getting anecdotal evidence from patients talking to them that they're all abusing steroids. So I said, how much is the problem? If it's 33% of people are taking steroids without a good reason. In Kerala, we did a study in our pharmacies. So one of our medical students got an ICMR project to do. So we said, let's send her to investigate the pharmacies, how they sell glucocorticoids, how much glucocorticoids they sell. And this is published in the Indian Journal of Endocrinology, our own journal, which we have. And this showed that there is a big problem where a lot of pharmacies are indiscriminately giving steroids. And this is the last paper I want to close with. This is a study done in Koni block. We had a elective student who came with us who wanted to do a good study. We said, let's look at the rural community of Koni in Pathanamthitta district in Kerala. How much so she went on a house-to-house survey of 1,400 households. And she interviewed everybody and looked at how many of them abuse steroids. Even then, it's much smaller than in Bihar, but it's definitely a problem. And hopefully in the next issue of IJEM, you'll see the original paper published. It's been accepted and we are hoping to get that. And ultimately, this should lead to changing things. And I think as we have to be physician advocates for change in society. And I think public health is something we all like bench work, but I think public health is the way forward. In one way, as endocrinologists, we can build. So all our work over the last 10 years, we have collated and then published it in the National Medical Journal of India, NMGI, saying building research capacity in resource poor setting are triumphs and challenges. Lois, my colleague, and myself, she's excellent in doing number crunching and statistics and all. So she is very good in writing. I provide the ideas, the thoughts. And together, when we came together, we could get a paper in the NMJI. And I'm very happy. This is one of our best papers, most cited papers as well, about where we share our experience of the struggles of doing research in resource poor settings. So finally, I want to close with this closing slide. This is from Robert Frost. We know the ones about going miles to go before I sleep. But this is another path which is always thought-provoking. In a road, there are two roads. In a wood which diverged. I took the one less traveled by. And I think it makes all the difference. And I'm sure all of you can sometimes consider taking the less traveled road. It may not be immediately rewarding, but the rewards are much more beyond what you want. So thank you very much for your patient listening.
So I think one of the take-home messages that the Endocrine Society is adopting from Dr. Philip's talk is I think we should now get more proactive about steroid stewardship. We have seen infectious disease doctors talking about antibiotic stewardship. That means in every hospital, there is an infectious disease. There is a control unit that decides that you are inappropriately using antibiotics. I think you should now go back to your hospital and tell your medical superintendent, we want to make a steroid stewardship council. We want to see why patients are being prescribed steroids in the hospital. If they are being prescribed steroids, is it at the right dose? Is it for the right duration? Have they been given the right kind of knowledge? Are there sugars? Their bone health, has this been looked up? So I think as endocrinologists, you could go back to your hospitals and decide that you want to be the stewards of steroid use, at least in the hospital. I don't think we'll be able to do it for the community for now, but at least in the hospital, I think in each of our hospitals, the same way that infectious disease people control antibiotic usage, I think we should be controlling steroid usage as well. So thank you, and thank you, Thomas, for giving us the opportunity to waste your time.
Thank you, Vinny, and thank you, Jubin. And I'm happy to say that we all did our training together. We used to gossip together. We used to crib together. And we used to have some outings together. And Dr. Jubin is the executive editor of IJM. And quality articles and quality reviews are always welcome. Am I right?
Yes, please quality articles, whatever you're doing as your thesis, please consider IJM as your home for your thesis. I mean, if it is very, very good, send it to Nature, but then afterwards send it to IJM when they refuse it. And please, when you do and you've reviewed a lot of literature and you think you can write a good review on that, please send us the review also.
Thank you, Dr. Philip Finney and Dr. Jubin. That has been an astounding session. I think we will break for tea right now and we can assemble back in 10 minutes. Thank you. Divya Shruti, Dr. Prasoon, Dr. Karthik, and Dr. Shamir Bashir.
Good evening, everyone. My dear students, senior members, Dr. Thomas, Dr. Nisha, colleagues. I'm extremely happy to sit in the chair of a student with giants in the field of endocrinology. First of all, I should thank Dr. Thomas, Dr. Nihal and their team for the wonderful opportunity and nice arrangements you made. See, I think you might have heard a lot of discussion, both academic, spiritual, practical. Okay, I think you are in a sleepy mood, right? You want to go and sleep now? You have option A, B, C. Okay, anyway, we'll finish as soon as possible. So my student will be presenting a case for you. And if you want to ask any questions, you can. And at the end, we'll have a fruitful discussion also. Over to Dr. Sorry. Before that, Sir Niranjan, sir. Good evening, sir.
Good evening. Good evening.
Good evening, sir.
Thanks to the entire organizing team. Am I audible?
Yes, sir.
Thanks to the entire organizing team, including Professor Thomas Paul and Professor Nitin Kapoor for inviting me, and apologies that I'm joining virtually. I should have made it physically, but next time it will be with the COVID situation improving. And thanks also to my co-chair, Dr. Jabbar. I think we can straight go into business now.
Okay, over to Dr. Sandra for the presentation.
Respected teachers and dear colleagues, so I am presenting a case of Mr. X. He's a 41-year-old male hailing from Kasaragod. He worked as an electrician in Gulf. He returned back 2 years back, and his presenting complaints were progressive enlargement of hands and feet for past 8 years and uncontrolled plasma glucose values for past 4 years, headache and blurring of vision for past 1 year. His history of presenting illness in detailing, patient started noticing progressive enlargement of his hands in the form of tightening of his marriage ring, and he had to change the size of the wedding ring thrice during the past 8 years. He also has noticed the enlargement of his feet. In Gulf, he had to change the size of his shoe from 9 to 10 size over the last 5 years. And also when he returned back 2 years back, his relatives have noticed changes in his facial appearance, relative coarsening, and also increase in the size of his nose. And they also noticed a change in his voice, which was more deepened than earlier. And he complains increased sweating of body. That is, even after a cold shower, he used to get increased sweating of his palms and sometimes his whole body. He was detected to have diabetes mellitus 4 years back when he developed multiple skin lesions over his groin, and his plasma glucose value at that time, he remembers to be around 200 to 250 milligram per deciliter. He was started on oral hypoglycemic agent, which he took for 1 year, and with it was controlled. But after 1 year, his plasma glucose values were very high and not controlled with increased dose of this oral agent, and he was started on insulin. Over last 3 years, his insulin dose was gradually increased by the treating physician, and now his insulin requirement is around 120 units per day. But he does not give history of hospital admissions. There is no history of diabetic ketoacidosis or no history of hypoglycemia. For past 1 year, he noticed he is used to getting recurrent episodes of headache, which is intermittent dull aching, hollow cranial headache, which lasts for around 20 to 30 minutes and resolves spontaneously. And all these episodes are not associated with loss of consciousness, seizures, double vision, or vomiting. He also noticed blurring of vision for past 8 months. He has difficulty in seeing vehicles which is coming from the right side of the road while crossing, as well as he is telling that he bumps to objects while walking, bump to doors and all. And also he gave history of snoring, and he also noticed daytime somnolence. And there is one episode of altered sensorium and vomiting 5 months back following a febrile episode for which he was admitted in a nearby hospital. He tells that he was given IV fluids and was told to have low sodium value. He remembers it to be around 120 milliequivalents per liter. And he was advised to take oral salted feeds on discharge. He also gave 2 episodes of likely symptoms associated with fever after that. And with these symptoms, he consulted a nearby physician. And because he had recurrent episodes of fatigability during febrile episodes, he was further evaluated and he was told to have hyponatremia, and an imaging was done which showed some mass. But he doesn't give history of cold intolerance or constipation. He gives a history of loss of libido for past 2 years, but there is no history of reduced frequency of shaving or loss of axillary or pubic hair. And there is no history of hypertension, dyslipidemia, no history of chest pain, palpitation, breathlessness, no swelling of feet, no history of fractures, renal stones, swelling over neck, and there is no history of blood in stools, no history of proximal muscle weakness, and there is no history of flushing, diarrhea, wheezing episodes, and no history of cough, breathlessness, or hemoptysis. And also he doesn't notice any skin lesions or any facial or skeletal deformity problems. And he doesn't have joint pains. So he was evaluated for the symptoms here in CMC Vellore and was told to have an intracranial mass for which surgery was advised after doing some blood investigations also. And he underwent surgery in November 2021 through a transnasal route that he remembers and that he was told. And he had an ICU stay of around 2 days, but there was no complications after the surgery. There was no increased urine output or increased thirst or no episodes of high or low sodium values in the post-operative period that he could remember. And after the surgery, he was started on he was told that it was oral steroids, and he was also started on thyroxine tablets. And he also remembered that he was given a drug which he used to take twice weekly. And he's on these 3 drugs for past 6 months, apart from insulin and metformin. And after the surgery, for next 2 months, he could appreciate the improvement in his symptoms. His headache reduced, there was no sweating, his vision improved slightly, and the requirement of his insulin also came down in the following 2 months. But again, 3 months back, he again started getting these visual symptoms as well as headache, and for which he was currently, he recently consulted here again, and some blood investigations as well as repeat imaging was done, and he was told that he had a residual lesion, and for further management, he is being admitted here. And past history, he also gave a history
Just
of—
a minute. Okay, so these are the history, right?
Yes,
Can you just summarize whatever you discussed now?
So, summarizing a 41-year-old male who
Yeah.
had history of acral enlargement, coarsening of facial features,
Okay.
and also features of and that is features of hypersomatotropism associated with features of mass effect in the form of headache, visual field defects, and also 3 to 4 episodes suggestive of adrenal insufficiency, and also
Okay, just a minute. Dr. Chetan, who is Dr. Chetan? Okay, Dr. Chetan, what do you think about the issue? Are we dealing with an endocrine problem here or what?
So looking at the history, as she has told, there is acral enlargement is there,
Yeah.
and this is associated with the raised intracranial tension, with mass effect on the optic
What is the
chiasm.
evidence of mass effect here in this history?
Sir, there was an history of holocranial headache was there, and even once he was admitted with the vomiting, and the
Okay.
vision disturbances were there. So all these suggest a pituitary cause for.
So you think, sir, there is a slide? Slide? You think it's the endocrine problem?
Yes, sir.
Okay. So these are the evidences or statements for you, right?
Yes, sir.
Okay. What would be the differential diagnosis in this patient? No, anybody can make a diagnosis of acromegaly in this patient, right?
Yes, sir.
Always being a physician, say, my friends were discussing, always we should think medical causes first, right? Okay. There are medical causes which can almost mimic like this. That's possible, right now? That's possible.
Yes, sir.
But what do you think? Do you have any differential diagnosis in this patient?
So macroglossia could be because of hypothyroidism, or some.
Well, so now we'll start with the appearance, the facial appearance now.
Some people with insulin resistance also present, like in cases of.
How would you pick up, like,
lipodystrophy.
you have 100 cases now, right? 100 cases of such type of similar appearance. How would you pick up hypersomatotropism from this?
They'll mainly have a acral enlargement will be there, sir. Like the extremities will.
Tell me what are the other differential diagnoses if the patient has got acral enlargement? Praveen, who is Praveen? Praveen bhai?
Yes, sir.
Thoda bol sakte hai?
Yes. Pachydermato.
Acral enlargement.
Acral enlargement.
Any physiological condition which can produce acral enlargement? Physiological transient. Just look into your growth profile. Past history, your past history. Anybody? Rajesh? In adolescence phase also you can get acral enlargement, right? Okay, it's a transient, right? So what other differential diagnosis you can give? Apart, so you don't discuss about the macroglycia differential diagnosis. What are the other differential diagnoses for this type of patient? Yes, Karthik.
Then,
insulin resistance syndrome 1, 2, 3, 4. Then
drugs like phenytoin.
Certain drugs also can produce exactly that can mimic as a or hypersomatotropism.
Sometimes
right?
hypothyroidism can produce coarseness of
Theoretically speaking, hypothyroidism can also produce this type of phenomenon. Right?
Then,
Okay. But what I want to tell you that always you should consider medical causes first. Right? A physician, your first qualification is MD medicine, right? Then only your MDN comes, right? So first thing, medical causes, right? What do you think about the cause? Next is Ashwini. Yes, Ashwini. What is the issue? From the history, available history, what do you think?
Yeah. Patient has predominantly acral enlargement, sir. Along with that, he has uncontrolled diabetes, which is also suggestive of acromegaly.
Which acral part is involved here? Acra means what?
Extremities.
Yeah, any other area? Why it's called acromegaly?
Fleshy nose, prognatism.
Okay.
Fleshy
Any
nose.
evidence of prognatism in this patient? How do you look for prognatism? How do you look for prognatism?
On a lateral.
Ashwini thinks that I have a prognatism, right? Possible, no? How do you objectively assess? Basic MD question.
On a lateral view, sir. We look it in a lateral view, sir.
Lateral view or from lateral side. All right. Okay. Then what else in this patient?
He has fleshy nose, sir.
Okay. Any other point? Clinical stigmata of hypersomatotropism. First, we'll discuss 10 minutes basic and we'll go further.
Face is a bit oily, sir, like seporia.
Oily, you should go and touch on the face, you know. Mushkil hai. Kya karna hai that?
Coarsening of facial features, sir.
Madam, you just look at the eyebrows area.
Eyebrows.
Okay, you can see a little prominence. Don't you think so? Okay. Apparently, the patient has got little prominent eyebrows. Then what else? Any other points?
Macroglossia, tongue.
Chhod do na. Macroglossia, don't discuss about macroglossia now. Any other positive finding in this patient? Point or kya? Any Ashwini? Betty? Any other physical finding? Any other physical finding?
Acanthosis.
Can you see this hole like? Okay, this is also seen in hypersomatotropism, right? There's an extreme variant of this one. Can you name that?
Cutasis verticis.
Exactly. Okay, this type of phenomenon this is seen in hypersomatotropism. How do you decide, or how do you go about investigating? You can't investigate in all patients. Insulin resistance, such a common phenomenon here. So how do you investigate, or how do you pick up these patients for investigations? How do you pick up?
If a patient has typical signs and symptoms of acromegaly, or it is associated with other comorbidities like difficult to treat type 2 diabetes.
So no, I don't know what are the signs and symptoms. You tell me 1, 2, 3, 4, by which you will suspect, you'll go for investigation. You can't go for investigation for all patients. Am I right?
Yes, sir.
Acral These are all statements from textbook.
Acral enlargement, seborrhea, increased sweating, hyperhidrosis, uncontrolled diabetes.
Shamir, can you add to that?
Sir, we look for the any activity along with the clinical features of acromegaly, along with difficult to treat diabetes, hypertension. We have to suspect.
Karthik, can you add on to that?
Especially joint pain features suggestive of arthropathy, progressive headache, blurring of vision.
So what he wanted to say that if the patient has got multiple signs and symptoms, at least in a few symptoms, or many of the symptoms, that's a statement, many of the symptoms or signs or features like uncontrolled hypertension, uncontrolled diabetes mellitus, okay, very bad joint, right? Okay, then, okay, all these situations, you should suspect the possibility of significant hypersomatotropism, and you should investigate the patient. The next clinical finding in this patient is macroglossia. You know, there are at least half a dozen of causes. Can you tell me that? Can you contribute for that?
Sir, hypothyroidism, Down syndrome,
yeah,
probably.
Two more, if you can. Otherwise, just forget about that. That's not an issue. Babu, can you contribute?
Sir, amyloidosis.
Amyloidosis. Simple fungal infection can also produce See, think about medical conditions. Okay, acromegaly is one cause for macroglossia. That's all, right? Okay. So this patient has got multiple stigmata of acromegaly or hypersomatotropism. What is the type of disease? Is it a pituitary disease? From the available data, you don't know anything about the history investigations.
Sir, looking at the features, symptoms, and the features of raised intracranial pressure and mass effects, I would consider a pituitary.
Pituitary. So you think a patient has got a pituitary problem which is responsible for that. What type of disease? Is it active disease or inactive disease, or active disease becoming inactive disease?
Since he had a recent evolution of the pituitary insufficiency, I would consider it still growing and perhaps an active disease.
Active disease. Okay. So from the available data, you have a gentleman with evidence of hypersomatotropism, which is active disease, and it seems patient has got a pituitary pathology. That's a clinical workup for the timing, right? Over to sir. Nilanjan sir,
yeah,
this comment.
So I think we are dealing with acromegaly. So what this patient had some hospital admissions. I think Ashwini, can you tell us why was the hospital admission due to? Probable diagnosis in the background of acromegaly.
Whether the patient had any apoplexy at that time, sir, because he had fever at that time and he was noted to have hyponatremia and he improved with fluids. So whether the patient went into crisis like episodes during that time?
That was a crisis with a hypotension. Now, can acromegaly per se cause this sort of crisis, or what is the pathologic mechanism behind it?
So usually acromegaly are large tumors, sir. They are macroadenomas.
Right.
Patient can have apoplexy associated, can have sudden apoplexy, sir, which would have resulted Also the tumor per se.
And which hormone deficiency or excess of which hormone is the culprit out here? That's why I want to. This is a very easy question. Means what deficiency would cause this shock or vascular collapse? Anybody else? It's an apoplexy, maybe an apoplexy, or but which hormone deficiency had precipitated this crisis probably? Rajesh Yadav, Rajesh?
Yes, cortisol deficiency is what I would think.
Cortisol deficiency. So why do you get other hormonal deficiencies in acromegaly? What's the commonest histological type in acromegaly? Commonest pathology. First you say commonest pathology causing acromegaly. That is growth hormone excess.
Somatotropinomas.
Somatotropinomas located at the
in the pituitary
itself.
Yes.
If I say that, okay, acromegaly is a hypothalamic disease, so what would you say? Is it starting at the hypothalamus, or the start point of starting is at the pituitary level?
Sir, commonest one is pituitary only, yes, I think, sir. Hypothalamus, it's a rare.
So if it is hypothalamus, what would be the main causative hormone?
GHRH, sir. Growth hormone.
Apart from pituitary, can there be other sources of growth hormone resulting in acromegaly?
Ectopic source of growth hormone as well as ectopic GHRH also can.
So what are the common sites? If it is, suppose in this case, you have done a pituitary imaging. I don't know whether she has got a pituitary tumor, but suppose you do not get any pituitary tumor, but still it is a florid acromegaly and biochemically that suppose a diagnosis, where would you search?
So, pituitary neuroectoderm tumors or bronchial carcinoid.
So other neuroendocrine tumors, maybe bronchial, maybe pancreatic, maybe that's 2 to 5%, definitely less than 5% of total cases, but these are rare things. Now, the presenter, she has given a history, a treatment history. Following that, he was on certain drugs. From that, can you have an idea? But most probably, he was having some drugs given twice weekly. What was that probably?
Probably cabergolins.
So what is the necessity post-surgery of cabergoline in this patient? So maybe the patient had hyperprolactinemia. Now, what may be the causes of, say, hyperprolactinemia in acromegaly?
Maybe the tumor would have been a mammosomatotropinoma or a mixed cell tumor, and perhaps even if otherwise it's not, if it's poorly controlled after surgery with somatostatin analogs, maybe we would resort to cabergoline as an add-on.
So you said it can be a mammosomatotrap tumor. It can be a plurihormonal tumor, that is the same cell secreting both. Can it be without a mammosomatotrap tumor? Just it's a somatotropinoma, a large pituitary macroadenoma. Can it lead to hyperprolactinemia? Anybody else?
Due to stalk compression, it can cause hyperprolactinemia, sir. It can be a somatotropinoma only, but a large tumor compressing the stalk. It can also lead.
So how stalk compression leads to prolactin, increase in prolactin? What hormone is affected here?
Dopamine release from the hypothalamus, which is inhibitory, is interrupted, sir. So there is increased prolactin secretion.
Right. So there may be many possibilities, and that apart, without the prolactin being raised, there is the intrinsic lactogenic effect of growth hormone. That is sort of a specificity spillover also can operate here. Dr. Jabbar, please.
Yeah, now that's a clinical part, right? Okay. how do you evaluate this patient? What investigation you want to go for? Let us look into the.
I think, has she summarized the clinical features? She has said the history. To summarize the clinical findings, and I think then she can.
Okay. With one word, just summarize the clinical findings.
So examination findings.
Yeah.
He has, as already mentioned, prominent supraorbital ridges, wrinkled forehead, and stigmata of acromegaly and macroglosia. Grade 3 acanthosis nigricans was present, but there were no skin tags, no goiter. Acral enlargement of hands and feet were there. There was no kyphoscoliosis, no cephalomacules, nevi, facial asymmetry or soft tissue swellings. Fallon test was negative, and musculoskeletal system, pertaining to musculoskeletal system, there was no swelling, tenderness, restriction of movements in all joints, and all of the system exam, nervous system also, everything was normal. Cranial nerves, 3, 4, 6.
Summarizing statements.
Summarizing diagnosis: probable acromegaly, GH secreting pituitary adenoma with features of mass effect, features of activity, and hypopituitarism, and no history suggestive of apoplexy, and complications and comorbidities in the form of uncontrolled diabetes mellitus, sleep apnea syndrome, and underwent surgery.
Okay,
and
that's it. Okay.
No,
Now,
just-
see how come. Yes, sir, please.
Yeah.
Please.
Yeah. Actually, just I interject one. So you said there was no history suggestive of apoplexy. Why? The patient in the interim had a vascular collapse, needed hospital admission. So,
Sir, there was no history of low BP and no history of headache or seizures or loss of consciousness at that time. He had a fever followed by vomiting, abdominal pain, and a slight disorientation. That's all. And
so that can be following an apoplexy. That may be just because of a cortisol deficiency that has been precipitated or unmasked by the stress of the febrile illness, right?
Yes,
So,
sir.
but there was not typical, you mean to say, there was no typical features of headache or nerve palsy, unconsciousness. Okay, go ahead.
Let us go for the biochemistry evaluation.
So,
You have the evaluation?
Or rather, what would you do? Yeah, yes, it's there.
Yeah. So Ashwini, what investigation you want to do for this patient? Now you have a clinical suspicion or whatever, right? Okay.
Yes.
What investigation?
So first, I want to look at his glycemic controls. Then I want
So now we'll go for the comorbidities by then. Okay. Now what investigation you want to check?
I want to do a oral glucose tolerance test and see for growth hormone suppression, sir.
Suppose, Chetan, what do you think? What is your opinion?
So since he is a post-operative patient,
No. You don't know anything about this. Whatever history and that history may be wrong. We'll go as a virgin case, right? This case. What investigation you want to do in this patient?
So IGF-1, sir.
What is the sensitivity of IGF-1?
It's about 60.
Yes, second, Babu. What is the sensitivity of IGF-1? Any idea?
Around 90%.
Anyway, it's at least more than 90. But what's the specificity?
I'm not sure of that.
Karthi, you want to go for GH or you want to go for IGF?
Both has gone. Both has its own limitations because the patient is having uncontrolled diabetes. So,
what are the limitations? Can you just discuss? I didn't understand that. Uncontrolled hyperglycemia will alter the IGF-1.
So, uncontrolled hyperglycemia can decrease the generation of IGF-1 from the portal circulation.
What are the factors responsible for the conversion of GH to IGF-1?
So, one, the adequate insulin concentration should be there. Then there are if the sex steroids, these
Just a scenario, patient IGF is elevated in presence of uncontrolled hyperglycemia. Just interpret the report.
Then it is highly suggestive of the diagnosis.
Actually, do you accept that?
Yes, sir. It is
That's
highly
it. Okay.
Just a sec. Yeah. No, Dr. Jabbar, yeah.
Yes, sir. I'm listening to you.
Yeah. So you said that the glycemic control is not good. IGF-1 is high. Do you need to optimize glycemic control before you advise an IGF-1 with a high pretest probability of acromegaly?
You can do IGF-1 straight away itself, and if it is in the high normal or if it is elevated, then
No,
it
sir
is-
is
It's not
asking.
a problem. The problem is if the pretest probability is high, and if you get a low IGF-1 or a normal IGF-1, then it's a problem. If you get high, that's not a problem. Yes, go ahead.
Okay. So you want to go for IGF-1 first, right? Okay. What's IGF-1? IGF-1, this is at presentation, right?
Yes, sir.
So
371.
what's the normative data? What's the normative data? Any idea? We presume that's only 100. Okay, just for the discussion. So this IGF-1 is elevated. What else you want to do?
the next step would be to confirm it using an oral glucose.
Which one is the gold standard?
Is the OGTD or glucose suppressed GH.
How many samples you want to take?
So ideally, you would require from the basal, you would collect every 30 minutes for the first 2 hours.
Okay.
But certain studies have shown that collecting just 60 and 120 minutes is good enough.
Okay, the value is 144 nanograms per ml. Ashwini, what do you think?
It is elevated.
Multiple, elevated.
It's
Suppose my value is 0.3. What? How do you interpret?
It is normal, sir.
What's the normal level?
It should be suppressed to less than 1 nanogram per ml. Sir.
That's your. Suppose the laboratory is very good. You're working in United States.
It is 0.4, sir.
0.4. Okay. So this patient has got unsuppressed GH and elevated IGF-1. Are you happy to make a diagnosis of acromegaly now? Right? So it's a patient. The patient has got a acromegaly, right? Okay, fine. And the other investigation you can see here, prolactin is 160 nanograms per DL? Per DL or ML? Yes?
ML.
So there's a spelling mistake there. Okay. What do you think?
Why did you need to dilute? What was the initial value it came?
What was the initial, Babu? That's your protocol? Okay. Sir, that is the protocol of CMC, that's all.
Right.
Okay, interpret. 160 nanogram per ml. Is it normal or abnormal? If it is abnormal, how do you explain?
Usually in stock effect up to 100, sir. 100 nanogram per
Exactly,
day.
that's the reason I'm asking you. Okay, so
So
level is
here-
more than 150, 160.
We consider it to be a mixed tumor, which is probably secreting prolactin also. We'll consider that also here, sir. Along with GH, whether it is a co-secreting tumor of
So you think it's a
Mammosomatotrophic
mammosomatotrophic issue, right?
Yes.
That's your interpretation now. All right, okay. So other hormones are testosterone, of course, slightly on the lower side, I think, and the cortisol is 4.1. So how do you interpret that? 4.1. Is it normal or abnormal?
Less than 5 microgram per deciliter.
Reference data.
That depends on the assay that is used, sir. 3 to 8.
What is the common assay used in your laboratory?
So we use CLIA only, sir.
Clear. So what's a level? At which, okay, there's a high chance of adrenaline insufficiency. What's the level?
5 we take.
That is your.
5 microgram.
Okay. Any other data which gives you different values? Okay. There are data for 3 also, especially for pituitary problems, right? There are data are available, right? So these are the data. Now this patient has got an unsuppressed GH plus elevated IGF. Thyroid status seems to be on the normal side. T4 is okay. And prolactin is also high. Okay. So what would be the final working diagnosis for the time being from the biochemistry?
Probably a mammosomatotropinoma, sir, with associated hypogonadism, and I'll consider hypoadrenalism also.
Hyperandrogenism, any disease can produce hyperandrogenism, right? Pituitary disease. So you can't say like that, right? Okay. We'll go ahead with what investigation you want to do. Shamir? This patient has got, these are the issues, biochemical issues, clinical issues. What investigation you want to go for?
Next, sir, I will go for an MRI cell with pituitary protection.
Suppose if you are working in Bihar, just like Dr. Penny's place, what will you do?
Sir,
Bihar
if
means
it
there
is-
is no facility for MRI. So is a CT is okay?
We can, sir, we can in a resource-free setting, you can do a X-ray call also to look for.
X-ray, okay. X-ray will give a little, okay. What is the role of CT scan in this patient?
Sir, CT scan, sir, usually when MRI is contraindicated.
Okay.
Or if MRI is not available, we can go for a CT
Any
scan.
other indication? Yeah, bony changes, especially certain age group, probably the CT scan is useful, right? MRI is the investigation of choice. There is no doubt about that, right? Okay. So we'll see the MRI also. Show the MRI. This is before surgery. Madam, interpret. Interpret the MRI.
It is a T1 weighted coronal imaging showing an isointense mass in the pituitary sella, which is extending into the suprasellar region and involving the optic chiasma as well. So,
Optic chiasma. You think the patient has got a macroadenoma
Yes, sir.
producing pressure effects.
Yes, sir.
Is that the diagnosis?
Yes.
Radiological, right? Okay, fine. Now, so what's the diagnosis now? Patient has got a pituitary macro producing hypersomatotropism. There is a suggestion for prolactin elevation also with a little alteration of the hormone. As a physician, what is your line of management now?
the first management would be surgery, sir. Definitely.
Eh?
Surgery.
What is the basis for that? I'm telling you, I'm just supporting Lavanya. I want to give octreotide. You should have some data. Unless you have data, you can't say. I'm a fan of Dr. Lavanya from St. John's. I don't have any problem for money because I'm working in government sector. Now you give me the data, or you give me, this is my plan because of this reason.
It is a macroadenoma which is producing mass effect, sir, and compressing the.
Yes, compression is there. That is number one. Any other reason? What is above the data, JCM? Are you aware of that?
50% of the tumors, around 85 to 90%, if they're microadenomas, by surgery they can be cured, sir. 50% of macroadenomas are cured by surgery, sir. If SRLs, that comes to only around 20 to 30%. Sir.
Anyway, SRL is not a good option in this patient. Okay, this is only pulling discussion, right? Okay, because patient has got a pressure effects. You want, what are the other merits of surgery in this patient? One is that will relieve the pressure. Number two, number three, number four.
It reduces the tumor size. Sir.
Number one.
SRLs, post-surgery will work better if there is.
No. Now we are discussing primary. Lavanya is keenly observing all these things. She wants to get a little more support.
For SRL effectiveness, also surgery.
Effectiveness, it's a very brisk reduction. That is number one. The other one, so-called primary treatment, that will take its own time. Number two, you don't want to get tissue diagnosis in this patient.
Yes, yes.
These are all astrology now, right? We don't know what's happening. This patient may be having some sort of the pathology, and you have an issue. Is it a mamma or soma or both, right? So you will get a tissue diagnosis, you will get the brisk reduction and pressure effect. So Lavanya is out, right? You can't support Lavanya here, right? Okay. So, and you have strong data, okay, for giving primary surgical treatment. Above that data is very beautiful data that's available in JCN 2014. I forgot the volume, right? Okay, fine. So they will go for surgical management. Okay. Sir?
Yeah. So this is a pituitary macroadenoma having pressure effects, and we understand that the treatment of choice to start with is surgery. So following surgery, what are the adjunctive treatments that the patient may need? Means first, what is the rate of cure in this patient? Probable rate of cure with surgery. Any one of you, please say. Suppose you subject this patient to a transsphenoidal surgery. So what is the possibility of cure with surgery alone? Praveen?
It's a macroadenoma, sir. It is extending superiorly and compressing the optic chiasma and also laterally extending to somewhat around only 50% chance of reduction in post-surgery.
Only 50%. Now, how do you assess when and how do you assess the efficacy of surgical treatment? So this patient has been subjected to neurosurgery. Now, in the neurosurgery department, in the neurosurgery ward, and you are called upon as an endocrinology resident to decide upon the state of surgery. What would you do? Would you
a random growth hormone level on from day 3 to day 7. If it is less than 2 microgram per liter, if it is less than 2 microgram per liter, we can consider that the patient is cured, like the disease is in remission.
Right.
First
So,
one.
anything else? IGF-1?
IGF-1, it will take a longer time to normalize it. So immediately post-operatively, we don't take IGF-1, we take only growth.
So when you would be guided by IGF-1, if you have to test for IGF-1, when will you do that?
At 3 months, sir, or after 6 weeks only, recently they have mentioned, but not within the first.
General teaching is 3, not before 3 months. But some studies are now suggesting that it starts coming down from 6 weeks after a successful resection. What are the other changes that may point towards a successful resection? As you follow up the patient clinically and with certain other investigations.
His glycemic status, sir, immediately the requirement may come down. If it is hypertensive, and patient can have diuresis post-operatively.
Right.
Headache will improve. The patient's headache will improve.
Headache. So what are the changes generally that reverse on successful treatment of growth hormone excess? Anybody else? I think Prasoon Rastogi? Yeah.
So soft tissue swelling comes down, so which are reversible.
Soft tissue. So you have to give a very brief answer. So now tell me, what are the changes which are not reversible?
Arthropathy stays. Cardiovascular changes that have occurred stays. Cardiomyopathy is not reversible completely.
What about what about sleep apnea? What types of sleep apnea can you get in acromegaly?
So sleep apnea is partially reversible due to when the sleep apnea is due to the soft tissue swelling that is reversible, but some aspect of the sleep apnea stays post surgery also.
What aspects? What are the contributors to the sleep apnea in a patient of acromegaly untreated? Is it purely obstructive? Is it central, or is it mixed?
It is mixed, sir.
Mixed. So what are the components of sleep apnea that generally reverse following treatment?
So the aspect of sleep apnea due to obstruction, that is due to macroglossia and the
that is the pharyngeal musculature, the beak, tongue, the soft tissue they reverse,
yes,
but the bony enlargement will not reverse. And if there is any hypothalamic damage because of the tumor itself, because of the procedure or following radiotherapy, if there is a central component, that will not reverse. So,
sure,
and hypothyroidism along with acromegaly as a part of acromegaly will also be a contributor to sleep apnea. That will also be reversed on successful treatment.
Yes.
So in 50% of cases, there would still be a residual tumor. Now, how do you plan to go about? It means, presenter, I forgot your name, madam. So what
Sandra.
did you, Sandra? So what did you do? Means what would transplantal surgery?
Yes, sir.
Okay.
The histopathology showed it was consistent with mixed, sparsely granulated somatotroph lactotroph adenoma. with a MIB index of around 2%. And
from the, yes, sir, from the histopathology. Ashwini, you just interpret. How?
Usually
Histopathology.
densely granulated tumors have good prognosis, sir. They respond well, but it is a
No,
sparsely,
see, don't discuss theory. You discuss histopathology.
it's a sparsely granulated and a mixed tumor, sir, which is
So are you in the right direction now?
Yes, sir.
Okay, that's good. Okay. What do you think about the behavior of the tumor? What would be the? What's a MIB?
It's the proliferation index, sir.
So what do you think? Karthik, what do you think about the behavior of the tumor?
Sir, there is no K67 or MIB cutoff.
There are certain things are missing from the histopathology, right? Okay, then available data.
So then 2%, some studies have quoted anything more than 1%, you have to treat it as an aggressive tumor.
Okay, before this, what are the types of neurosurgical procedure, you know, madam? Neurosurgery, is it a transcranial or transsphenoidal? Is better?
Transsphenoidal.
Transsphenoidal. What type of surgery? Is it microscopic or endoscopic? Which one is a favored one now?
Microscopic.
Microscopic. Do you have any data for that? Any data supporting your comment? No, see, you can't make any comment unless you have a data. In DM training, after DM training, it's okay, fine. Whatever you want to do, do it. No problem. Yes, Babu, Prasoon. Oh, Rajesh Yadav. You think microscopic is good, right? Because you have a microscopic view.
Yes, yes, sir.
Yes, no, that is not the correct answer, right? The correct answer is endoscopic, okay? Because you will get a wide view, panoramic view, and surgeons are very comfortable nowadays. The whole world is changing to endoscopic, right? Okay, fine. But the data is very interesting. Data, at least in a 5 data are available. All these data are saying that there is no significant difference at all, except one last trend data which showed probably endoscopy is good. So by and large, the till today, or probably from today onwards, the endoscopy procedure is a favored one. There is no doubt about that, right? Okay. Coming back to the histopathology, this patient has got an intermediate value. Some book says 3, some book says 1, some book says 2. So what else you want to do in this patient? Adjuvant or medical treatment, whatever.
Adjuvant, somatostatin analogs, I would like to.
Somatostatin. Why they have started carbapenem then? We'll give a very negative report here. It was a wrong decision against Dr. Thomas Paul. No, no need. Excused. Chala, go ahead.
It's a mixed somatotrope lactotrope adenoma. Sir.
Okay,
so
then
it is likely to respond to carbapenem.
Okay, so I think say that there is no harm in giving that, right? Yeah. Just forget about that. Sparsely granulated. Such a situation, how do you take the follow-up and treatment? Sparsely means, is it a good sign or bad sign?
Bad sign.
Bad sign. How do you manage this patient?
Sir, I would again somatostatin analog I would consider, and then
what is the percentage of efficacy? How do you assess the efficacy of drugs?
Right.
What are the factors we'll consider if you are choosing a molecule? Now, there are a lot of drugs are available now and likely to come up, right?
Yes.
What are the factors by which you will take a decision? What is the efficacy of carbapenem? What is the efficiency of your octreotide? Or what is the efficacy of the other drugs also, yes, which are in the pipeline, or it's already available in some other place?
Somatostatin analogs about 60%. I remember. So carbapenem is
no. You Rajesh Bhai, you can't give such a statement, right? Okay, you can divide into certain categories of patient. Yes, you are likely to get this much of improvement, and certain category you will not get that much of improvement. Karthik, can you say a few comments for that? So this is after surgery. This is patient is after surgery.
Sir, overall, the somatostatin analogs have got a biochemical and tumor control rate of only 30 to 40% contrary to the early reports. So again, there are factors which gives a favorable things like if the younger age patients, female gender, then if it's a densely granulated, and if the IHC is showing SSTR expression positivity, all the this we have a higher rate, for example, 60 to 70%. But here, I think it's the lesion being a sparsely granulated
Yes.
adenoma and
Yeah.
it's an elderly male. The response is less robust.
Okay.
So
Then what you want to do? You want to go for medical treatment?
Still, you can give a trial, and there is pathophysiology which is better suited for tumors which are sparsely.
What is the merit of pathophysiology?
Because the sparsely granulated tumors express more of SSTR5 rather than SSTR2, so it may be a better
It's
choice.
very
than-
effective against 5. Then,
then
and do you have any data for that? Database?
Yes, Paola study also in octreotide resistant tumors, it has been found to give an additional 20%. Then the data by Shimon et al, around 50 to 60% additional gain of remission has been achieved with pathophysiology in those who have failed octreotide therapy.
Okay. Ashwini, what is PAPIS data? PAPY data. Is it related to pathophysiology?
Yes, sir.
Partly.
Partly. In
Okay.
patients who are resistant to octreotide, whether pathophysiology helping.
Okay. You are giving the octreotide for this patient, right? Patient is not responding. What will you do then?
We consider pathophysiology, sir. Then the next option is
Idhar nahi hai na, it's not available. What type of radiotherapy?
Sir, it is near. If it is nearer to the optic asthma, we'll go for a fractionated.
This is almost pushing the optic asthma.
So fractionated radiotherapy.
Okay.
Go ahead with.
Sir,
What are the types of radiotherapy you know of that you can offer to a patient of pituitary macroadenoma? Sandra? What do
Sir, it can be conventional or stereotactic. Stereotactic, again, stereotactic radiotherapy or radiosurgery.
Yeah, what are the advantages of stereotactic radiosurgery? Why this is a fashionable one? What are the advantages?
One thing is that it can be given in a single dose.
Good.
And more convenient to the patient.
That's
And
it.
for small tumors, which is away from the optic chiasma, like more than 5 millimeter away from that, we can give that.
Well, why can't you give to a tumor which is near the optic chiasma or near the cavernous sinus? What's the problem? Because it's a very collimated beam. It's a focused radiotherapy. Chances of collateral damage is less. So, but still, why can't you give?
Rajesh, sir is asking question. Don't sleep in between, right?
So the advantage of stereotactic radiosurgery or gamma knife surgery is that it is a single sitting, collimated beam, less collateral damage. It's a focused radiotherapy. That's why it's preferred, and it's costlier too in the private sector between the conventional fractionated radiotherapy. But then you cannot give it if it is near the vital structures. Why?
So, because of the close proximity and intensity, because it is.
Basically the fact is that if you can focus it on the right area, it's fine. But if there is a minimal offshoot, then the patient may turn blind. That's the problem. So you have to steer clear of the vital structures. Similar for the cavernous sinus. Coming to the efficacy, what is the efficacy? That is the safety, convenience, I understand. What is the efficacy of stereotactic radiosurgery versus conventional fractionated radiotherapy?
Both the same. Both are same, sir. Efficacy wise, it is same.
By and large, most of the studies do not tell that the efficacy with radiosurgery is more. It is basically the convenience and maybe the damage to the other vital structures. So that brings to the side effects and complications of pituitary radiotherapy. What may be the complications?
So, it will eventually cause pituitary insufficiency, sir. Other hormone insufficiency.
Hypopituitarism, which are the hormones to be affected first and most prominently? And which hormones are likely to be affected least following pituitary irradiation for macroadenoma? Shamir.
Sir, growth hormone is the first hormone to be affected, followed by gonadotropins, and least is TSH.
And maybe SCTH also. So the gonadotropins are very much susceptible to radiation damage. So this is not applicable for this gentleman, but if you get a person in the reproductive age group, that the question of fertility is an important thing. What about other second malignancies? What's the data, long-term data on cerebral damage and malignancies?
There are reports of increased risk of meningiomas, sir, in cases, especially in these conventional radiotherapy patients. Gliomas also reported.
So a slight increased risk of intracranial malignancies and any other subtle, frontal lobe deficiencies, cognitive decline.
Sir, cognitive dysfunction, cerebrovascular disease.
So these are the listed side effects of irradiation to the pituitary, and these are probably less with a stereotactic radiosurgery, the gamma knife surgery. That's why we discuss it, but efficacy-wise, as I reiterate, both are same. Now, did this patient receive radiotherapy?
Not yet, sir. He's admitted now for planning for a radiotherapy.
Right. So what would be the regimen? What do you plan for this patient?
So usually 45 to 50 gray total, that is divided into 1.8 gray per visit, and that is spread over 6 weeks.
I think we are almost at the end, about less than 2 minutes left. Dr. Jabbar.
Yeah, before closing, so what are the new drugs? After 5 years, we are having another class here, right? Okay, what are the new drugs are in pipeline and trials and ongoing trials for acromegaly? Ashwini? Kuch bolo na?
Oral octreotide is.
Any trial for that?
I'm not aware of the name.
Rajesh bhai, aapko malum hai? No, madam. Shamir?
Chiasma optimal trial. Chiasma optimal trial.
Optimal trial. Okay. What are the other drugs in our pipeline? After 10 years, the CMC is conducting another session. So that time we'll discuss that medicine also.
Paltusotine.
What is the name of the trial? Ongoing trial?
No idea.
Yes, Karthik? Acro? What? Path? Acrobat trial. Acrobat trial. Are you sure? Path? Okay. So, what are the other drugs in pipeline?
Oligonucleotide against the growth hormone receptor.
Good.
Then octreotide subcutaneous implants.
Yes, crystalline forms also. There are a lot of things are pipeline. After 10 years, we'll have another discussion. Probably Dr. Thomas will invite my students, Dr. Sandra, in the caliber of Professor of Endocrine. Thank you very much. Once again, before closing, thank you very much, CMC team, for the kind invitation. And special thanks to my friend Nilanchanji for contributing a lot for the discussion. Thank you, my students. I'm closing the session, signing off. Thank you very much.
Thank you. Thank you. Thanks a lot.
Thank you, Dr. Sandra, and a big round of applause for both the faculty, Professor Jabbar sir and Professor Sengopat sir, for that
very enriching, informative, and educative session. And I think this has been one of the most interesting sessions so far. So with this, we move on to our next session for the day. And just before that, a few housekeeping announcements. I think you all have received a feedback form, which was kept on your chair. If anybody has not received, you can collect it from the reception outside. We would request you to fill it and give it before you leave. Once you give it, you'll be able to also collect your certificate and a memento while you're leaving. And today's dinner is not in this venue, is not in the venue where you're staying, but that would be at GRT. That would be with all faculty and all the students. So it would be a nice place to interact. That would be in Hotel GRT on the first floor. So with this, we move on to the next session of the day, which is indeed one of the most common cases that we have to deal with in our practice, a patient with diabetes. And for this, I invite our faculty. We have Professor Rajesh Khatgawat, who's a senior professor from All India Institute of Medical Sciences, New Delhi. We thank you, sir, for coming all the way. And joining online, we have Professor Rakesh Sahai, professor and head of Osmania Medical College in Hyderabad. Sir is also the current president of Endocrine Society of India and currently placed in Nepal and joining from there. Thank you, sir, for joining from overseas. And we invite Dr. Akash to present the case. Dr. Akash, finally a PG from Osmania, Hyderabad. Over to you. I also invite the students who are part of this session to come and take the seat. I think you already know your names, but Dr. Ramesh, Dr. Mujib, Dr. Vivek, Dr. Harshita, Dr. Harikiran, Dr. Himanshu, Dr. Aruna, Dr. Krishna Mori can all come. Thank you.
May I start, sir? Hi, Rakesh, you are here?
Yeah, good evening to everyone, and special thanks to Dr. Thomas Paul and Dr. Nitin Kapoor and the entire faculty at CMC for inviting me to join this session, and thanks to Dr. Rajesh who is there physically there in the session. Disturbance in the internet connectivity, so I'll be there. I'm here.
Diabetes is one of the cases which more than 100% surety that you will get in exam, whether it's a DNB or DM exam, you will get a case of diabetes. And most of the time what you will get is type 2 diabetes, not type 1 diabetes, and which is 90% of the time must be having diabetic foot or visible some complications where you can examine. So most important thing examiner wants in that case is how you make diagnosis, what are different components of diabetes you have elaborated, not going into genetics of anything or not going into the treatment detail, not going into pharmaceutical drugs detail or insulin, but the common management which you can do, which clearly can differentiate you from a MD medicine or DNB medicine, which make the disease easy for management for the patient. So this case is definitely you will get in your exam. So we can start with yes, Dr. Rakesh. Can we start with case?
Yes, sir, please.
Dr. Rakesh.
Yeah, please, we'll request the student to go ahead with the presentation.
Yeah. Good evening to all the teachers and my dear colleagues. So I'm presenting a case of Mr. Chakrabarti, 71-year-old male, who used to work as a Pandit in the temple. He's a resident of Bangladesh. He presented to us with the chief complaint of blackish discoloration of fifth toe of left foot, along with ulcer on the lateral surface of left foot for the last 3 months. He is a known case of diabetes for last 45 years. So his age of onset of diabetes was 25 years of age. He was initially diagnosed when he was evaluated for his complaint of increased frequency of micturition. And on an evaluation, he was found to have a random glucose of around 300 milligram per DL, and he was started on oral antidiabetic. But after around 1 month of therapy, there was no improvement in glycemic control, and he was advised to switch to insulin therapy, which he says he has been on since last 45 years. He noticed blackish discoloration of the tip of fifth toe, along with development of an ulcer on the lateral surface of left foot around 3 months back. He's not able to clearly differentiate which developed first. He says he noticed both together only, and the blackish discoloration has progressed over the last 3 months to involve the whole of the left fifth toe, and the ulcer has progressed to its present size. There is no history of inciting trauma. There is no history of recent change in footwear. The ulcer or the blackish discoloration was not associated with any pain, swelling of the foot, or any fever. At present, he does not complain of any increased frequency of micturition, increased thirst. There is no complaint of any weight loss. There is no complaint of paresthesia, tingling, burning in the feet. He complains of numbness of both the feet with history of loss of chappals without awareness. There's complaint of dryness of skin of hands and feet. There is no complaint of lightheadedness or giddiness on standing up from supine position. There is no history of any heartburn, early satiety, bloating, or any constipation, diarrhea. He does not have any urinary complaints of any hesitancy, incontinence, or any burning micturition. There is no history of reduction in vision or floaters. There is complaint of swelling around eyes for the last 3 months. But there's no complaint of any swelling of any lower limb. There is no history of any frothing of urine. There is no complaint of any chest pain, shortness of breath. He gives history suggestive of claudication. He says that he was able to walk for a fixed distance, and he started noticing of having pain after walking that distance from last 1 to 1.5 years, which has gradually progressed over time. The pain was relieved by rest, and now for the last 3 months, he is complaining of rest pain. The pain is located in the calf region, cramp-like nature. There is no history of abdominal pain or any steatorrhea. Coming to past history, he's a known case.
Can we just stop at present history? So could have asked from this patient to get more information. Diabetes. What's your impression of diabetes?
Sorry,
till we have received history, what's your impression?
It is unlikely to be, sir, type 2 diabetes, because the patient has been on insulin therapy for last 45 years. He does give history that he had tried like a couple of times to switch over to oral anti-diabetic therapy, but that was always associated with poor glycemic control, and he was changed back to insulin therapy. That this is something I mentioned in past history, does not give any history of hospitalization for decay. His age of onset and absence of any history of decay makes type 1 diabetes diagnosis unlikely. Type 2 diabetes diagnosis also, there is no because there is no response to any oral therapy.
So you said type 2 unlikely because he required insulin quite early and could not be managed on oral hypoglycemic agent. Type 1 is also, you said, unlikely because didn't have diabetic ketoacidosis. Then what type of diabetes we are dealing with?
It is insulin dependent diabetes, sir. It could be autoimmune. It could be latent autoimmune.
So which one, type 1?
No, sir.
So you said type 1 is less likely?
Yes, sir. Autoimmune.
Type 2 is also less likely?
Yes, sir.
So which type of diabetes then?
Sir, slowly progressive autoimmune diabetes can be there, sir. LADA can be there.
Under which classification you will put that?
Sir, based on the new classification, it comes under hybrid form of diabetes, sir, in which it includes LADA and it includes ketosis prone type 2 diabetes, sir.
Ketosis prone, but didn't have any episode of ketoacidosis. Ketosis symptomatically didn't have?
Yes. not regarding this patient, like it comes in the hybrid forms of diabetes based on WHO classifications.
So you also think that it's not a case of type 2 diabetes? Suppose if I say that this is a case of type 2 diabetes, then what are point against type 2 diabetes?
Dr. Ramesh, can you answer that?
Sir, his need of insulin, persistent need of insulin.
First is age of onset. So 25 years, which is not usually against onset of type 2 diabetes. It's not common, and especially this was somewhere 45 years back.
Yes, sir.
So not today. 45 years back, he was diagnosed at the age of 25. So still not a very strong point to say that it's not a type 2 diabetes. Still possible type 2 diabetes, but less likely to be type 2. What against?
Then probably we don't know. Then lack of obesity.
So you feel that Western literature which says that at the onset patients with type 2 diabetes are obese is true for our country also? Do we see all patients with type 2 diabetes at onset are obese by BMI?
May not be.
Not
obese.
all. So by BMI criteria, obesity is not that common in our type 2 diabetic, newly diagnosed diabetic patients. So again, not a very strong point. What else?
I could look into the family history.
We haven't reached to that yet. And family history may or may not be, again, not very strong point. And that was also 45 years back. The rest of the family member might not have been checked also. What else?
Then we can rule out other types of diabetes like pancreatic diabetes. Any history?
Pancreatic, you mean to say FCPD?
Yes, sir.
So till now, didn't have anything else? No pain abdomen. You didn't mention pain abdomen.
I mentioned, sir, there's no.
You said,
yes.
okay. And you said no history of malabsorption, like no steatorrhea or anything. Yes. So for any FCPD for a duration of 45 years presenting with that and without any pain abdomen, theoretically possible, again puts less likely. What else? Okay, so now we come to theoretical aspect of that. How do we differentiate between type 1 and type 2?
So Mujib,
not in this patient, coming out of this patient, how do we differentiate between type 1 and type 2?
Mujib can tell us about clinically differentiating between type 1 and type 2 diabetes.
Clinically, type 1 diabetes patient, they can present with ketosis and decay episodes, and they usually present very younger age at onset.
He present 25, so 45 years back, 25 was younger age of onset. Presence of ketoacidosis is a very strong point in type 1, although type 2 can also present, but it's a strong point in favor. But absence of history of ketoacidosis does not rule out anything.
Other clinical pointers towards?
And lean habitus and early age of onset. And
any other clinical pointers with regard to autoimmunity?
Other autoimmune condition, vitiligo and hypothyroidism. And absence of insulin resistance.
The common autoimmune conditions which you see? Hypothyroidism? Yes. Equally common in type 2 also. Not a strong point.
Celiac disease.
Celiac disease, yes, could be. And then whenever, most of the time when we present the case in exam, it becomes very easy for us to say label without doing anything else type 2 diabetes, which is not. And even if it's a clear case of type 2 diabetes, one of the common question which comes in exam is how do we differentiate? Starting from the clinically, from the history, family history, and then this question end up with the biochemical parameters. So for all, it's important to know what is prediction of type one diabetes with antibodies. What are different antibodies? How do we predict that? And if these antibodies are positive, what are chances of becoming type 1 diabetes? So we have clear data from 3 large cohort. One is US, one is German, and other is Swedish cohort. They have combined all these data, and there is 25 years prediction of based on antibodies publication is there. This is diabetes care publication somewhere 3 or 4 years back, where combined data prediction rate they have said is 11%. If there are 2 antibodies positive, 11% is the annual risk of becoming type 1 diabetes. So if you take 100 newborn children who are antibody positive, 2 or more antibody positive, so by the total duration of 15 or 16 years, everybody will become type 2 diabetic. So for routine management, type 2 diabetes is common. We are seeing commonly, and most of the time we see type 1 is clearly differentiable. They have multiple episodes of diabetic ketoacidosis presenting very early. But in this case, who presented at 25 years, again, it's really very, not for you, but for us also, it's difficult to say whether it's a type 1 diabetes or type 2 diabetes, could be either type of diabetes. Other information you could have asked from patient is what was the duration on which patient was on oral hypoglycemic agent? You said initially for some period he was on oral hypoglycemic agent and then shifted to insulin, and for the last 45 years he is on insulin. Suppose we use a period of 1 year, he is on oral hypoglycemic agent and didn't develop a diabetic ketoacidosis and then controlled on which, more likely to go into type 2 rather than the type 1. If he develops episode of diabetic ketoacidosis, not ketoacidosis, suppose he was admitted, given IV fluid, given insulin, recovered, so we can presume could be a diabetic ketoacidosis. At all places, it's not possible to measure urine ketones or blood ketones, but admission is again supporting of that. Other thing we could have asked is, started on insulin, so what was his glycemic control? We know that might not have checked HbA1c in 45 years, but seeing blood glucose values, we could get general idea what was his controlled on insulin, whether he's responding well to insulin or not.
And also another question is, has there been any period of time during which in the 45 years when he's been off insulin, maybe 6 months, 1 year, was he any time off insulin, and at that time did he have any problems?
Yeah, absolutely. It's a very good point. It's not possible for any individual to take insulin for 45 years and not stop for a few weeks or few months. Might have had marriages in the house or some other emergencies in the house, so might have stopped, and could be that it stopped for 2 months, 3 months, might have developed hyperglycemic symptoms, might have lost weight, become symptomatic, but didn't develop diabetic ketoacidosis. So all these information are important. Many informations like you said frothing of urine. So why do we ask this history?
So for looking, it is an indicator of proteinuria in urine, so it can be present.
So are there any other causes of frothing in urine without proteinuria? And there are studies where they have evaluated few hundred patients who complained of frothing in urine and then checked whether they are proteinuria. Only 1/3 of them had proteinuria. So if frothing is there, frothing is usually today, one is immediate frothing, the large bubbles, and which within seconds they disappears. But frothing which appears at the end, lasts for long, along with discoloration of urine, it is more typical of proteinuria, and this frothing lasts for maybe few minutes or maybe few hours. These froths are present. Its frothing is nothing but it's a air entrapped inside the small vesicles which is present, because protein act as a surfactant and they are amphiphilic, so they keep this air entrapped inside this bubble, so it present. But only 1/3 of these patients who have frothing have actual proteinuria. This is similar to gentle asthma. We believe that those who are having gentle asthma are having dyslipidemia. So there are enough studies such that less than 50% of them will have any abnormality in the lipid profile. So again, similar to that, we believe that these are common, but these are not actually common. So we have taken history and we do not go further. So what's your diagnosis now? So we discussed a lot about type of diabetes. So we'll not go into detail of diabetes, whatever you say, type 1, type 2. So we accept that. And in this case, it's really difficult. We need to go to investigations to find out what type of diabetes. You agree, Rakesh? I think just disconnected. And then at some point of time, we are prompted to say that to differentiate, we will do that meal challenge test, or we do C-peptide, or we'll do OGTT or insulin. These tests are again not very strong supportive of one diagnosis. If you are doing at the time of diagnosis, yes, they can differentiate between type 1 and type 2. But at 45 years of duration of diabetes, no test can differentiate whether it's a type 1 or type 2. So one is diabetes. We understand could be type 1 or type 2. What else? Diagnosis.
So not type 1, but it still can be autoimmune, sir. LADA, it can
Agreed.
Be.
So
Yes,
it's
sir.
difficult to make clear diagnosis in this case. But if you know clear answer, if you know answers that how to differentiate type 1 and type 2, you can easily take 5 or 10 minutes of examiner's time. Examiner has a limited time of 40 minutes or 45 minutes. If you know all these studies and all this data, you can take out 10 minutes of that. You can force examiner to go on this side to say that yes, type 2, but I believe it could be type 1 also. It's difficult to differentiate. These are my reasons. Definitely he will be prompted to ask how do we differentiate, and if you answer that, then lastly he will think that candidate might not be knowing antibodies, so he will come into antibodies, what's antibodies, and then usually end up are we more antibody positive or are we less antibody positive in comparison to the Caucasian population. There are enough publications which clearly suggest that prevalence of antibody positivity is not as much as we are having in Caucasian population. These are the cases of type 1 diabetes, and even if we take all type 1 diabetic patients and measure antibodies in them, they all are not antibody positive.
What is the spectrum of antibody positivity in type 1? Can Vivek tell us something about this?
After the age of 15 years, I think the most common is anti-GAD65 antibodies. Before that, it is ICA antibodies. And approximately 50% of them will not be having antibodies after the prolonged duration. And other antibodies.
There are a few typical questions which will be asked. Which is first antibody to appear? Which is most specific? Which antibody will have fluctuating course? Which one antibody positivity will have higher chances of becoming type 1 diabetes? These are the few fixed questions you will be definitely asked. And which antibody, like most commonly antibody we do is GAD65. And GAD65 is a very fluctuating course. Alone GAD positivity doesn't mean anything in course of type 1 diabetes. So GAD may increase over the time, can come down, can again go up. There are well reported cases in literature where GAD becomes strongly positive and then comes down. So there is fluctuation. And then which one is most specific for diagnosis? If you see that antibody positive, there are highest chances of conversion into type 1 diabetes. Yes. And which is earliest to appear? ICA is earliest. ICA.
Islet cell antibody is the earliest.
Okay. And then from theoretical point of view, no center in India is doing all 4 antibodies measurement in their department. So we need to know what are different methods by which, just a theory question that ICA measured by this method and these are measured by these methods. So we should have some knowledge about their method, and positivity means what? So is there any fixed cutoff that if it's more than 25 will be positive and less than this is negative? It's not clear cutoff levels available for all these antibodies. Anything more, Rakesh?
Yeah, we'll go ahead, sir.
So diabetes agreed. What else? History-wise, what complications you can predict? One is clear that he has blackish discoloration, means there is some complication. So what is that?
Gangrene, sir.
Yes.
Gangrene with the ulcer is there. Along with that, sir, features of neuropathy are there. And there's swelling around eyes, which could be a feature of nephropathy also. Along with that, the important issue is he has got history of claudication. So peripheral arterial disease features are also there.
So anything, so would like to continue with the history?
Yes, sir.
So diabetes likely to be type 2 or type 1 with multiple complications starting from peripheral neuropathy, peripheral vascular disease, could be nephropathy also, because he has some features. He has frothing of urine, he has periorbital puffiness. So these are suggestive feature, not diagnostic, but suggestive feature of nephropathy. So you can complete that rest of history.
Yeah, yes, sir. So in past history, patient is a known case of coronary artery disease. He underwent coronary artery bypass grafting in 2009, 13 years back. He also underwent bilateral cataract surgery around 10 years back. He's a known case of hypertension since last 5 years. There is no previous history of foot ulceration or amputation. There is no previous history of hospital admission for DKA. In family history, patient in third in birth order, there is no family history of diabetes in parents. He belongs to a family of 4 brothers and 9 sisters. He belongs to a family of 4 brothers and 9 sisters. One of the sisters is diabetic. The onset of age for diabetes for that sister was 50 years of age. He has got 5 children, 1 son and 4 daughters. None of them are diabetic. In personal history, he is non-vegetarian. I did his 24-hour dietary recall. The total amount of calories came around 1700 kilocalorie per day. Should I go in detail of sir dietary recall?
Just total calories, and what next we want is percentage of protein is giving calories to him. So that will give us he's getting.
Sir, he gives history of intake of fish around 3 to 4 times a week, sir.
Approximately like 20% or 30% of calories is getting from protein, or he is not getting good amount of protein?
No, he's getting around 20% of calories from protein, sir. His appetite has reduced in last 1 year. His sleep he feels disturbed in sleep because of calf pain at the night. His bowel bladder functions are normal. In addiction history, there is no history of smoking, alcohol intake, or any tobacco chewing. This is the history, sir.
So with complete history, would like to revise your diagnosis, anything? So we are dealing with a 71-year-old male with 45 years duration of diabetes, on insulin from 45 years with multiple complications related to diabetes. So CAD, what will you call? You will call it complication of diabetes?
Yes, sir.
CAD.
Yes, sir. Because the patient had been diabetic for around 30 years before he developed the coronary artery disease. So it's likely to be a complication of diabetes, sir.
It is a risk factor for CAD.
Yes, sir. Diabetes diabetes modifies the lipid profile, sir. So there is increase in oxidized LDL. Other than that, there's
so is it diabetes a risk factor for for CAD, or it is equivalent to CAD? It's not risk factor, it's equivalent to CAD.
Yeah.
Otherwise, every type 2 diabetes is having CAD.
Right.
So what are other conditions which are equivalent?
So let us ask Harikiran to answer this question.
What
are the
sorry.
CAD equivalents?
Hymns.
Harikiran, Dr. Harikiran.
So peripheral artery disease is also risk factor for.
Yes, peripheral. What else? There are 3 conditions. What?
Smoking.
Not smoking.
Something else which is common in our population. Is CKD a risk factor? I mean, is it equivalent to CAD?
Diabetes is one, peripheral vascular disease is one. What else? What's third condition which is equivalent for CAD? So somebody who is having peripheral vascular disease is equivalent of CAD, must be having CAD. We need to evaluate in detail.
Yes.
What's third condition?
Rectal. Erect.
Which one? Related to vascular system only. Why we say diabetes is equivalent to CAD? Yes, we believe that diabetes is equivalent to CAD. Why? So, Harshita? So this is based on famous Swedish study where what we did was they prospectively followed those who had those who had MI and those who has diabetes. So they have prospectively followed and they found that those who have diabetes, the risk of having myocardial infarction in these patients is equivalent to those patients who already had one myocardial infarction. So that's why this was some 10 years follow-up of this study, and based on that, this concept came that diabetes is not a risk factor now. Diabetes is equivalent of CAD. So he has undergone bypass surgery, so that's a clear indication that he's having coronary artery disease, and there is clear evidence of atherosclerosis. So atherosclerosis is there in central artery. This must be there in peripheral arteries also.
Yes.
Go ahead.
I'll start with my examination.
Rakesh?
Yeah. So I would like to ask you a couple of questions. Would you like to tell us a little more details about, what was his course of his CAD? What was the presentation and what was the evaluation done and why was the CBG done? Because that's important.
He had complaint of chest pain with breathlessness. He was diagnosed to have an acute episode of infarction at that point. And later on, he was evaluated and he was he does not know the medical details, but he was advised to undergo bypass grafting, sir.
Okay.
So
I think you go ahead with the examination.
Yes, sir. Patient is conscious, cooperative, and oriented to time, place, and persons. His height is 170 centimeter. His weight is 54 kgs. His BMI is 18.7 kg per meter square. His waist circumference is 78 centimeter. On vital examination, he was afebrile. The pulse was 64 per minute, regular, good volume. Posterior tibial and posterior tibial artery and dorsalis pedal artery, these pulses were not palpable in both the feet. Other than that, all the peripheral pulses were palpable. There was no carotid and no femoral bruit. His blood pressure was 114 by 68 mmHg in left arm in supine position. And there was no postural fall in blood pressure. His respiratory rate is 16 per minute. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. On head-to-toe examination, on eye examination, he had bilateral pseudophakia. On oral cavity examination, he had lost most of the teeth of the lower jaw, and the remaining all the teeth were had yellowish discoloration with evidence of yellowish blackish discoloration with evidence of dental caries. On neck examination, there was no acanthosis, there were no skin tags, there was no goiter. His JVP was normal. On hand examination, there was he had thick waxy skin with flexure contraction of multiple fingers. Prayer sign was positive. He had a median sternotomy scar of length around 15 centimeter visible on the midline of the chest. He also had a scar on the left lower limb from the previous saphenous vein graft, visible from the medial part of the left knee joint up to the medial malleolus. Coming to the foot examination, he had loss of hair with dry skin present on both the feet, along with hyperpigmentation of both feet up to the ankle joint, more on the left side. He had scaling of skin with cracks and fissures present below the ankle joint on both the feet. He had dystrophic nails. Nails were yellowish, had yellowish discoloration, deformed. Bilateral arches were preserved on both the feet. He had callosity of lateral malleoli of both the feet. He had bilateral clawing of toes with prominent metatarsal heads on the left side. He had gangrene of the fifth toe of left foot, along with an ulcer on the lateral surface of left foot, which was 4 by 8 centimeter in size, with calloused margins, with sloping edges, with slough, with tendon and muscle forming the base of the ulcer, without any surrounding erythema or swelling. Probe to bone test was positive. There were 2 small ulcers in the second web space, around 3 by mm each, which were opposing each other. Both the feet were cold on palpation. Coming to systemic examination, on cardiovascular examination, as soon as S2 is heard, there are no murmurs audible. Respiratory system examination, bilateral adequate air entry without any evidence of crepitations. On perabdominal examination, it's soft, non-tender, there is no organomegaly. On CNS examination, higher mental functions are normal, cranial nerves are normal. On fundus examination, there is evidence of bilateral mild non-proliferative diabetic retinopathy. The motor examination is normal. There is no loss of tone or power in any of the limbs. On deep tendon reflex examination, bilateral ankle reflexes are absent. On sensory examination, 10 gram monofilament on both the sides is 2 by 10. Vibration perception threshold was 34 on the right side and 38 on the left side. Proprioception is lost. Fine touch, pinprick, temperature are reduced below the ankle joint. His ulcer grading was Wagner grade 4 or University of Texas class 3C. That's all, sir.
So at the end of history and examination, now your complete diagnosis?
Sir. It's insulin-dependent diabetes mellitus with diabetic foot gangrene, with neuroischemic ulcer, with severe peripheral artery disease, with diabetic symmetric polyneuropathy, with diabetic autonomic neuropathy, with bilateral mild non-proliferative diabetic retinopathy, with diabetic chiroarthropathy, with history of hypertension, CAD, which has undergone bypass grafting, and the ulcer grading, as I said, sir, Wagner's grade 4 or University of Texas grade 3A.
In this case, but otherwise, routinely we do not expect from you to comment on fundus examination, but definitely in exam, we would like you to comment on fundus examination and eye examination. And just by torch, can you say that patient is having proliferative diabetic retinopathy? Test by torch examination or by examination of your mobile light? If anyone?
Sir, if there is iris involvement, late stages of proliferative diabetic retinopathy, iris vascular involvement is there, then it can be resolved. Otherwise, it's difficult.
So there is not a common possibility, but rubeosis iridis may be there. And if rubeosis iridis is there, that's a part of proliferative diabetic retinopathy, suggests that there is an advanced stage. Even then, if we do not see rubeosis iridis, we need to comment something on fundus examination to complete diagnosis. And in this patient with 45 years of duration with all other complications, there must be definitely some evidence of diabetic retinopathy also.
I commented, sir, it's bilateral. There is mild non-proliferative diabetic retinopathy.
You have examined that?
Yes, sir.
Sorry, then I missed that. And didn't mention about scar of bypass.
I did, sir. Median sternotomy scar is there. It's around 15 centimeter in length from sternal angle to sternal north, sir.
And in this patient, do you need probe test? Why do we need probe test? Because some people are very much against doing probe test. There are chances that you may introduce infection during probe test also. So what's our basic purpose of doing probe test? Why we want to do probe test? It's mentioned previously where other modalities were not available in those days. Yes, if you reach to the bone, you can find out that bone is, you can touch to the bone and that will suggest that. But now we have other modalities which can clearly tell what's grade of ulcers. And that maybe that during that time we may introduce infection, although looks like infected foot also, but not very essential to do in each and every case in probe test.
Right.
And
One
other
point I would
common, go ahead.
Yeah, one point I would like to ask is about the blood pressure in the lower limbs. You have not mentioned the blood pressure in the lower limbs, although here we have clear-cut gangrene of the toes and we have a history of peripheral vascular disease. But I think that is a point which you have not mentioned.
Yes, sir. Sir, on palpation, I was not able to palpate any of the lower limb pulses. And on auscultation, actually, I couldn't hear any sounds, sir.
So what is the significance of the ankle brachial index? Can you tell us something about that?
Yes, sir. So ankle brachial index is an indicator of severity of peripheral arterial disease, sir. Normally, it is between 0.9 to 1.4. Less than 0.9, we say mild peripheral arterial disease. Less than 0.7, we say moderate. And less than 0.4, we say severe peripheral arterial disease, sir.
You have, in your description, you have already said that patient is having severe peripheral vascular disease.
Yes, sir.
And in this patient where you have established gangrene, much information will not be retrieved from measuring ankle. Yes, it's essential to measure in each and every case, but somebody gangrene has set in. That means there is a critical peripheral vascular disease.
Yes.
Other common question, which is not very important from the practical management point of view, is this test for peripheral neuropathy. This is when Winston the test, somebody will ask why you use 10 gram only, then you need to know why we use 10 gram, and then there is one more 5.07/10. So we need to know what are these and why we do not use less than 10 gram or why we do not use more than 10 gram. This is simply because 10 gram is the pressure you put, then there is buckling. This is based on the initial studies, not from diabetic. Diabetic was a very small part. but most of the studies coming from the patients of leprosy, where they have used these 3 wires they have used, and they found that this 10-gram pressure is most likely associated with the loss of peripheral sensation, which they confirm with the nerve conduction velocity. And simply 5.07 is some logarithmic transformation of the amount of pressure which is generated. So that's why, and they have tried other type like 4.65 or something, and 3 values they have tried and finally found that 5.07 is the best predictability of peripheral vascularity, peripheral neuropathy. So, and again, there is a lot of discussion about the point which you need to check during this monofilament examination, how many minimum points, maximum point. There is no clear guidelines. Even ADA do not suggest 3 minimum points should be there, but you can go up to 10 points also. And this is only suggestive. This is not diagnostic. Rakesh?
Yes. So can you tell us something about, does he have nephropathy here? Clinically, do you have any features of nephropathy from what you've seen?
Clinically, sir, the only evidence there was swelling around the eyes. There is no history of reduction in urine output. It's difficult to confirm, sir, on a clinical basis.
Periorbital puffiness, seeing his stature, could be because of hypoalbuminemia, which is not diabetic, although there was no history of alcohol intake, but still could be, looks like malnourished because of that hypoalbuminemia, and you can have very well that periorbital puffiness in that case also. Just wanted to know, to me look like that there is some amount of gynecomastia in this case. First picture you have shown, must have checked, so there was no gynecomastia.
No, sir, I didn't appreciate any gynecomastia.
Any importance of gynecomastia in this patient? Whether it's a drug induced or because of any other cause?
It could be a drug-induced gynecomastia.
Even if it's not there, just mention always in a diabetic patient that there is no gynecomastia or not. And we haven't, I haven't heard anything about genital examination.
Yes, I didn't do so. I missed that.
So that's also important portion of diabetic. What abnormalities we are likely to see in such case in genital examination? And even in such a long duration case, examiners may prefer that you do some assessment of rectal tone also, which could be a part of autonomic neuropathy. It's a difficult examination to do, and we are not very much expert in doing that, but at least by assessment you can give some information about that, about rectal tone, specifically asking about whether he's having any features of autonomic neuropathy. You said that at your description that there was no features of autonomic neuropathy, but in a 45 years old with all complication, everything, I expect some amount of autonomic neuropathy definitely there in this patient. At times there may be problem in communication with this patient, or patient might not be giving us proper history of complication, but not there. Similarly, history, like you didn't ask about 71-year-old, but still peripheral vascular disease, could be Lariche syndrome or difficulty in getting erection, or this type of history is also important. That could give you just idea that blockage is not only in the peripheral part, it could be upper part also, although Lariche syndrome is extremely uncommon type of presentation, not a common feature of peripheral vascular disease in a diabetic. So what's the commonest site of peripheral vascular obstruction in peripheral vascular disease in such patient with long duration? Suppose we do angiography in 100 patient. What is the site where we will find maximum chance of absorption? Anyone?
Dr. Himanshu can tell us about this.
Distal vessels will be more involved.
Pardon?
Distal vessels will be more involved.
No, distal vessel doesn't mean you name anatomical area.
Below the popliteal fossa.
So below popliteal there is trifurcation. Anterior, posterior, and peroneal.
Yes, sir.
So where you expect more cases if you do angiography in 100 patient? So where you will find more obstruction, more chances of obstruction?
Common peroneal.
What do you think? Yes, he's right. Just below popliteal, at the place of trifurcation, there is commonest site of obstruction in these patients. And after that, one is trifurcation, and then second common site for peripheral vascular disease in the same segment from femoral to down. Profunda femoris is also a common site, but not commonly associated with the distal, this type of gangrene which is most of the time seen with the blockade at the level of trifurcation or below that.
So how do you like to evaluate this patient? Investigations, what investigations would you like to do?
Yes, sir. So we'll do the routine investigations. We'll do a complete blood count, looking at WBC count. We'll do ESR. We'll do a renal function test, urine protein creatinine ratio. We'll look at the fasting glucose, postprandial glucose, HbA1c. We'll do an ultrasound looking at kidneys, and we'll do a lower limb Doppler. We'll do an X-ray foot.
Can you interpret the reports seen on the screen?
So you have reports in front of you. Comment on that.
Sir, he has got anemia, 9.1 gram per DL. His creatinine is 1.2. At this age, it's very likely it's stage 3 or more CKD, sir.
Usually we label based on eGFR.
Yes, sir. It's,
so alone based on creatinine, difficult to interpret. We see in photograph that it looks malnourished. BMI is also 18 something. So 1.21 is quite high for him, but exact situation we will come to know if we mention eGFR. Your comment on thyroid functions?
Yeah, he has got hypothyroidism, sir.
Not hypothyroidism. You have to tell what type of hypothyroidism.
Yes, sir.
It's likely to have primary hypothyroidism.
His HbA1c is 8.1%. 24-hour urinary protein is increased. His cholesterol, his LDL cholesterol is 32.
When we label hypocholesterolemia, when we label what Harrison says, when we label hypocholesterolemia, hyper we always see, but okay, go ahead. We are not left with much time. Go ahead.
Causes of anemia and diabetes. Can you quickly tell us causes of anemia and diabetes?
Sir, nephropathy can be a cause of diabetes. Treatment with metformin can be a cause of vitamin B12 deficiency anemia. Autonomic neuropathy can be a cause of anemia and diabetes. Gastroparesis can be a cause of anemia and diabetes.
Forgetting something important? You mentioned previously. Which may be likely in this case. Could be celiac also. We are not sure. Type 1, type 2 could be celiac.
Yes.
It's a hypochromic. It's a microcytic type of anemia. Low hemoglobin. So could be celiac also. Never investigated.
Yes.
What else? As in that, another important cause of anemia in diabetic patient?
Anemia of chronic disease.
Just that's very much possible. Already have CKD, so that's possible. Anything else?
Antiplatelet induced blood loss. Antiplatelet induced blood loss.
Is he receiving, must be receiving post bypass?
I have actually not seen the
We don't.
treatment.
Okay, fine. Could be because of that also.
So X-ray findings, maybe Dr. Aruna can tell us about the X-ray.
There is a diffuse osteopenia, sir, and
but that's the first thing to comment in this foot. And can we
There is a
comment
deformities.
legibly on osteopenia in this X-ray? Difficult.
there is a calcified vessels are
Yes,
present, sir.
yes, absolutely correct.
And there is a deformity that is seen. That is, it's like hammer toe deformity can be seen, sir. And
What else you are seeing?
cals.
And what important thing you need to tell in this X-ray of that picture of foot you have seen previously? Need to comment on osteomyelitis, need to, whatever impression you can make, need to comment on Charcot's, need to comment on disarticulation, and there are sesamoid bones, need to tell, is there any, because there is a ulcer, is there any gas or not?
So
A foreign body also sometimes can be there.
Yes, absolutely, foreign body also.
We'll move to the next one because we have very little time left.
Yes.
So Dr. Krishna Mori.
Yes, go ahead. So comment on that, CD angiography.
Right lower limb showing diffuse multifocal calcification, 30 to 40% stenosis. Mural centric and circumferential calcified plaques, causing around 50 to 60% stenosis in the superior femoral artery.
Okay, so there is clear evidence that is having peripheral vascular disease. There is obstruction more than 50%, and you need to know how do we measure. CD angio is not available. We can do Doppler also. What are the triphasic patterns, and when we call it as a clear evidence of it becomes monophasic, then we say that yes, clear evidence of peripheral vascular disease. So do you have more slides? Do you have more slides?
I'm not the one, sir.
Achha, you're not a professor.
Yes.
So do we have more slides?
Any other investigations available? Yes.
That's all. So but now your complete diagnosis.
Insulin dependent diabetes, sir, with foot gangrene, with neuroischemic ulcer, with severe peripheral arterial disease, with diabetic sensory motor polyneuropathy, with diabetic autonomic neuropathy, with bilateral eye, mild non-proliferative diabetic retinopathy, with diabetic chiroarthropathy, with hypertension, and with CAD, sir.
Routinely, many small things we also need to mention in examination, prayer signs and eye signs and all these things. Just mention that. Doesn't mean anything great in 45 years of duration of diabetes. Most likely that everything would be having. So another important question when comes in some point of time in exam is dressing of a diabetic. If your patient is having diabetic foot, then there will be definitely a question on dressing of diabetic foot. How do you do dressing? What you are doing and what you advise. So anyone on some quick comments on dressing of
Elsa can, Dr. Elsa can tell us about this.
So there cannot be one type of dressing. There are different type of dressing, which type of wound is having, where theoretically we can advise that type of swelling. Practically, we know that everybody is doing saline dressing.
Hydrocolloid dressing can be used.
Hydrocolloid
dressings, then silver impregnated dressings, then placental extract dressings in non-healing ulcers.
Do you use these dressings?
Usually only saline dressings are practically
Saline dressing is good when it's a dry wound. Saline dressing is good when it's a healing type of ulcer, whereas you see red granulation tissue, keep that moist. Nothing else is required, that granulation tissue will grow. But when it's infected, when it exudative, fluid itself is secreting more fluid, then you need to absorb that, keep moist. Hydrocolloid type of dressing, you if available, then alginate type of dressing you can use where they will keep wound moist, they will absorb extra fluid, which is extra exudate, which is secreted. If they are not secreting, then they can alginate type of they contain fluid or moisture, which they will keep the dressing. Then they have occlusive dressings also, which clear non-infected. You want to keep wound moisture inside, so you can occlude by complete. So different type of dressings, duration of dressings, how long we need to give antibiotics for treatment of ulcer, again depends upon whether it's osteomyelitis or not. And one typical question is, how do you differentiate between chronic osteomyelitis versus Charcot's foot? And there are some soft point, but finally we end up saying that we will do MRI. Nobody does MRI for that, but MRI gives clear answer. And what are findings in MRI which support Charcot's foot, and what are findings which support the peripheral osteomyelitis? So if you get diabetes case, this is all is going to be discussed. Nobody will reach to the metformin or sulfonylurea or insulin or type of insulin will not reach, because you always get 45 minutes or 60 minutes for a case discussion of diabetes, and these are the things which are commonly discussed. Rakesh?
Yeah, I think we did discuss all these issues. We were not able to discuss about the management or the therapy of this, but I think that's the best we could do in the available time. Thank you.
Thank you.
Thank you, sir.
Thank you, Akash. Thank you very much, Professor Gadgawat and Professor Sahai. A big round of applause for this session. Thank you, all the participants. And I think it was another yet educative and informative session. Last one around diabetes. So with this, we move on to the penultimate session of the day. And just repeat the two housekeeping announcement. One about the dinner. So the dinner today is for everyone together in JRT Hotel, which is about 1 kilometer from here and walking distance from where you're staying. That is Spence Park. So you have to fill the feedback form. That may not directly help you as a batch, but would definitely help the future generation, because we do take that very seriously to design our programs. And so please do fill it very sincerely. So we move on to the next session of the day, which is Meet the Professor session. And we have faculty. I invite Professor Asha, who's the current head of Unit 2, Professor of Endocrine at CMC. Well, Lord, I also invite the panelists for this session. We have with us Dr. Tushar, who's Professor and Head of Department of Endocrine at KEM Mumbai. Thank you, sir, for joining online. We also have with us Professor MJ Paul, who's the current Head of Department of Endocrine Surgery at CMC Vellore. Thank you, sir, for joining in. And we also invite Dr. Julie Hepzibah, who's the Professor and Head of the Department of Nuclear Medicine at CMC Vellore. I invite you all to please come on stage and hand over the proceeding to Professor Asha for moderating the case. The case is on pancreatic neuroendocrine tumor. We have two presenters. We have Dr. Venkat Sandeep and Dr. Krishna Prabha from CMC. Over to you.
So in the next 45 minutes, we will be discussing a few cases of neuroendocrine tumors, which we have seen in the last few years. And we will discuss about the various diagnostic and management aspects. Over to Dr. Venkateswaran.
Good evening, everyone. Here I present a case of a 34-year-old lady who presented to CMC with recurrent episodes of hypoglycemia. She had initial symptoms at the age of 12 years. She had bone pains and proximal myopathy. And at the age of 20 years, she was evaluated for the same, and her calcium, she was found to have PTH-dependent hypercalcemia. The imaging revealed left superior and right inferior parathyroid adenoma, and subsequently the surgery was done and the 2 parathyroid adenomas were excised. At the age of 30 years, on follow-up of the PTH-dependent hypercalcemia, she was again found to have elevated calcium and elevated PTH levels. On imaging, she was found to have left inferior parathyroid adenoma, and because she also had a thyroid nodule with higher thyroid score, she was offered left inferior parathyroidectomy and left hemithyroidectomy, and the remaining parathyroid tissue was implanted in the neck. After surgery, she developed hypoparathyroidism and was started on calcium and active vitamin D supplements. She also had oligomenorrhea and was found to, at the same time, was found to have elevated prolactin. MRI pituitary revealed a 1.2 centimeter tumor on the left side of the pituitary, and she was started on cabergoline 0.5 mg twice a week, which she continued for 2.5 years and stopped herself. So this is the family tree of the index. The index patient is patient number 7, and her father had meningioma, and it was operated 3 times, and he died at the age of 50 years with pancreatic cancer. And mother had a duodenal ulcer and died at the age of 70 years. 2 of her siblings were found to have dyspepsia, and the other brother had prolactinoma with apoplexy and duodenal ulcer. One of her nephews had renal calculi with multiple skin nodules. On the father's side, 3 cousins of the index patient had died of cancer at young age of 35 to 58 years. So with a combination of recurrent primary hyperparathyroidism, hypoglycemia, which could be likely due to insulinoma, and pituitary macroadenoma with elevated prolactin, can be prolactinoma or non-functioning pituitary macroadenoma. And in the background of a significant family history, we considered a diagnosis of MEN1. Dr. Tushar sir, how do we evaluate for hyperinsulinic hypoglycemia in such patients?
Yeah, sure. Thank you very much. And I think the history is clear-cut, and it clearly says that this is multiple endocrine neoplasia type 1 syndrome, and you're trying to evaluate symptoms of hypoglycemia in this particular patient. So you don't expect any other causes apart from endogenous hyperinsulinic hypoglycemia in this case. So we would definitely go for a 72 hours fasting test, where you typically ask the patient to come in the morning and be fasting, and we check for HGT every hourly or half an hourly, and keep a look on urine ketones maybe 3 hourly or something. And the moment the patient is symptomatic with sugars by HGT is going below 50, you'll collect the blood for random blood sugar, insulin, C-peptide, and beta-hydroxybutyrate. And you expect that if in the face of hypoglycemia, if your insulin is more than 3 and C-peptide is more than 0.6, so it goes in favor of hyperinsulinic hypoglycemia. So I would be expecting it in this case.
So on presentation to CMC at the age of 34 years, she presented with fasting hypoglycemia, and we did a supervised 72-hour fast. After 22 hours of fasting, she was found to have elevated insulin and elevated C-peptide, which pointed towards endogenous hyperinsulinic hypoglycemia. Serum calcium at that time was normal. She already had subtotal parathyroidectomy and was on calcium and active vitamin D supplements. The fasting gastrin at that time was found to be normal. So, Dr. Tushar, sir, what imaging modalities would be useful for localization?
So when we look at this case of hypoglycemia in a background of MEN1, I think we would look at definitely an anatomical imaging as well as functional imaging. So anatomical imaging, what we use is a contrast enhanced CT scan of we do from neck to pelvis. So because it's a MEN case, so you're going to have multiple tumors right from your parathyroid, which are knocked off in this case, but you could have a thymic lesion, you could have some carcinoid sitting there, bronchial and adrenal nodules, and definitely you may be able to find multiple tumors on the pancreatic imaging, duodenal pancreatic imaging there. So CT scan can be used or an MRI can be used, but when we know that we'll get multiple tumors, like as it is seen in this particular case, you see 3 or 4 tumors there, which are arterially enhancing, and there is adrenal nodule also, but we are not sure then which nodule is really secreting and which one is non-functioning. So there will be a combination of non-functional plus functional scans. So gastrin is negative here, so it's going to be only insulinoma versus non-functioning NETs. So the next scan we can do is gallium dotatate PET CT. You can do a confirmation scan with MRI because there are a lot of issues with radiation and all that. I'm sure radiologist and a nuclear medicine physician would elaborate more on that. But definitely an anatomical based scan followed by a functional based scan. Dotatate is there. One point I would like to add, even dotatate may not be, though it's more sensitive to picking up anatomical lesions, it may not pick up insulinomas that well due to its inherent characteristics, and you may have to do an exendin based scan to differentiate between these nodules if you really want to be very clear to have a pre-operative evaluation and trying to look at which pan net is really secreting insulin.
Dr. Julie Hepzua, ma'am, does functional imaging improve the sensitivity of detection of such tumors? In the context of suspected MEN1, would functional imaging PET scan be a better choice?
There is a definitive role in functional imaging in MEN1 syndrome. And as you can see in this slide, as Dr. Tushar has already alluded to the fact of anatomical imaging, the importance of anatomical imaging in functional imaging, in the sensitivity of SRS PET, that is somatostatin receptor scintigraphy, which includes gallium dotatate, DOTATOC or DOTANOC, but the most commonly used is dotatate scan. And there is a sensitivity of 97% and also a high specificity. And it has also proven its utility in special situations such as detection of unique neuroendocrine tumors and in cases of unknown primary neuroendocrine tumors. And I have, although this is quite a busy slide, I'm not going to go into the details of each and every modality, but you can see the advantage of whole body PET CT, especially FDG and DOTA-PET. FDG is predominantly useful in poorly differentiated tumors or in grade 3 and above, and also in neuroendocrine carcinomas. And the advantage of PET is that you can get a whole body imaging, and it is, as we know, it's functional study, and it is quite easy to perform. But I wouldn't go as a first line option, especially because it is not available in all the centers. And if your center has a good functional imaging setup, you can definitely go for it. And these are the main PET radiopharmaceuticals that are used for neuroendocrine tumors. And the commonest I said was dotatate and PET, FDG PET. And dotatate has a somatostatin receptor affinity to type 2 predominantly. And we all know that most of the neuroendocrine tumors express type 2. And dotatate is also important for the theranostic approach, theranostic utility. So we DOTA talk and DOTA knock. If you look at DOTA talk, it is predominantly it is useful when the somatostatin type 3, type 2 and 5, and for knock it is 2, 3 and 5. So we would prefer dotatate for therapeutic purposes. And this slide also tells you the different sensitivity and the specificity of different imaging modalities. And as Dr. Tushar also said, for insulinomas, gallium-68 DOTA exendin is the first imaging modality of choice.
So suspecting a diagnosis of MEN1, we did a genetic testing for MEN1, which showed a heterozygous mutation in the MEN1 gene on exon 9, which was a novel insertion mutation. Dr. M.J. Paul, sir, what are the treatment options in this case? What are the surgical options for patients with multiple tumors all over the pancreas? And can a part of the pancreas be preserved to retain its exocrine and endocrine functions?
Hello, good evening, everyone, and glad to be part of this team. Greetings to Tushar, Julie, and Asha. And this is an interesting topic in multiple tumors of pancreas, and I would like to start by outlining initially the approach should be tempered by the fact that generally MEN1 patients have a reasonable lifespan, whatever we do. They don't have very aggressive tumors. So correspondingly, our treatment also should be tempered, mainly in managing functional tumors, and a combination of medical, surgical, and observational strategies are used to keep the patient in good symptomatic control. So I think that being the bottom line, when we look at a symptomatic insulinoma, it is not easy to control long-term medically. So generally, surgical option is preferred here. As was said, the patient has hyperplasia and adenomas. Some are functional, non-functional. So localizing tumors is not easy on the functional aspect in the pancreas. So the surgical strategy when we have multiple tumors has generally been accepted as what we call the Thompson procedure. And this is named after Professor Norman Thompson in Michigan, who did a series of these cases and showed good control over the long term, which includes subtotal pancreatectomy, which means we remove the distal pancreas, spleen preserving preferably from the neck distally, and the lesions in the head are enucleated. Thereby, you preserve enough exocrine pancreas for the exocrine function preventing diabetes and achieve a reasonably long-term control over the pancreatic tumors and the insulin secreting syndrome. This we have done in two that I can remember, the Thompson procedure. Alternatively, sometimes the tumors are localized distally, and we had one patient who, after extensive imaging, had lesions only in the tail, and we did only a tail excision and has been under long-term control. So when the next tumors will present is not clear-cut, and it's better to have a sort of strategy that limits the amount of surgery according to the tumors that are there. So to say, the punishment should fit the crime. I think that with that, I'll pass on.
So this case underwent distal pancreatectomy and enucleation of the pancreatic head lesion. And the histopathological examination showed a well-differentiated pancreatic endocrine neoplasm, which is multifocal. And the MIB1 index was 1 to 2%. After surgery, she developed hyperglycemia, which transiently required insulin, and subsequently was euglycemic without medication. So at the time of presentation, at 34 years to CMC, patient was found to have a Hardy's B tumor of 1.2 centimeter size without any visual symptoms. On follow-up at the age of 34 years, she developed visual field defects, and the maximum size of the tumor was 2.2 centimeter. You can see in the figure, it is just abutting and pushing it upwards. And she was offered endoscopic transsphenoidal excision of the non-functional pituitary adenoma. The hormonal evaluation was normal, and prolactin was only mildly elevated. The histopathological examination revealed pituitary adenoma, which with focal immunopositivity for prolactin and FSH, and the MIB index was found to be 5%. Dr. Asha, ma'am, what are the follow-up strategies advised for these patients? Discuss about the family screening and surveillance.
So, as you are all aware, this patient, in this patient, we saw that initially she had primary hyperparathyroidism, for which she underwent surgery, subsequently developed multiple neuroendocrine tumors of the pancreas with a functioning insulinoma as well as multiple non-functioning tumors. And the third surgery was for her pituitary adenoma. So since we have done 3 surgeries, we cannot assume that we have cured the endocrine tumors of the patient. She still has part of these endocrine glands left, and she can always develop recurrence in future. So it's very important to screen these patients periodically to identify the recurrence early. And also we should keep in mind the frequency of the various tumors associated with MEN1 and design our screening strategies based on these. So primary hyperparathyroidism is the commonest manifestation seen in about more than 90%, even up to 100%. Most of them are asymptomatic when you screen them, pick them up on screening. Symptomatic disease usually develops by the 3rd decade. Neuroendocrine tumors of pancreas initially were reported in only about 60% of patients, but over the years in the recent papers, the prevalence has gone up even up to 80%, and the cumulative probability of developing a pancreatic neuroendocrine tumor progressively increases with the age of the patient. And these are the main tumors that are responsible for increased morbidity and mortality in these patients. Pituitary adenomas reported in 30 to 60%, mainly in the 4th decade. Adrenal tumors less common. Neuroendocrine tumors of the stomach, thymus, lung, and bronchopulmonary tract also very less, in about 3 to 10%. Of late, there has been an observation that there is a 2-fold increased risk of developing breast cancer among these patients, as well as papillary thyroid cancer. So the screening recommendations, most quoted ones are from the clinical practice guidelines of MEN1, which was published in 2012, where the screening begins at the age of 5 years for insulinoma and anterior pituitary tumors with measurement of the hormones, prolactin, IGF-1, glucose, and insulin. At 8 years, screening starts for primary hyperparathyroidism. At age 10 years for non-functioning pancreatic neuroendocrine tumors, and for gastrinomas at the age of 20 years. Though it seems interesting that we can start screening the patient very early, when we look at from the patient's perspective, if we look at the number of scans a patient has to go through and the number of blood investigations, it is really numerous. So we have to keep in mind the goals of management in these patients. The main goals are to prevent premature morbidity and mortality, and which is mainly related to the bronchopulmonary and the pancreatic neuroendocrine tumors. Also, there are various challenges to surveillance because the disease behavior is not uniform. You have a diverse spectrum of tumors involving multiple endocrine and non-endocrine organs, and there is a wide age-related penetrance of these tumors. So when we look at a person who is diagnosed as a child by genetic testing as MEN1 mutation positive, that person would undergo about 200 blood tests and approximately 70 surveillance scans if the classic screening protocol is followed up to the age of 50 years. And so this is a huge economic burden, as well as has significant psychological impact on the patient who has to undergo these many tests. Hence, a pragmatic approach is what is recommended in the recent articles, where regular assessment of relevant clinical symptoms is what is recommended every 6 to 12 monthly. screening for asymptomatic patients should focus on tumors whose treatment is likely to improve their morbidity and mortality, especially the pancreatic neuroendocrine tumors. And recent consensus statements have said that screening can start after the age of 16 years. And individualized decisions have to be further made about the frequency of further biochemical testing as well as imaging. Of late, the recent articles recommend imaging every 2 to 3 years instead of doing it every year. And we should always acknowledge and accept that there is a degree of uncertainty as to how these tumors behave. We will be showing some cases regarding that. And so we have to educate the patient and the family regarding the same.
On follow-up of this case, 7 years after initial presentation to CMC, the imaging showed multiple pancreatic tumors, the non-functioning pancreatic neuroendocrine tumors, which are awaiting surgery. Hand over the subsequent discussions to Dr. Krishnaprabha, my colleague.
Moving on with the family tree of this MEN1 family. So the index patient, as we discussed, was patient 7, and she had 2 elder brothers and 2 elder sisters. So going on to patient 4, her elder brother, he presented to us at the age of 50 years with history of dyspeptic symptoms, and his gastroscopy revealed antral ulcers, and his serum gastrin was 1065 picogram per ml, which is more than 10 times elevated than the normal 100 picogram per ml, and his chromogranin was more than 1500 microgram per dl. And his MRCT abdomen revealed bilateral non-obstructive renal calculi, and he had 3 enhancing lesions in the pancreas. The largest was around 14 into 10 mm. And so he was started on medical treatment with PPIs, pantoprazole 40 BD, and he was advised periodic biochemical tests as well as imaging surveillance. Now, as we know, in men 1 with hypergastrinemia, the primary modalities, we will treat the hyperparathyroidism. So he also had a PHPT, and he underwent a 3.5 gland parathyroidectomy along with a cervical thymectomy, and his HPE showed, the biopsy showed parathyroid hyperplasia as expected. His prolactin was normal. Now, his son was the patient number 8. He had a macroprolactinoma and a PHPT, and he was treated with also cabergoline, and he also underwent a subtotal parathyroidectomy and a cervical thymectomy. Dr. Tushar, what is the efficacy of medical treatment for these gastrinomas, and which patients should be referred for surgery? Are there any differences in the management of functioning versus non-functioning pancreatic neuroendocrine tumors?
I'll take one by one. So
Yes.
efficacy of medical treatment for gastrinoma is mainly for symptom control, and we use proton pump inhibitors as was used in this case, pantoprazole. You may add H2 receptor blocker also, or sometimes maybe a somatostatin analog to those patients who are really metastatic and you can't really offer surgery for them. And second question is which patient should be referred for surgery? I think these are difficult cases, and rather than referring a patient to a surgeon, it should be a part of multidisciplinary team management. As Dr. Paul had already stated, that the patient has to see all of them together, and the decision of surgical, medical, imaging, and the radiotherapeutic managements should be taken in consultation with each other. So by and large, if you are having really more liver metastasis, then the patient really goes for medical therapy as such. But if the idea is to prevent the metastasis, pick the patients earlier, and gastrinomas are usually multifocal. So even local metastasis can be tackled surgically. I'm sure Dr. Paul will talk more about it. So generally a tumor which is approximately around 2 centimeter or more in the duodenum or pancreatic region should definitely go for surgery. Local peripancreatic lymph nodes can be with lymph nodes also can go for surgery. and patients with isolated liver metastasis can also go for surgery. Now, management of functioning versus non-functioning. All functioning needs surgery except for this gastrinoma, as we have stated. Other insulinoma, which is most common, definitely requires surgery. And the other rarers like somatostatinoma, glucogonoma, and VIPomas. In non-functioning, it's very clear that up to we can wait up to 1.5 to 2 centimeter size, because after that the chance of metastasis is really more. And but at the end of the day, we have to take a joint consultation with surgeons and all specialties to take a right decision for an individual patient.
Thank you, sir. Dr. Paul, what are the options of surgical treatment for gastrinoma, sir? And what are the challenges we encounter during surgery for functioning versus non-functioning NETs?
Yes.
Yes,
Interestingly, a few years ago, I looked at all our data and found we had very little surgical treatment for gastrinomas in the last decade. So I spoke to my gastro colleagues and found they had identified only 4 patients in the last decade, and either they were metastatic at onset or they were managed easily with medical management. So I think gastrinoma kind of selects itself out from my experience, and looking at even Indian literature, I could find only 1 operation for gastrinoma in the last 15 years. So it's an unusual tumor, and I think there are a couple of misrepresentations of it, in the sense it is the exact incidence is very difficult, because it also depends on definitions and picking up imaging. So when I did a thorough search of literature, actually from a surgical point of view, we teach that the commonest is insulinoma, not gastrinoma. So that is a moot debate point, first point. Second is, when we come to surgical management, if we have a rare case where we actually have a gastrinoma syndrome and you've identified a lesion, what we find is actually most commonly it's in the duodenum submucosal location. It's not often a pancreatic tumor. It's much more common in the duodenum. And the only one where I've actually taken one out is when we did a combination pancreatic for insulinoma as well as duodenal submucosal excision of a gastrinoma. And that led to a cure. So the high incidence of more than 50% will be malignant and present with metastasis. So automatically they are not surgical candidates. And the ones that come to surgery often are duodenal rather than pancreatic. I think this is just basically surgical take-home points, I would say.
Okay, sir. Thank you, sir. So sir has already discussed about these 4 management strategies, about operating only when the imaging demonstrates a lesion more than 2 to 3 centimeters, and of course to operate in all cases in those presenting with a clinical syndrome. So the Thompson procedure, sir, has already discussed in the management of the insulinoma itself. So now we come to her elder brother, the second elder brother. He presented to us in 2011 with asymptomatic primary hyperparathyroidism, but he had a history of being treated outside for a macroprolactinoma and with apoplexy, and he was on treatment with cabergoline for that. And in 2007, he had a duodenal ulcer which resolved with treatment. He also had a hypergastrinemia. In 2011 is when he presented to us with an asymptomatic PHPT. We did a system, of course, to rule out an ectopic parathyroid, but we found a right inferior parathyroid adenoma. The ultrasound revealed a parathyroid gland enlargement of all the 4, and there was hypercalciuria and osteoporosis on the DEXA. So, of course, he underwent the subtotal parathyroidectomy and the cervical thymectomy, and the histopath revealed the parathyroid hyperplasia. But what was interesting was that in the cervical thymectomy, there was an atypical thymic carcinoid which was reported on the biopsy, and he was advised a strict follow-up for that. But he presented to us in 2006. He presented to us 16 months later, by which time the chest X-ray had shown this enlargement in the thymic in the anterior mediastinum, and for that he underwent a subtotal excision, and the histopath revealed a neuroendocrine carcinoma of the thymus with lymphovascular and local invasion. So he underwent chemotherapy, radiotherapy, and 6 cycles of peptide receptor radionuclide therapy. Now, his children were also screened for MEN1 gene, and they were found to be negative, fortunately. So, Dr. Jolie, what is the role of peptide receptor targeted therapy in the management of pancreatic and other foregut neuroendocrine tumors? What are the options, cost, and efficacy?
Okay. PRRT, that is peptide receptor radiotherapy, has proven to be a relevant and effective treatment, especially in patients with GEP. And how is it done is lutetium-177 dotatate is a radiopharmaceutical and the isotope that is used. It is given as an IV infusion of about 200 millicurie each sitting, and there is 4 infusions 8 weeks apart. And this is done with co-infusion of arginine and lysine. These are positive amino acids, and this is especially done to prevent the renal toxicity, so that there is a prevention of the reabsorption, tubular reabsorption of the radioactive peptide into the renal tubules. Now, arginine and lysine infusion has proven to reduce the radiation toxicity to the nephrons by about 40%. And if you, this is the other options that are done for PRRT is yttrium-90 dotatate and actinium-225 dotatate. Now, the cost of these is quite enormous. Lutetium is easily available in our country. It is also produced in the nuclear reactor from BARC. And if it is procured from our country, it costs anywhere between 25 to 75,000, and the costs vary in different government setups and private setups. Now, we prefer imported lutetium dotatate for the fact that it has high specific activity, and that costs about easily about 2 lakhs, 2 or above for each infusion. So there's a total minimum of 4 infusions that we need to do for PRRT to complete the course. And yttrium-90 is not available in our country, and it is extremely expensive, almost 10 times lutetium. And coming to actinium-225, this is an alpha emitter. It has much more, it is proven to be much more effective, but the cost, evades us from using it as a routine PRRT, PRRT source. So actinium-225 costs anywhere between 5 to 9 lakhs per infusion or per sitting. So this is what I would like to inform you all. And the other complication, the most common complication that has been reported in the literature is because of renal toxicity and bone marrow toxicity. Now, if you look at the literature, the renal toxicity has occurred in patients who already have a pre-existing renal damage, and it is about 1.8 to 2% is what has been reported in the literature. And coming to the bone marrow toxicity, MDS, that is myelodysplastic syndrome, and acute myelocytic leukemias have been reported in 2% of patients. But these patients are patients who have already had alkylating chemotherapies. So these 2 major side effects are quite limited, and most of the time these the toxicities are reversible and short term.
Thank you, ma'am. Moving on to her elder sister. Now she presented to us with asymptomatic primary hyperparathyroidism, and she underwent an excision of the right inferior parathyroid adenoma, and a cholecystectomy was done for her in 2011. So this was at about 30 years of age, and this was done in an outside center, following which she had a post-operative pulmonary thromboembolism, and that was a very stormy post-op course. So following which she was not willing for any further surgeries, and subsequently she was found to have a gastrinoma also, and an MRCT abdomen showed multiple pancreatic neuroendocrine tumors subsequently. And these were her MRCT scans, but fortunately, none of these lesions have increased in size. And her son, patient number 9, is an engineer, about 20 years old. He presented to us with multiple collagenomas. He has a microprolactinoma on medical treatment. He also had a primary hyperparathyroidism. He underwent a subtotal parathyroidectomy and thymectomy in 2016. Fortunately, his serum gastrin is normal. So, but also his MRCT abdomen over the years from 2016 to 18 has been showing an increase in the size of certain exophytic lesions in the pancreas. And the largest lesion is measuring 27 into 21 mm. So there's an increase of about 8 mm size of these lesions over the last 3 years. So he's having non-functioning pancreatic neuroendocrine tumors. So Dr. Paul, what proportion of these tumors progress on follow-up, and what is the risk of metastasis? And can patients with metastasis be offered surgery, sir?
Yes, it's I mean, these numbers are too low to talk in terms of proportion, but generally they tend to progress with time. The rate of progression varies depending on the case. So when we follow them up and we do find increased size, syndromic symptoms, or presence of metastasis, that would be a definite indication to treat. Now, whether to treat in the presence of metastasis surgically, there are a lot of options now, even on to surgically excise metastasis if they are amenable. So when they are large and potentially malignant, yes, we do offer surgery, excision of the primary lesions, and if possible, combined surgical excision of the metastatic lesion. The liver has been done successfully. If the liver lesions are not amenable to surgical excision, then we have options of radiofrequency ablation, where there are a limited number which are confined to anatomical areas of the liver. And thirdly, transarterial chemoembolization of lesions, which are used when you have both lobi in multiple site involvement. So the therapeutic strategies for metastasis have increased considerably now. And the attempt is to try and ablate, if not surgically excisable, because these patients can be controlled for a long time.
Yes, sir. Thank you, sir. The eldest sister is mutation negative. She only has a lipoma of over the occiput, and all her biochemical evaluation till now has been negative. Asha, ma'am.
So we saw in this family, multiple members of the family affected by the same genetic mutation causing MEN1, manifesting with different MEN1 related endocrine and non-endocrine tumors with differing degrees of severity. I would also like to discuss one more case from a different, not from this family. This was a 70-year-old gentleman who presented to us in 2010 July with sudden onset of upper abdominal pain, newly diagnosed diabetes, a recent weight loss of 5 kilos. He had a perianal rash at the time of diagnosis. He also had been admitted to the emergency with a left focal seizures due to a frontoparietal meningioma. On evaluation there, he was found to have tender hepatomegaly, which was hard in consistency with a nodular surface, and ultrasound had shown multiple hepatic metastasis. And for evaluation of that, he came to our hospital. So with this constellation of diabetes, perianal rash, probably a necrolytic migratory erythema, with multiple metastasis, newly diagnosed diabetes with very high blood glucose, we considered a possibility of glucagonoma. His fasting plasma glucagon came elevated, and his CT MRI confirmed the presence of a tumor in the tail of pancreas, which was 3.7 centimeter with multiple hepatic metastasis. He underwent an ultrasound guided biopsy, confirmation of the diagnosis, which confirmed a neuroendocrine neoplasm with a MIB1 index of 10 to 15%, indicating a grade 2 neuroendocrine tumor. Subsequently, because of the highly metastatic disease, surgery could not be offered. So he was initially given chemotherapy because of the high MIB1 index with carboplatin and etoposide for 6 cycles. There was no significant response, though his diabetes was controlled better. That was the only change which we saw over the duration of time. After the completion of chemotherapy, he was treated with octreotide and also capecitabine temozolomide combination. He remained clinically well for 2.5 years. His diabetes was controlled, but subsequently his metastatic load progressively increased 3 years after the diagnosis, and he succumbed after 4.5 years. A few points about glucagonoma. When you're measuring glucagon, always keep in mind the pre-analytical and the analytical errors. It is very temperature sensitive, so the sample should be taken and transported on ice. There can be interference by other peptides derived from proglucagon, especially if you are seeing a patient following a gastrectomy or a Roux-en-Y gastric bypass, and especially if you are doing a non-fasting sample where you can get a falsely elevated value. Glucagon can also be elevated in cirrhosis, diabetes, sepsis, etc. The glucagonoma syndrome is characterized by the 4 Ds, that is dermatitis, necrolytic migratory erythema, diabetes mellitus, depression, neuropsychiatric symptoms, and DVT. They have an increased propensity to develop thrombotic events along with elevated glucagon levels. Most of these are sporadic. Only about 3% are associated with familial syndromes, MEN1 and VHL. The average age of diagnosis is in the 5th and 6th decades. Most of them have an initial indolent course, and it takes about 3 to 4 years to make a diagnosis. And at the time of diagnosis, more than 50% would have metastasized. The treatment, if it is surgically resectable and localized, surgery is the first line treatment of choice. If you have a few metastases in the liver, you could consider chemoembolization or resection, radiotherapy for localized metastasis, and in well-differentiated tumors, somatostatin analogs or peptide receptor radionuclide therapy can be tried. And in those who don't respond to any of these measures, everolimus, capecitabine temozolomide are the other options. Thank you. With this, we end this session. Any questions we can take up?
Thank you so much, Dr. Asha, Dr. Julie, Dr. Tushar, Dr. Paul. Thank you so much. And it was well appreciated. Thank you so much for your wonderful and valuable contribution. And I got some feedbacks for the next endocrine masterclass. We are going to incorporate. I got the permission from Dr. Julie. That is the functional imaging and just as a workshop, neuropathology as a workshop, and endocrine pathology, and also the other allied, that is radiotherapy, pituitary, that we will be incorporating in the endocrine masterclass 2023, probably scheduled for October 2023. Thank you so much. Over to you, Dr. Nitin.
Thank you. So that reflects the importance of good feedback. It may not help you, but will definitely help the future generations. So again, request that you fill the form very sincerely, and it's anonymous, so you can write whatever you like. And please give that feedback form at the reception before you collect your certificate and memento. I think with this, we move on to the last session of the day, which is the quiz. All of you have written a preliminary round, and based on that, there would be a few teams, 4 teams that will be selected. The cash prize for the first prize is around 20,000. For second prize is 15,000. Third prize is 10,000. And there's also a prize for the 4th team who will be selected and shortlisted out of all the teams who participated. So I hand over the session to Dr. Ramya. Just reminding again, after the quiz, the dinner would be in JRT Hotel. We look forward to see you there. It would be an informal, interactive dinner, not only a chance to interact with your peers, but also the faculty who's come here from outside CMC as well as from CMC. All right. Over to Dr. Ramya.
So coming to the final event of the day. So yesterday there were 25 participants, means 25 teams who participated in the prelims, and we have selected the top 4. So as I read out the name, I request the postgraduates to come forward and pick up the chits. Dr. Karthik V and Dr. Shamir Bashir from Government Medical College, Trivandrum. Dr. Harshita and Dr. Himanshu from MS Ramaya Medical College, Bangalore. Dr. Ramesh Roshan, Dr. Sandra Moses from Government Medical College, Trivandrum. Dr. Manjunath, Dr. Rohit Barnabas from KEM, Mumbai. So in team A, we have Dr. Manjunath and Rohit Barnabas from KEM, Mumbai. In team B, we have Dr. Karthik and Dr. Shamir from Trivandrum. Team C, we have Dr. Harshita and Himanshu from MS Ramaya. And again in team D, we have Dr. Ramesh and Dr. Sandra from Trivandrum. So basically there are 4 rounds in the quiz. The first round will be history round. The second round, an open round in which you get to select from 5 branches, from which branch you want the question. And the third round will be a clinical round. And the fourth round will be rapid fire. I'll tell the rules of each round as we go into the rounds. So first going into the history round. So here each team, the first round we'll start with team A. The second round we'll start with team D. And third round again starts with team A. And the fourth round will start with team D. So in this round, each team gets 1 question. The duration allowed to answer the question is 20 seconds. And for each correct answer, you will get 10 marks. There is no negative marking in this round. In case if the team doesn't answer, so there is a chits which is given to you. So when the question is being asked, you can simultaneously write down the answers. And if the team to which the question is directed doesn't answer, then all those who are writing the correct answer will get half mark. That is, if you give the correct answer, you will get 5 marks. But simultaneously you have to write, because when the bell rings, we will collect the papers.
So now we are moving on to the first question. This is question of team A. Please check whether your mics are working. So the question is, name the person and what was the mutation did he harbor that led to his clinical condition? Those who know the answer, please write down the answers. Rebecca. Dr. Karthik, please give the paper. So the answer is, this is a personality who lived in 1700s and he was popularly known as the Irish giant. His name is Charles Byrne. He was as tall as 231 centimeter. He was loved for his kind nature and he was considered like a celebrity. But the sad thing was that he died at the age of 22 years. You can read yourself, why did he die? What was the reason for his death? In fact, he has had a last wish which have not been fulfilled yet. This is the skeleton of his skeleton being kept in the London Museum. We can note that this is a normal person, the skeleton of a normal person, and we can note how tall is he. In fact, in 1900, Harvey Cushing, he just examined his skeleton and he found that the pituitary fossa was widened. And that's when he diagnosed that he had a pituitary adenoma. In 2011, a DNA was extracted from his teeth in which they identified that he harbored AIP gene mutation. So we have team C has written FIPA gene mutation. So they get 2.5 points to team C. So now coming to team B. So can you identify this personality and what was his discovery in endocrinology?
Dr. Owen, he described the parathyroid glands in rhinoceros, one-horned rhinoceros.
Yeah, that's right. So this is Sir Richard Owen. He's known for his many discoveries. Like he's the one who first coined the term dinoceros. In fact, he is holding the skeleton of a dinosauria in his hand. So he's also well known for his controversy, which he had with Charles Darwin. He just refuted against the theory of evaluation, which was suggested by Charles Darwin. So he is the one, he identified the parathyroids while he was dissecting the Indian rhinoceros. He was doing an autopsy in the Indian rhinoceros. It was initially in his honor, the glands were known as glands of Owen, and later it was named as parathyroid. So team B gets 10 points. So now going to team C. So name this famous personality. Name 2 eponyms in endocrinology named after him.
Graves.
Speak loudly.
Graves.
So this is Sir Cocker, who received Nobel Prize for his work. He received Nobel Prize for medicine for his work in the field of thyroid. Actually, he's the one who improvised the thyroid surgery techniques, which reduce the morbidity associated with thyroidectomy. There are at least 7 eponyms in his name, and there are 3 in endocrine. So the Cocker-Debray-Semeglin syndrome, the Cocker's incision for thyroid, and Cocker's sign associated with thyrotoxicosis. So team 1 gets 4 points. LCL 1 is wrong. So I'll give you 4 points. Sorry. No, it's 2.5 points. I asked eponyms in endocrinology. That's okay. Okay. Okay, both team A and team D gets 4 points. Now coming to team D, the direct question to team D. Team D, right? Okay, you wrote here, team D. 4. So team D already have 2.5. Okay. So coming to your question. So identify this eminent person. She received Nobel Prize for her discovery and shared the same with 2 other scientists. Can you name at least one of the scientists? There is a clue in the picture. So this is Dr. Rosalind Ello, who discovered radioimmunoassay, and she received Nobel Prize in medicine for that. In fact, she shared her Nobel Prize with 2 other endocrinologists, that is 2 other people who are working in the field of endocrinology, Roger Guillemin and Andrew Shalley for the discovery of hypothalamic peptides. So team B gets 2.5. And team A also gets 2.5. Now we are moving on to the next round. So in this, there will be 5 branches from endocrinology. So we'll start with team D now. The first team to answer will be team D. So you can choose any one branch. So once chosen by a team, that branch cannot be chosen by the other teams. But you get to answer. This is also a pass round. So if the team is not answering, you get to answer the questions. So here you get 20 marks for each right answer. And the time duration here is 20 seconds. These are majorly related to journal articles. May not be direct questions directly from that article, but something related to that. So team D first. Which one you want to choose? It's bone, pituitary, obesity and metabolism, thyroid, diabetes.
Thyroid.
Okay. So I think everyone is aware of this journal article from IPGMR, which is published in JCM in 2021. I need not describe anything about this article. So we'll go on cell-free DNA, the diagnostic use of cell-free DNA to differentiate between benign and malignant thyroid nodules. So going straight to the questions, what was the cell-free DNA cutoff established in the study for differentiating malignant versus benign thyroid nodule? Name any 2 risk factors that was associated with increased concentration of cell-free DNA in the study.
Uh, 6 point cutoff.
Okay. Risk factors.
High risk features, tumor burden.
Okay. So the cutoff which they established using this study was 67.9 nanogram per ml. They first did surgeries. They selected those with benign and malignant, and they established this cutoff, and they validated the same in those with indeterminate nodule, that is Bethesda 3 and 4. And the tumor burden was not clinically significant. It was lymph node, presence of lymph node, lymphovascular invasion, capsular invasion, and extrathyroidal extension, which was significant in the study. So team B, team B gets 7.5 points. Now moving on to team C,
Pituitary.
pituitary. So this is a new concept which has been evolving over the past 5 years, I will say. So this is a journal, this is an article from European Journal of Endocrinology, which came in 2021. This is actually a review article, but there are at least 10 studies related to this. So what we expect when a patient when we do growth hormone suppression test in a patient with acromegaly is that following the growth hormones glucose load, the growth hormone levels in fact get suppressed, even though they may not get suppressed completely, but they will be usually lower than the basal levels. But what we notice in at least 30% of the patients is that paradoxically there can be an elevation. So the question to you is that what is the mechanism behind the paradoxical growth hormone rise in acromegaly following glucose load? And name what is the clinical implication? Name at least 2 clinical implications of that, which is derived from the studies. So the answer is it's similar to the ectopic expression of GIP receptors in the adrenal. It is said that there is ectopic GIP receptors being expressed in the somatotropes as well. So following a glucose load, this receptors get stimulated and there is increased growth hormone production. So the clinical implication being they found that tumors which exhibit this paradoxical growth hormone rise, they are compared to the others, they were smaller, they had higher IGF-1 levels, they were densely granulated, and hence they had better response to somatostatin receptor ligands. So 2 teams have written GIP receptor expression. You haven't mentioned where is the GIP receptor being expressed. Team D has written GIP receptor in pituitary. So okay. So 7.5 points, 7.5 for team D, 5 points for team B, and 2.5 points for team A. So just for writing GIP receptor, I haven't given the point. Now moving on to team B. So you can select.
Bone.
So we all know that FRAX is a web-based tool which assesses the probability of major osteoporotic fracture and a major hip fracture based on clinical risk factors. So from the time FRAX came in 2008, it was established by Dr. Canis et al. So we know that there are certain limitations which have been suggested from the time it was started. And many articles have come up telling that the FRAX needs modification. In fact, starting from 2011 till 2020, there are many articles which are published that FRAX can be modified in this way. So this article came in 2022, in which they have summarized like in what all way the FRAX can be modified to have a better fracture predictability. So the questions is FRAX model, which is currently available, is available in how many countries? And the second is name 4 modifications proposed to the conventional FRAX for addressing the limitations.
It's available in 64 countries.
Okay.
Then,
the second question.
Modifications one, if the patient is having diabetes, you can either tick for the rheumatoid arthritis or add the trabecular bone score or increase the age by 10.
That's for diabetes.
Yes,
okay.
and for decrease the T-score by
okay.
2.5.
The next.
Then difference between the
actually, I think you have exceeded the time. So one which you told is right, the modification for diabetes. Now they have suggested that for diabetes, you can just tick rheumatoid arthritis. So actually this article, when they came, they told that from 2011 itself, we have many articles telling dose modification for glucocorticoids, incorporating TBS into the fracs and everything. But what this article in archive said was that this is all arithmetic calculations. Maybe if these things are incorporated into fracs itself, we will, and so that we can get an automatic score, it will be better. But so far that haven't happened actually. Actually, fracs is available in 73 nations at present, and the modifications which they have suggested is based on that is the dose exposure to glucocorticoids. Concurrent, if data on lumbar spine is available, we can correct for that as well, because usually we enter only hip BMT. And if TBS is available, we can modify based on that. The hip axis length, that is the hip geometry. If there is a history of falls in the recent times, type 2 diabetes, immigration stature, and recency of prior fractures. So based on all this, these are not directly incorporated into the fracs, but there are arithmetic calculations which are given for this, based on which the scores can be modified. So team A gets 2.5 points. And team C also gets 2.5 points. And team B also gets 2.5. Team D also gets 2.5. So now moving on to team A.
Pancreas, ma'am.
Pancreas, diabetes. So this was an article published. This article came in Diabetes Care. So actually, the first personality who is shown in the picture is Dr. Roger Pecoraro, and the second one which is shown in the picture is Dr. Edward actually. So these two eminent personalities, actually Dr. Edward was awarded the Dr. Rogers award by ADA, American Diabetic Association, for the year 2021. He was bestowed with that award. And these two worked together in a landmark study in diabetic foot actually. So that is how they are related. Now the question is, name the landmark study in diabetic foot that was initiated by Roger and later completed by Edward after his death. Named 4 factors that predicted the occurrence of diabetic foot ulcer based on the study.
Madam, you would like to tell the factors?
Yeah, please.
The prior history of ulcer.
Okay.
History of ESRD.
Okay.
Microvascular complex retinopathy, neuropathy, history of neuropathy, and history of amputation.
Okay. So I'll give 5 points to team A. So if you have written studies for the other teams, I'm giving, otherwise I'm not. So this was the Seattle diabetic foot study, which was a prospective study in diabetic foot ulcer. In fact, these patients with diabetes without foot ulcer at the beginning of the study was prospectively followed up for 10 years. There were 24 publications from the single study. And in the study, they noted that all those risk factors which we tell for diabetic foot ulcers are actually based on this study. So that includes hyperglycemia, impaired vision, history of prior foot ulcer, history of prior amputation, loss of protective sensation, tinea pedis, and onychomycosis. So with this, we are coming to the end of round 2. So Anwar will now put up a cumulative score. Meanwhile, the question on obesity and metabolism, I will request the audience to answer this question. So we all are aware of the DIRECT study, the study which brought diabetic remission, that is reversal of diabetes. That concept came into existence after this DIRECT study. So in which they found that based on lifestyle modification, if there is a certain amount of weight loss, this can result in diabetic remission in people with early diabetes. So this top article in Diabetes Care, which came in 2022, was also based on the same thing, but here the intervention was bariatric surgery. So the question here is, what was the threshold percentage of weight loss suggested for type 2 diabetes remission following bariatric surgery among those with advanced type 2 diabetes? That means those who with a longer duration of disease and those who are on insulin. And what was the mechanism for reversal of diabetes in DIRECT trial? Anyone from the audience or anyone from the participants, if you want to answer? What was the mechanism of reversal for diabetes in DIRECT trial? You heard of the tin cycle hypothesis? So the mechanism of reversal for diabetes is the loss of fat from liver and the pancreas, so which gets deposited when there is a spillover phenomenon. So the percentage of weight loss which they suggest for remission of diabetes in those with advanced disease is at least 20% weight loss. So with this, we are coming to the end of round 2. So the cumulative scores, Anwar announced.
At the end of round 2, team A has scored 16.5 and team B has scored 27.5. Team C has scored 5 and team D 14 marks. So team B is leading currently.
So now moving on to the lighter rounds, the easier rounds. So there is no pass in this rounds, only direct questions directed to the teams because these are easier rounds. So we will start with team A first. Similar to that, the time duration is 20 seconds and each correct answer you will get 10 marks. There is no negative marking. So we will start with team A. Most of the time there won't be a clinical clue available. You should just answer the questions based on the pictures which are available. So what is the diagnosis and name 2 agents used to treat this condition?
Polycytic fibrous dysplasia.
Polycytic primary fibrous dysplasia. Anyone want to answer? There is Engelmann. What are the two name agents which are used for treating that? Yeah, so even glucocorticoids. Okay, so this is progressive diaphyseal dysplasia, also known as Camaraty-Engelmann syndrome. You can note that there is differential involvement of the diaphysis, sclerosis of the diaphysis, and which is evident in the bone scan as well. And predominantly glucocorticoids are used to treat, and the glucocorticoid sparing agents are losartan and bisphosphonates. So now moving on to team B. What is the diagnosis? Name 2 skeletal manifestations of this disease. Mike. Yeah. Anyone wants to answer? Time is over. It's meant to be. It's actually, you have the thyroid ultrasound there, in fact. So this is mucosal neuromas. In fact, this patient came to us. This is one of the patients whom I saw in my first year. I didn't diagnose this case. He was in fact referred to us for not gaining weight for a non-specific symptom. Actually, one of my teachers made the diagnosis based on that, looking at the mucosal neuromas actually. So it's meant to be. So there are many skeletal manifestations associated with this, like Marfanoid habitus, kyphosis, pectus excavatum, etc. So now moving on to team C. What is the diagnosis? what is being shown in the, I don't want what is being shown in the picture. What will you expect in the bone marrow picture there? This patient went to the hematologist for anemia actually. It's a case of, actually this patient was referred to a hematologist. The hematologist, before doing the profile, actually they didn't do a calcium, they did the complete blood count, and because she had bicytopenia actually, so they did a bone marrow and the alkaline phosphatase was elevated. That is how she was referred to us. She had primary hyperparathyroidism with bone marrow fibrosis. Now the question for team D. So so I'll give a clue here. There was history of young onset hypertension in the family. What is the diagnosis and what is the chromosome locus of the gene implicated?
Bilateral pheochromocytoma meant to.
What is the combined diagnosis? Actually, it's not pheochromocytoma actually. It's a complex cyst in the kidney with clear cell carcinoma, and there is pancreatic tumor as well. So it's von Hippel-Lindau syndrome, and the chromosome location is short arm of chromosome 3. So these are all clinical pictures and images of our own patients actually. So now we are moving on to the final round of the day. So this is rapid fire round. Again, the round is going to start with team D first. Okay. So here, each team gets to answer 6 questions and the total duration is 30 seconds. Each correct answer will give you 10 marks. There are no negative markings and there is no pass allowed. Okay. Straight away, we are going to the round. So team D first. So I'll read out, be attentive. I am going to read out, I'm not going to project the questions. So what is the color code for conventional pre-mixed insulin 50-50? If you don't know, you can tell pass.
Yellow.
Name the genetic mutation associated with pycnodysostiosis.
Pass.
What does T in East syndrome stand for? East, E-A-S-T. What is it? Aging. Okay. So these are the questions. What is the color code for conventional pre-mixed insulin 50-50? It's gray. Name the genetic mutation associated with pycnodysostiosis, cathepsin K. What does T in East syndrome stand for? It's tubulopathy, epilepsy, ataxia, sensorineural hearing loss, and tubulopathy. Aging leads to decreased thyroid requirement. It's true. In MEN2 syndrome, what is the codon mutation in red gene commonly associated with cutaneous lichen amyloidosis? It's 634. Name the drug studied in FRAME trial. It's romosozumab. So if you don't know the answer, please don't think, just say pass. So now coming to team C, your time starts now. What is the color coding for injection fiasp?
Orange.
What is the genetic mutation associated with hereditary hypophosphatemic rickets with hypercalciuria?
Pass.
What does S in visa classification for Graves ophthalmopathy stand for?
Vision.
Huh?
Vision.
Yes. Type 2 deiodinase is located in endoplasmic reticulum, true or false?
Pass.
So team C gets 1 right, so 10 marks. So what is the color coding for injection fiasp? It's red and yellow. So what is the genetic mutation associated with HHRH? It is because of the mutation in the sodium phosphate co-transporter 2C. It is SLC34A3. So S in visa classification stands for strabismus, which you got right. Type 2 dehydrogenase is located in endoplasmic reticulum is true. And the next question is expand AAP gene, aryl hydrocarbon receptor interacting protein. Name the drug studied in optimal trial. It was discussed in the previous session. Oral octreotide, octreolin. Now coming to team B. What is the color coding for conventional premixed insulin 3070?
Brown.
What is the genetic mutation associated with progressive diaphyseal dysplasia?
Pass.
What does R in WAGR syndrome stands for?
Retardation, growth retardation.
Esophageal atresia is a manifestation of carbimazole embryopathy. True or false?
True.
5 milligram prednisolone is equivalent to dash milligram of methylpred.
4 milligram.
Which drug was studied in the intervention arm in active trial?
Abaloparatide.
So you got 5 questions right, 50 points. So the only one which they missed was what is a genetic mutation associated with progressive diaphyseal dysplasia? TGF beta. So now coming to team A. Okay. What is the color coding for NPH?
Green.
What is genetic mutation associated with osteopoikilosis?
Pass.
What does C in Charge syndrome stand for?
Coloboma.
Struma ovary results in increased radioactive iodine uptake in thyroid. True or false?
True.
Expand BSCL2 gene.
Pass.
Name the drug studied in roadmap trial.
Pass.
What is the genetic mutation associated with osteopoikilosis? So you got 2 right, 20 points. So what is the color coding for NPH is green. What is the genetic mutation associated with osteopoikilosis is LEMD3. What does C in Charge syndrome stand for is coloboma. Struma ovary results in decrease. There won't be any uptake in the thyroid in struma ovary. BSCL2 gene stand for Berardinelli-Saib congenital lipodystrophy 2 gene. And this is roadmap is a diabetic nephropathy trial in which olmesartan was studied. So we will announce the winners. Meanwhile, I'll request the postgraduates here to give your feedback regarding the masterclass session. If anyone wants to share anything regarding what could be improved, anyone wants to talk. So with this, we are coming to the end of the session. Anyone wants to answer this? What is this? Yeah, it's glucagonoma and that is necrotic migratory arthritis. And what is the diagnosis? This is a 50-year-old gentleman who came with bony pains. It's Paget's disease. What are the findings you'll expect in the histopathology in a Paget's?
Mosaic pattern.
Mosaic pattern and cement lines. So with this, we are coming to the end of the quiz. So the team which came first is the team from Government Medical College, Trivandrum, Dr. Karthik and Dr. Shamir. So the team who came second is the team from KEM Mumbai, that is Dr. Rohit and Dr. And the team who came third is from MS Ramaya, Dr. Harshida and Himanshu, and the team from Trivandrum came fourth. So I would request Dr. Rakesh sir to come up to the stage to give away the prizes for the quiz. Dr. Rajesh. Come here. So the winners, after collecting the certificates, please you have to sign the voucher. So the team, the first winners are Dr. Karthik and Dr. Shamir from Government Medical College, Trivandrum. Third, no? They're third. And the second prize goes to the team from KEM Mumbai, Dr. Rohit and Dr. Manjunath. The third place goes to Dr. Harshida and Dr. Himanshu from MS Ramaya. The fourth place goes to Dr. Sandra and Dr. Ramesh from Government Medical College, Trivandrum. Thank you.
Thank you all. I hope you had a good academic feast in the last 2 days. I request you all again to please hand over your feedback forms, collect your memento and certificate, and join us for dinner at JRT Hotel, first floor. Thank you.